All right, hello everyone. Let a few more people trickle in from the breakfast area, but we do want to get started on time. We have a few introductory slides to get through before we start with our first session of the day. So first off, we want to welcome everyone. Thank you for getting up bright and early and coming to join us for the 10th annual Rocky Mountain Highlights in Gastroenterology and Hepatology. We're really excited. First to kick this off, but also because this is our first year as course co-directors. And so should probably introduce ourselves. My name is Blake Jones. I'm an assistant professor of GI and hepatology at the University of Colorado. And then I'll let my partner here introduce himself as well.
Just to echo Dr. Jones, thank you for being here. We know it's an early start, like Blake said, and there's plenty of coffee outside. I think I'm already on cup number 3 myself. So I'm Avash, Kalra, one of the transplant hepatologists here, also an assistant professor of medicine. And like Blake said, this is our first year as course directors. We're really excited to be doing this and excited you all are here. I also want to thank folks that you may have met on your way in already. Lindsay Carter, Christy Click, and Matthew McLean have been instrumental in putting this together. We'll talk more about them later when we close the conference this afternoon. But thank you to them for organizing this. They're here to help all of us today, and you can see their faces there, although Matthew has a beard, and so you may just imagine a beard on that face, and that's Matthew if you see him.
All right. And if you can, don't forget to engage with us on social media. As geriatric millennials up here had nothing to do with this, but thanks to our helpers below, we do have a hashtag RMH 2023. And if you're on Facebook, or I guess it's now called X, not Twitter anymore, feel free to tweet and engage with us.
So in terms of the format today, there are going to be 4 sessions, and you have the agenda that you can either pull up online or it's printed out in your packets as well. So 4 sessions, and then each session will be followed by a panel discussion and Q&A where the panelists, or the speakers rather, from that session will sit up here and we'll do a question and answer at that point. All of you are encouraged to ask questions during that Q&A, and hopefully that can be an interactive session for all of us. We also want to remind you, please don't forget to visit the exhibit hall. We will thank our sponsors in further detail later this morning, but they really are an important part of this conference. We're really appreciative of their support and their being here today. We'd love for you to also interact with them and talk with them about their products and their involvement. So visit the exhibit hall for a chance to win one of 10 $100 gift cards. So you have a bingo card in your packet, and they each have stars. And if you visit, I think 10 of the 8, of the exhibitors, you can be qualified for that raffle that we'll do later today. 10 people will win the $100 gift card, and we'll announce those winners at the end of the course.
Few housekeeping items. If you didn't already know, we do have free Wi-Fi here. You can see the name and then the network password and everything up there. If you did park outside, make sure to stop by the registration desk, or if you see Lindsay or Matt or Christy around, you can ask them for parking registration. And then we are providing food, as you already recognize. Breakfast happened already. There'll be lunch from 11:50 to 12:30. And then we have an awesome reception cocktail hour actually on the roof at 1:50 to 2:45.
This is information regarding CME, maintenance of certification, and nursing contact hours as well. So make sure you checked in at the registration desk that's at the top of the stairwell outside of this room to verify your attendance. Complete the online evaluation code via the QR code and link that's found in the check-in desk, but also on the website for this conference. The link is below, and that should be provided in your packet as well. The conference website has instructions regarding credit links and disclosures as well.
And so this is just more details about the credits offered. So Colorado School of Medicine, obviously accredited by the Accreditation Council for Continuing Medical Education. And if you are participating in this, you get live activity for a maximum of 5.75 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation. And then regarding ABM maintenance of certification points, if you complete the CME activity, you'll likewise get 5.75 MOC points from the ABIM and MOC program. You can read the rest of that up there.
These are the disclosures of relevant financial relationships to learners. The speakers listed here on the left side of this table will mention these disclosures during their talks later today as well.
And then again, more just about CME and MOC. You have the hashtag up, the QR code up there, and then the website as well to access the evaluation. That's where you can also claim your CME credit and MOC credit. It's available till Sunday, August 13th at 5 p.m. So you have over a week to complete it.
And then this is the nursing continuing professional development financial relationship disclosure form as well, with the same disclosures from faculty listed at the bottom of the slide. And I'll just add to, as Dr. Jones said, there's the evaluation form. We really will use the feedback that you guys give us about the meeting today to improve and hopefully enhance next year's conference as well. So we'll give that information later today.
All right, and you can either scan this QR code now for nursing contact hours or visit the registration deck to get up close and personal view. All right.
Just want to take a moment to provide some acknowledgements. So first of all, for our educational grants, the Olympus Corporation of the Americas provided educational grants for this conference today. We're extremely appreciative of that.
Again, just reiterating the chance to win one of 10 $100 gift cards through visiting the exhibitors and collecting bingo cards. And just a reminder, again, you have to be here at the end of the day when we announce the winner to actually claim the credit. Further acknowledgements for our silver level exhibitors from Castle Biosciences, Cook Medical, Exelixis, Janssen, Takeda Pharmaceutical Company, and Takeda Pharmaceutical Company, both Entyvio and Datex.
And our bronze exhibitors, AbbVie for digestive, AbbVie for hepatology, Irby USA, Intercept, Medtronic, Olympus America, Sanofi, Steris, AbbVie Pharmacology, Bristol Myers Squibb, Fujifilm Healthcare Americas, Gilead Sciences for liver disease, Microtech Endoscopy, Interscope, and Ovesco Endoscopy. We really appreciate all of your support.
All right. With that, we're going to get started with our first session of the day. So I'm going to introduce Dr. Waseem Ahmed. He's assistant professor of medicine in the GI Hepatology division. He's in our IBD section, the Crohn's and Colitis Center. He also happens to be program director of our recently developed IBD fellowship. And he's going to be talking on new and emerging therapies for inflammatory bowel disease. Welcome, Waseem.
Thank you. Do we have a laser pointer by chance? This guy? Yes, nice. Okay. All right. Well, good morning, everyone. Thanks for the speakers for having me today. I was going to just start off by saying, it's really sad to see that Twitter icon change to an X. As someone who's like really engaged on GI Twitter, it looks like a inappropriate app I just never want to click on anymore. But I'll digress. I'll be talking today about new and emerging therapies for inflammatory bowel disease. Have no relevant disclosures for today's talk. My learning objectives for today are to review the efficacy and safety of new therapies for moderate to severe IBD, to review the efficacy and safety of soon-to-be approved therapies for moderate to severe IBD. And if I have some time, I'm going to introduce some emerging novel therapies for moderate and severe IBD. Before I dive into that, this is just a nice figure kind of depicting the approval of various drugs for IBD over the past 70 years. As you can see, this is a very right-heavy figure. And we have a ton of new therapies which have been developed over the past decade, which we can offer to our patients. Now, this is a nice luxury for us to have for those of us who care for this patient population, but it also creates a lot of potential problems, including how do we position the right drug for our patient, and how do we deal with payers when we think about personalized medicine when some patients are mandated to have failed some drugs before they can even be considered for other options. So first, we'll be talking about new and upcoming therapies, and we'll do this based off of what's going on in therapies based off of their mechanism of action. And we'll start off first with JAK inhibitors. A little bit of context here, just as a reminder, JAK proteins act intracellularly through STAT proteins, and they typically act so in a dimerized fashion. When activated, they translocate into the nucleus and have effects on gene transcription. In doing so, this ultimately results in high cytokine production when activated. JAK inhibitors inhibit the activation of JAK proteins, and they do not allow for that interaction with STAT complexes. This in turn reduces gene transcription and results in inhibition of cytokine production. Now, there are 4 different JAK proteins, and as I mentioned, these typically act in a dimerized fashion. And so in doing so, when activated, they have different downstream effects, not only on the immune system, but also effects on erythropoiesis, myelopoiesis, and platelet production as well. And so for the purposes of IBD, you can imagine it's most important to activate a specific JAK complex that potentially will then mediate inflammatory properties. So first, we'll talk about upadacitinib for Crohn's disease. Now, most of us are aware of tofacitinib, which is a pan-JAK inhibitor, which has been approved already for ulcerative colitis for a number of years. Upadacitinib is a JAK1 selective inhibitor, which was originally approved for ulcerative colitis a little bit over a year ago, but more recently for Crohn's disease just over a month ago in late May. And this is actually our first new advanced therapy for Crohn's disease, which is a once-a-day pill, which is pretty exciting. This is a schematic of the phase 3 clinical trials program for upadacitinib for Crohn's disease. This consisted of 2 induction studies where patients were randomized to upadacitinib versus placebo. Patients who were responders to the drug or placebo were subsequently re-randomized to the maintenance arm of the study, where they were then dosed different doses of upadacitinib maintenance versus placebo. What were the outcomes of this study? Now, when you look at outcomes in clinical trials, particularly for IBD, it's important to not only appreciate the response and remission rates, but you have to do so in the context of the placebo arm. IBD trials classically always have very high placebo response rates. And that's a whole separate talk to itself. And so the importance here is not what the percentage of response is, but what is that difference relative to patients who are dosed placebo, or specifically kind of what I will refer to as the delta. With upadacitinib, for patients in the induction arm, you can see that there are significantly higher rates of response and remission in patients on therapy relative to placebo. One of the other important caveats to IBD clinical trials is how do you think about patients who've previously failed other therapies? And so no matter what patient you are seeing, if they've been exposed to 1 or 2 drugs, the likelihood that a 3rd or 4th agent is going to work is always going to be lower. So if you've previously been exposed to a biologic, your chances for success with the next drug are always lower. However, the hope is that that rate relative to placebo will still be maintained. And importantly, with upadacitinib, we see that where the efficacy rates do decrease in patients exposed to biologics on the right side of these figures, but that delta remains preserved at about 20 to 25%. Looking at the maintenance arm of these trials in the bottom portion of this slide, you can see a similar effect. And one of the interesting things to note is that patients on a higher dose of upadacitinib at 30 milligrams seem to have a delta of roughly 10% over patients on 15 milligrams daily. And so typically in our practice, in patients, particularly those with more severe disease who've been exposed to advanced therapies in the past, they're sticking on 30 milligrams maintenance dosing moving forward. Some of the just intriguing caveats to this study, which I think are important to take note of. So as most of us are aware, JAK inhibitors do have the potential to have rapidly effects in terms of clinical improvement in our patients. It's previously been demonstrated that a significant proportion of patients who receive upadacitinib for ulcerative colitis can have a clinical response within 1 day, which is pretty darn amazing. What about Crohn's disease, which is a totally different transmural beast? This is a post-hoc analysis from the phase 3 clinical trial program, which suggested that even within a week, a significant proportion of patients can achieve clinical response or even symptomatic remission. One of the other intriguing things from this trial is the thought that perhaps we can actually start treating perianal fistulizing Crohn's disease with upadacitinib as well too, which is a very complex process and which is very hard to treat for our patients in general. This is also a post-hoc subgroup analysis looking at patients who had perianal fistulizing disease in this clinical trial program who were treated with upadacitinib. As you can see, small numbers. This is a post-hoc analysis. The study was not powered to assess these patients, or specific outcomes were not designed to look at perianal fistulas. But regardless, in this small fraction of patients who received induction upadacitinib relative to placebo, you see significantly higher rates of fistula closure, resolution of drainage, and resolution of perianal fissures. What about safety data for upadacitinib? Reassuringly, there do not seem to be significantly higher rates of adverse events, serious adverse events, infections, or malignancy relative to patients on placebo. Some of the numerically higher rates that we do see here in terms of adverse events relative to patients on placebo include rates of zoster infection or shingles, cellular abnormalities, CK elevation, and LFT abnormalities. And so typically we are monitoring these in this patient population as well. I will mention one of the things that we do not see here listed, but we probably most commonly see as an adverse effect in our practice is symptomatic acne in patients, particularly on those who get the induction dosing. This typically gets better on the maintenance dosing in my practice that I've seen so far. Now we'll talk about IL-23 antagonists and what's going on in this space. So there are several different IL-23 antagonists which are currently in the IBD pipeline. Several of these therapies already have received approval for other immune-mediated conditions, particularly in the arthritic and rheumatologic space. More recently, we've had risankizumab, which has been approved for Crohn's disease a little over a year. And probably in the next few days to weeks, we'll actually see the approval of mirikizumab for ulcerative colitis as well. Now, these therapies are selective IL-23 antagonists, which is different than the IL-12/23 antagonists, which many of us are familiar with, ustekinumab. They offer only selective IL-23 antagonism. And why is this important? Well, in this family of cytokines, it appears that IL-23 actually is the driver of inflammation. And the hope is that by selectively antagonizing this pathway, it will have additive effects for our patients. And we've actually seen this in the dermatologic space, where IL-23 selective agents appear to be superior than ustekinumab. So first, we'll talk about mirikizumab for ulcerative colitis. This is a schematic of the phase 3 clinical trial program, which was recently published. This consisted of one induction study, the LUCENT-1 study, where patients were randomized to mirikizumab versus placebo. Responders, again, were then re-randomized to receiving maintenance mirikizumab versus placebo in the maintenance arm. So how did this drug look? Well, it appears to be very promising, and I anticipate it's going to be approved very soon for ulcerative colitis. As we can see, in the induction arms, there were significantly higher rates of remission and response in patients who received the therapy over placebo. And again, one thing I want to point out is you see this delta of roughly 20% in patients, and that is maintained in patients who have previously been exposed to advanced therapies. How quickly does this agent work? Well, fortunately, it seems to be fairly fast, probably not as fast as a small molecule we just discussed and one we're going to talk about shortly. But you do see a significant increase in terms of rate of symptomatic remission, often within 4 weeks in patients on this therapy. What about safety data? This is a very safe mechanism of action when antagonized, similar to ustekinumab, with a safety profile similar to placebo. Really no significantly higher rates of adverse events, serious adverse events, or infections relative to placebo. Some of the things that we do see at a numerically higher rate are nasopharyngitis and headaches, which we typically see with all of our IBD therapies. And while the rates are very low, just to point out, there are a higher rate of patients having sensitivity reactions to the drug itself relative to placebo too. Next, we'll talk about S1P receptor modulators. So a little bit of context, this can be a little confusing, I find. I always have to review it again. The majority of our lymphocytes are not just circulating in our blood or activated. The majority of them are sequestered in our lymph nodes. The way that they are activated is by a gradient, which is established by sphingolipids, or S1P. S1P classically binds to S1P receptor modulators on certain lymphocytes, and when doing so, basically hones them to inflamed tissues where they have effects. S1P receptor modulators are a class of therapies that bind to the S1P receptor. When they do that, they internalize the receptor and they prevent basically the egress of lymphocytes from lymph nodes, which has resultant anti-inflammatory effects. Now, there are several different S1P receptor modulators. These are expressed in different concentrations in different cell types. And when activated, they have different downstream effects, often on immune-mediated function, but also things such as development of the cardiovascular and nervous system, and also on maintenance of the endothelial barrier. Now, ozanimod is an S1P receptor modulator we've had available for a couple of years for the treatment of ulcerative colitis, which was originally developed for multiple sclerosis. That is an S1P receptor modulator specifically of S1P1 and S1P5. We're going to next talk about etrasimod, which is an S1P receptor modulator of S1P1, 4, and 5, with the hope that by modulating S1P4, it will have additive immune-mediated effects. This is a schematic of the phase 3 clinical trial program for etrasimod for ulcerative colitis. This consisted of 2 studies, one induction trial, the Elevate UC12 trial, which was an induction-only study of patients receiving etrasimod versus placebo. The other study was the Elevate UC52 trial, which consisted of patients randomized to etrasimod versus placebo. A little bit different than the other trials I mentioned. This was a treat-through design trial where patients were not re-randomized to the drug or placebo in the maintenance arm. So if you were assigned a therapy, you stuck through it the entire time. How did this drug pan out? So this was actually a publication not too long ago, this past spring in Lancet. But similar to other therapies, we see a significantly higher rate of response and remission in the relevant primary and secondary outcomes with this drug relative to placebo, with a delta of roughly 20%. How quickly does it act? Well, it is a small molecule, and typically these act a little bit quicker, but it has been demonstrated that often patients have a significantly higher rate of symptomatic remission, often within 2 weeks. Now, one of the unique features of this study, which I wanted to briefly comment on, was that this clinical trial program actually allowed patients who had isolated proctitis to enroll in it. Now, this subcohort, this patient population, has classically been excluded from clinical trials for whatever reason, but they were allowed to be enrolled in this study. Small numbers, this was a subgroup analysis of this patient population, but it's nice to demonstrate that actually patients with isolated proctitis do respond to advanced therapies. This is a unique aspect of this clinical trial program, and it's something we hope to see in the future. It's very hard to sell patients who have isolated proctitis that they may need to be on injectables or IV therapies for the rest of their life. And so, the potential of a therapy as a once-a-day pill as a successful therapy for that is intriguing and exciting. Safety data for etrasimod also seems to be fairly reassuring. This is actually a pooled cohort from the phase 2 and the phase 3 clinical trial program. No higher rates of adverse events, serious adverse events, infections, cardiovascular problems, macular edema relative to placebo. Potentially the one numerically higher thing that was noted was a slightly numerically higher rate of LFT abnormalities in patients receiving the drug. What's going on in the naturopathic space? I wanted to devote a little bit of time to CUR-QD for ulcerative colitis. This is something that patients are messaging us about constantly, and so I wanted to focus a little bit of time on it. Some background information. Curcumin is an active compound of turmeric, which has known anti-inflammatory and antioxidant effects. It has already previously been shown to be effective in inducing and maintaining remission in UC when used in combination with mesalamine. Indigo, or qingdai, is a pigment compound extracted from plants, which has classically been used in Eastern medicine for hundreds of years. and has been studied as a treatment option for IBD. It acts on the aryl hydrocarbon receptor pathway, which is involved in intestinal inflammation and mucosal integrity. And so there is a major IBD center out of Israel, which has kind of brought this compound to market. And they have previously shown in a retrospective observational study that it can be effective to induce a clinical response and remission in patients with ulcerative colitis. And subsequently, they have actually published just recently a randomized controlled trial. This was a two-part study. The first was more a proof of concept open label study. The second was a placebo-controlled randomized controlled trial in which patients were randomized to receive KIRK-QD or placebo for 8 weeks. Patients who responded to their therapies were then continued on curcumin or placebo alone for 8 additional weeks. The co-primary outcome of this study at week 8 were rates of clinical response and objective response, which is defined as a decrease in the Mayo endoscopic score or 50% fecal calprotectin reduction. Now in part 2, which I'm going to focus on, you can see a small trial, 42 patients in total who are randomized. But interestingly, already 50% of these patients had previously failed a biologic or an immunomodulator. Over a third of patients had previously failed a biologic. How did it pan out? Well, as you can see in terms of the co-primary outcome, rates of clinical remission, clinical response, even endoscopic improvement, you see a high rate of response and remission on patients receiving the drug relative to placebo. Now, in patients who received KIRK-QD who were responders and then were transitioned to curcumin, at week 16, 93% of them maintained a clinical response. So pretty impressive results for a naturopathic compound. How quickly does it work? Well, in the publication, the authors demonstrated that within 2 weeks, the majority of patients had a symptomatic-free clinical remission or relevant decrease in their rectal bleeding subscore. And the safety data for the compound appeared fairly reassuring. Small numbers again, you do see numerically higher rates of headaches and LFT abnormalities in patients who receive this drug. Now, before they start adding this to our water supply, it is important to note that there are several large retrospective observational studies looking at long-term use of Qing dye, particularly in the Asian literature. And it has been shown in a very rare population of patients that there is potentially a rate of pulmonary hypertension with long-term use of Qing dye formulation. That has not been seen in this study. The center which is releasing this has not seen this in their specific formulation of the compound that they use. And they concluded that a combination of KIRK-QD is effective for inducing remission in active UC with a rate of adverse events comparable between patients receiving placebo. How do patients actually get this? So as I mentioned, this is a specific center in Israel, which is launching this drug. They have a direct-to-consumer proprietary website, as you can see down here. Patients essentially log into the site. Patients who have a diagnosis of ulcerative colitis, they input their symptoms and they are graded as having severe, moderate, mild disease, or potentially being in remission. Based off of their disease activity, they are then specifically given a 6-week regimen of this therapy, or 45 days in total, which consists of various 2-week regimens of KIRK-QD. These different regimens consist of different concentrations of curcumin relative to Qing dye. Now, Qing dye is thought to act primarily as the induction agent for this compound, whereas curcumin is the maintenance arm. And the assumption is, and the hope is, that if patients they are then transitioned to a compound which is more curcumin predominant, which will hopefully keep them in remission. And this is given the concern for the long-term effects of Qing dye use. Very quickly, I think I got a couple minutes. I'm going to touch base on what I think are interesting and intriguing novel emerging pathways for therapy in IBD. I wanted to briefly touch base on TL1A. TL1A stands for TNF-like ligand 1A, which is a member of the TNF superfamily. It's expressed on several different inflammatory cells. And interestingly, mouse models have shown that when TL1A is activated, it can not only have pro-inflammatory, but pro-fibrotic effects as well. And so TL1A antibodies are potentially the first IBD therapies that not only target inflammation, but fibrosis as well. TL1A antibodies are being studied both for ulcerative colitis and Crohn's disease and are in phase 3 programs currently for both indications. This is one of these antibodies which is being investigated by Prometheus, and this is their data from their phase 2 study, which shows that in patients receiving the drug, there are much higher rates of remission and response relative to patients receiving placebo. Interestingly, in the Crohn's disease study, which was also positive, I just wanted to focus that the investigators were able to show that in diseased tissue, in patients who had the active Crohn's disease who received this drug, their fibrotic signature actually decreased after receiving the therapy, and furthermore, as did their percentage of activated fibroblasts in their diseased tissue. So pretty cool to see that potentially we have a novel therapy that will not only target inflammation, but also potentially fibrosis too. And lastly, I wanted to touch base on obefacimod for ulcerative colitis. This is also a novel compound in the small molecule space. This compound was actually originally designed as an antiviral therapy to treat HIV. Obefacimod actually binds within the nucleus to cap binding complexes. In doing so, it increases the splicing of certain types of RNA to increase the release of microRNAs. When these microRNAs are increasingly expressed, they actually inhibit the translation of certain types of cytokines and chemokines, and this has downstream anti-inflammatory effects. When you inhibit the translation of these inflammatory molecules, you see decreases in terms of macrophage recruitment and activation, and this in turn can modulate our T cell system. This is data from the phase 2 clinical trial for obefacimod for ulcerative colitis. This compound is already in phase 3 programs. We're actually hoping to be in that clinical trial here at our center. And this is data from the phase 2 study, which showed that the primary outcome, which was week 8 decrease in the modified Mayo score, all patients on various dosages of this drug had a relevant response relative to placebo. So my conclusions for today: upadacitinib is an effective induction and maintenance therapy for Crohn's disease in both biologic naive and experienced patients. Mirikizumab is an effective induction and maintenance therapy for moderate to severe ulcerative colitis in both biologic naive and experienced patients. Etrasimod is an effective induction and maintenance therapy for moderate to severe IBD. CurQD may be a promising therapy for moderate to severe ulcerative colitis, and real-world data will be critical to further evaluate its efficacy and safety. And finally, anti-TL1A therapies and obefacimod are potentially effective therapies for both ulcerative colitis and Crohn's with novel mechanisms of action. Their phase 3 clinical trial programs are ongoing. Thanks for your time. Question?
All right. Thank you, Dr. Ahmed, for that fantastic talk. Up next, we have Dr. Nipun Reddy, an associate professor of medicine in the Division of GI and Hepatology here at the University of Colorado, who will be giving his talk on updates and future actions in eosinophilic gastrointestinal disorders. And just remember, save your questions for the end, either write them down or memorize them, and we will have an opportunity during the panel discussion for each of our speakers to answer them.
Good morning, everyone. Can you guys hear me? My topic was updates in the treatment of eosinophilic gastrointestinal disorders and future directions. Whenever giving talks at these sort of types of things, I try to straddle the line between being descriptive and talking about what medicines can work. And so hopefully I did that for you guys here. Here's a typical outline. I'll talk about just basic definitions, talk about endoscopic images of what you see there, and then we'll kind of get into the crux of the talks about management and then sort of future directions. So quickly, just for eosinophilic gastrointestinal disorders, or abbreviations EGIDS, it basically defines a chronic immune-mediated disorder characterized by a histological increase of eosinophil predominant tissue inflammation, and then clinically by gastrointestinal symptoms. There's sort of 3 types, or 4 if you include eosinophilic enteritis. The most common one that everyone really knows about is sort of EOE, or eosinophilic esophagitis. Less common is eosinophilic gastritis, my 10-year career as an academic GI, I probably have a handful of cases, maybe 5, and I've yet to see a case of eosinophilic colitis, so very rare in the literature. And so kind of thinking about associations with allergic disorders, typically our EOE can be seen with asthma, eczema, and then going down is less common with eosinophilic gastritis, and then not really associated with eosinophilic colitis. Sort of the allergic phenotype when you sort of have these sort of disorders for EOE is typically an IgE mediated response followed by a T cell. For EOG and EON is IgE, and then EOC is just a T cell response. The key thing to remember is I always get asked these questions, you can have peripheral blood eosinophilia associated with these diseases, but it's not always present. If you do have it, though, it can be a way to sort of mark sort of progress with treatment. So just talking about eosinophilic esophagitis real quickly. Typical people will complain of some heartburn, chest pain, a lot of dysphagia, food impaction or weight loss. Endoscopic features, you can have edema, linear furrowing, mucosal rings. We have this score that we actually use. It's called the EOE endoscopic reference score, which I'll go over in a second. Key thing is this diagnostic criteria, which is greater than 15 EOs per higher power field. One thing to know, this is sort of been an updated. We used to sort of have a diagnosis of PPI or GERD-related EOE in a sense, and that's sort of in the past we used to sort of have separate distal and mid, so we can kind of separate those two disease processes. Now we sort of all kind of lump them one together, so you don't necessarily need to sort of separate anymore. So this is sort of our when we're doing scopes of kind of what we're seeing. The key thing to look at is just sort of this is sort of what we worry about with people with EOE, kind of this trachelization of the esophagus. Seeing exudates can be problematic as well, and there's linear furrows. This sort of helps just grade sort of what people are initially, and then when you do a repeat endoscopy, it can allow you to see if there's any improvement. Usually when the biopsies, when you see this, you typically see eosinophilic inflammation. And the key thing is this immunostaining for this MCP. This ECP is just basically what the eosinophils, the catatonic protein that we kind of see on staining that sort of makes the presence that eosinophils are there. Key thing with EOE, you want to look at for any type of differential diagnosis. And then sort of once you rule those out, typically, you have your sort of diagnosis there. And the key thing with EOE, without any treatment, what you worry about is eventually you can get stenosis, some bleeding and then potentially perforation. For eosinophilic gastritis, so the key thing is looking at where you actually have the damage. If you have it in the mucosal form, you typically just have vomiting, abdominal pain, maybe some malabsorption. If you get in the muscularis, that's where you kind of get more obstructive patterns. And if you get into the serosal form, you actually get this eosinophil-rich ascites. Interesting that there's this endoscopic reference, gastritis reference that the group at UPenn came up with, which I didn't really know existed. And so it was kind of interesting to see like the sort of evolution of sort of this disease pattern. Key thing for here, and this is sort of very important, is actually you want to get targeted biopsies of both normal and abnormal appearing mucosa. You want large number of sample, 8 biopsies there. And the key thing is this number right here. And the reason this is important is, I've had pathologists just comment that their eosinophils present. Well, that doesn't really help us. So we sort of need to know a number because you can have eosinophils present and it doesn't necessarily mean anything. So you need this high power number. So this 30 EOs in high power field in greater than 5 spots, or 70 and if you have just 3 spots. And you can see how these are pretty high numbers, much higher than what you see in the esophagus. And so this is sort of what the group at UPenn came up with, and sort of how you sort of look at with a reference guide to eosinophilic gastritis. And these are sort of the pictures. You can see how you can get pretty, you can have erosion initially against the superficial ulceration, then you can get these deep ulcerations here. You can have some granularity here. And then you have some of these raised lesions here. It kind of makes you pretty suspicious for eosinophilic gastritis. Then the erythema can also be sort of pretty distinct. And then this thickened fold, this is sort of good examples of what thickened folds are. And this friability. So basically, anytime you touch the mucosa, you can have sort of spontaneous bleeding. Same thing with sort of EOE in a sense, you kind of get this eosinophilic inflammation. Key thing is you get blunt villi, which is sort of something you see with celiac disease, but then you wouldn't necessarily have this eosinophilic inflammation. Key thing here is also, ruling out other stuff. There are a lot of times you can get these sort of vasculitis disease, systemic mastocytosis can sort of present like this, and then an infection. So a lot of parasites can give you EOs in the biopsy, so you can have to sort of rule that out. And then drug reaction is something to think about. Eosinophilic colitis, just real quickly, again, really rare. I've never seen a case. Abdominal pain, typically diarrhea. They can have endoscopic features, some erythema, some loss of vascularity, some lymphonodular hyperplasia. Again, this is very non-specific stuff. You kind of see this in a lot of stuff. So again, what's difficult to see. And here is, basically the kicker here is like having very high numbers of EOs in the biopsy to try and get this diagnosis. Histological features, you kind of see a lot of crypt abscesses, the cryptitis. So there is some speculation that maybe this is sort of a kind of a step cousin to IBD in a sense, because there is some sort of overlap with what we see here. So that's why we wanted sort of rule out Crohn's disease. This hypereosinophilic syndrome is sort of kind of what you can sort of get some of these findings with this disease, and there's certain drugs that sort of help sort of diagnose that. So that's one thing you have to sort of evaluate. So here we're going to just talk about management, and we'll talk about diet modification, which is sort of like the big sort of unique thing I found out here in Colorado compared to where I trained at in Alabama. So which I'll touch on in a second. The main standard therapy is still steroids, endoscopic therapy, and then we'll sort of talk about emerging therapy, which, spoiler alert, I was sort of surprised. We haven't really made much progress since some of the drugs I've heard about 5 years ago. But anyways, so for EOE and diet modification, this is interesting. So this acronym IMPACTS, this is typically what we use for kids, but it's sort of something that makes sense. For a lot of my patients, it's a lifestyle change. You have to sort of get them to sort of think about, take smaller bites, chew slowly, try to turn away pills. So it's something to sort of kind of get in the mind of when talking with your patients about just eating, not necessarily avoiding food. This is more just eating. The key thing here is the 6 food elimination diet, which has kind of been studied for many years. And then initially, using the 6 food, just starting with that became pretty tedious in a sense, because you would avoid the six common foods associated with EOE, which would be milk, wheat, egg, soy, and shellfish and nuts. And then you do that for 6 weeks. Then you would you start from the least allergic in the food group, the least one that's commonly seen with EOE, which would be shellfish. Then you would eliminate that food. Then go about then you would go to 6 to 8 weeks, do an endoscopy, check to see if there was a decrease in EOs, and you can see how tedious that became. And so there's a group in Spain came up with this step-up approach, which is sort of what my colleagues here at Colorado do, which is you start with the 2 most common foods associated with EOE, which would be milk and wheat. And then you do this for about 6 to 8 weeks. And then if the count is high and repeat endoscopy, then you would step up to 4. So do milk, wheat, eggs, and soy. And if the count is high again, then you step up to 6. This method has been shown to reduce the number of endoscopies needed to sort of pinpoint what food is a trigger. And once you sort of identify that, then that's sort of the kicker there. The interesting thing about regional differences in Alabama, no one ever responded to a 6 food elimination diet in my 10-year career there. And one thing I thought was maybe just patients in Alabama love their food and didn't want to eliminate stuff. But it was interesting in Colorado, like there was a great success of this, because typically we see this success in kids, but now there's data out in Colorado and out west where patients, who are highly motivated can respond to this diet. I just didn't believe it because I just, in Alabama, it just never seemed to work. So I was just surprised to see how prominent it was here. That was something kind of interesting to understand about regional treatments of certain diseases. Medications. So proton pump inhibitors have been sort of associated with as an effective treatment for EOE. This sort of kind of comes from this PPI responsive esophageal eosinophilia. This is sort of initially was sort of like you had to like rule us out before someone could have EOE. So now we sort of think we sort of lump this in with EOE. Typically, people who have this, in my experience, have an endoscopic appearance that's not sort of classic for EOE. They're not going to have like the rings. They're not going to have like linear. They have maybe mild linear furs. They're not going to have like big strictures in a sense. So I feel like this is sort of like a mild variant in my experience, and so that's why I feel like the PPI tends to work with this group in particular. People with severe EOE or prominent endoscopic findings, this may not be a good medicine to start with because they may be too far along to see effectiveness with the PPI. The mainstay sort of treatment is steroids, which is interesting. There is actually not an FDA approved drug for EOE. There is one in Europe, but not in America. And so, of course, being savvy clinicians, we've come up with ways to sort of get our patients to take medicines, which is sort of unfortunate that we have to sort of educate them how to take them, and there's not a simple way to do it. But the most success that I've had is with the fluticasone, which is a 220 microgram spray. The key thing is you have to sort of do it without the spacer. So you kind of have to write that in, get the pharmacist to understand what you're talking about. Then you spray in the mouth, you have them swallow. You don't drink for 30 minutes after administration. Treatment range is about 4 to 8 weeks. Then you want to sort of do endoscopy to kind of assess endoscopic and histologic improvement. The key thing is that, sometimes they'll need maintenance therapy. Typically, this is people who sort of have, who relapse, or who have, bad strictures. And so so unfortunately, you may have to have them on some sort of long-term steroids. And then budesonide also works really well. But as you can see, since we don't have an orally deliverable to the esophagus medicine in the US, we have to come up with this sort of little combination here where we're sort of mixing the budesonide into Splenda and have them take that. And then again, this works really well as good as fluticasone. I don't actually use budesonide as much. I tend to use fluticasone. But again, it's very much the outcomes are about pretty even on response rate. And then prednisone, again, has shown some benefit, but the key is that the side effects of the chronic use of prednisone outweigh any benefit. So typically it's really not used at all. So going into newer medications, so this is probably the big one, dupilumab, which just got approved in 2022. It's an IL-4 receptor alpha antagonist, mainly used in asthma patients. Basically, it sort of blocks the proliferation of eosinophils in a sense. It's mainly used in non-responders. So the key thing is like, will this sort of jump to be used in as first line? There's some debate right now. Like I think I just read an article yesterday that there's some push to maybe have this up there with diet and steroids and even PPI in a sense. But right now, most of my colleagues and I called just a bunch of people out east and here to see what their sort of success rate is, and they tend to mainly use it for non-responders. The key thing is it's 300 milligrams weekly. So from a compliance perspective, because one of the biggest issues I have with my patients is that, they may not want to take their fluticasone because it is daily, it's twice a day. There's some side effects with fluticasone. You can get candidiasis. If you have patients and typically EOE patients can be, they're young males who are notoriously bad at responding to treatment, staying on treatment course. This could be a good medicine to use because it's only weekly. And the nice thing to see is that if you have an EOE patient that has other atopic conditions, asthma, eczema, this could be a great medicine for it, because it you kind of get a more targeted response. And that's sort of kind of what the future is sort of leaning towards, is sort of looking at the sort of the genetic makeup of the patient who has EOE, and kind of what sort of like and what other systemic diseases they have, as a sort of a way to sort of triage them and what to treat first. So this has sort of been like a game changer in the area right now. So there's some limited data for Montelukast, and I've seen some case reports. Talking to some of my mentors who in the past had some success with this, but again, it's still not something we sort of routinely use. Azathioprine, there's been some case reports with histological remission, but again, azathioprine comes with drug monitoring, so it's not necessarily ideal. And then infliximab, interestingly, has some case series on what you can use to sort of treat this. So emerging therapy and sort of future direction in a sense. So I kind of thought like there would be a lot of new drugs out there, and but interestingly enough, there actually hasn't been much advancement in a sense. This monoclonal antibody against IL-13 is called sintilimab. Initial study showed improvement in eosinophilic count, but then no improvement in dysphagia. The one caveat is that some of the authors thought maybe the study wasn't powered enough to sort of capture this true as a true evaluation of improvement or not improvement. But currently, this drug is in a phase 3 trial right now, so maybe we'll get more data on if this is going to be successful. Mepolizumab is a monoclonal antibody against IL-5. Again, this has showed improvement in eosinophil count, but then again, there's no symptom. The symptom score was no different than placebo, so there's sort of like a want of like of a drug where they thought this would be great, but then when we kind of got this back, they're like, we're back to the drawing board in a sense. Rezlizumab is an IL-5 neutralizing antibody. Again, this also improved in the eosinophil count. Then again, there's symptom score was no different. So sort of like, again, like, well, why is this occurring? And so now there's some debate is that maybe improving this eosinophil count is not the end all be all that we think it is, that there's something else that we have to do in order to sort of improve outcomes. And then benralizumab, which is a monoclonal antibody against IL-5 receptor, alpha receptor. This also again had improvement in eosinophil count. There is an ongoing study right now on showing that maybe this could potentially have both the improvement in eosinophil count and improvement in symptoms. Again, it didn't seem like this was something that was ready for prime time. So again, it was sort of a little disappointing. I thought sort of there'd be more out there, because a lot of these drugs I remember just sort of hearing about 4 or 5 years ago at DDW, and we're still in the same spot. There were other studies ongoing that were a little bit too basic sciencey for me, so that's why I didn't print them in here. So that's why. But these are sort of the ones that I could see that maybe there could be something potentially down the line, but who knows? Again, just sort of kind of going endoscopic treatment for eosinophilic esophagitis. Typically, we sort of do it after a trial of dietary modification or topical steroids. You want to dilate strictures that are less than 15 millimeters. That's sort of the diameter what I'm talking about. You want to use your Savary dilations, which is a guided bougie that kind of goes down. Again, you have to sort of be careful when dilating people with EOE, because they can get significant chest pain afterwards. So typically, I don't think I even do 3. I tend to do 2 at the most, because when you look back down there, you can see big rents or big dilation effects in the esophagus, which sometimes can scare you a little bit. So that's why you don't want to do too much at once. Combo therapy is kind of interesting. Like, some authors say that you can use PPI with topical steroids. Some authors say you shouldn't do combo therapy at all, because then you don't know what's working. Again, this sort of doing topical steroids and an elimination diet together, they're saying that necessarily doesn't add much benefit. And then sort of treatment response, just quickly looking at basically you want to see a symptom response, so no dysphagia, You want to see the histological response, so less than 15 EOs, and then endoscopic response therapy. You sort of want that less than 2. Quickly talk about eosinophilic esophagitis, gastritis, and colitis. Elimination diet is this sort of the mainstay. I actually had one patient recently who I diagnosed with EOE with eosinophilic gastritis. They actually responded to the 6-food elimination diet. And so this is why typically this is favored over step up elimination. You kind of want to monitor for peripheral if present. And then you have to sort of check endoscopy for histological improvement. Again, there's some data out there with the elemental diet, basically, which is a diet consists of lipid formula, which sort of you basically break down anything you eat to the most elemental form. There's actually one study where they had like 10 patients and they've been on this diet for 6 weeks and had 100% histological response. Again, compliance with this would be pretty hard, so I'm not sure if that's something that is really ready. And the interesting thing is, people always ask me about allergy testing, even for EOE and for eosinophilic gastritis. Allergy testing, in my opinion, plays no role. So like, there's nothing really to do there. Quickly with medications, steroids tend to be the mainstay for this. Topical steroids don't work really well. You have to sort of taper pretty quickly. Then you can keep on low dose if needed. Cromolyn, I actually had a couple patients on this. It does work pretty well. So that's something I've done in the past. And then this is sort of old data, but you can use montelukast. Basically, these are people who are steroid dependent eosinophilic gastritis. You can't get them off steroids. This tends to work well. A lot of my colleagues in Alabama have used this. Emerging therapy for eosinophilic gastritis. So dupilumab is something they're thinking that could work. This drug right here, this lirentelimab, is interesting because there's a lot of news case studies showing that there could be improvement for both EOE and EOG. We're just not necessarily sure. Again, with for mepolizumab and benralizumab, and no real improvement here. And then vedolizumab, interesting. There's some case reports, so maybe we'll get something there. And then this one, we thought this would be a good drug, but again, there was no histological improvement with when looking at a follow-up after being on the medicine. So again, not necessarily ready for approach. Quickly, what do I do? Typically with eosinophilic esophagitis, you can typically start with a PPI or elimination diet, depending on severity of symptoms and severity of endoscopy score. I typically use fluticasone if I'm going to use a steroid. And then if that doesn't work, I'll probably start using the step up elimination diet if I didn't use elimination diet to begin with, and then jump to dupilumab if that is unsuccessful, and then dilation if no real approach. And then for eosinophilic gastritis and enteritis, I tend to use 6-food elimination diet, steroids, and I've had success with Cromolyn, so that's sort of my approach. And these are my references. So, sorry, I went a little bit late, so I apologize for that.
Right. Thank you so much, Dr. Reddy. We're going to close out session 1 with an excellent talk, something that we all get always excited about, from Dr. Amitha Prasad Gumidyala, one of our psychologists at the University of Colorado Department of GI.
Thank you first to our organizers for inviting me to talk here today. I appreciate being able to be here. And I am very happy to talk about best practices in psychogastroenterology today. And I'm going to talk a little bit more specifically about cognitive behavioral therapy and gut-directed hypnotherapy. I have no disclosures. I really want to, for this talk, just sort of review the importance of and some empirical support of psychological interventions, primarily with disorders of gut-brain interactions or functional GI disorders. And then again, I do want to talk about cognitive behavioral therapy and gut-directed hypnotherapy. So first, I'll start off by just talking a little bit about why psychological interventions can even be considered in DGBIs. And really, what we know is that chronic GI disorders are highly prevalent and pretty costly for the healthcare system. It's frequently associated with lower quality of life and more doctor's visits. And there's also often a discord between GI symptom alleviation using medications or other medical interventions and improvements in quality of life. There is also a large body of literature documenting the association between a range of psychological factors, so things like stress, anxiety, depression, trauma histories, somatization, all of those things. And there's an association with those factors and symptom severity, poor outcomes, and quality of life impairments with patients who have DGBIs. And so with this growing recognition that psychological factors can impact symptoms, there's been a greater interest in using psychological interventions to address DGBIs. And really, typically what we see in the literature is that patients who engage in psychological interventions tend to have fewer subsequent medical procedures, as well as improvements in psychological status and quality of life as well. So in order to understand why psychological therapies can be useful, we of course have to talk about the brain-gut axis. And as I'm sure you all know, it's a complex two-way communication pathway between the central nervous system and the enteric nervous system. And this interaction occurs through neural, endocrine, and immune signaling. And so basically the CNS is not only perceiving what is happening in the gut, but it's also sending messages back down to the gut to maintain homeostasis and fine-tune the processes in the gut. And these brain-gut interactions essentially links the emotional and cognitive centers of the brain with these peripheral intestinal processes. So things like visceral sensation, permeability, gut motility, inflammation, all of those things. But when there is disruption in that communication due to things like stress, for instance, the brain can misperceive sensations from the gut more strongly and start sending down inappropriate signals to the gut that can also disturb intestinal functioning in all of these ways here. So given this evidence that dysfunction of the brain-gut axis plays such a big role in so many GI disorders, it makes sense that targeted psychological interventions can be a very logical approach with the goal of restoring some of that normal communication between the brain and the gut. So these psychological treatments that I'm talking about, you can consider them as brain-gut behavioral therapies. And these brain-gut behavioral therapies, or BGBTs, are clinician-administered, short-term, non-pharmacological interventions. They're really just focused on improving GI symptoms and GI quality of life. These target these specific cognitive, emotional, and behavioral mediators associated with dysregulation. And really, these therapies come from pretty highly effective behavioral therapies that are used to treat a wide range of medical and mental health conditions like depression, anxiety, chronic pain, and so on. And you can really think about two primary pathways for behavioral modification, which in turn can lead to GI symptom reduction as well. So the first one is modifying dysregulated ascending gut to brain pathways. And here we're just leveraging established behavioral techniques, really focused on reinterpreting those gut sensations that trigger more of the maladaptive and unhelpful cognitive and affective processes. So here you can use interventions like relaxation exercises or exposure strategies to decrease fear and avoidance behaviors. And again, really you're kind of targeting things like abdominal pain or visceral hypersensitivity or GI motility. And then the other pathway is focusing on techniques that modify dysregulated descending brain to gut pathways, in which GI symptoms really occur in response to cognitive and affective triggers. And this might come up from things like fear of symptoms or other environmental stressors. So here the goal might be using interventions to help modify those thought errors, improve coping, resilience, and some other self-manage or self-regulation skills. So there have been a lot of different psychological treatments that have been evaluated. And these really are the ones that have been tested pretty well and really show some promise in improving GI symptoms in multiple randomized control trials. And as you can see, a lot of them actually have some overlap or similar targets as a part of their interventions here. And there really isn't any clear evidence that any one type of intervention is better than the other, but really this is just because they haven't been studied side by side in these different trials. But when they get compared in meta-analyses, we really see pretty similar effect sizes for all of these interventions. With that said, gut-directed hypnotherapy and cognitive behavioral therapy usually are thought of as the leading psychological therapies for DGBIs. And there's a lot of empirical research that I'll show in just a second that supports their effectiveness. And often these are just the treatments that GI mental health providers frequently use in different clinics. So in terms of who would be a good candidate for these BGBTs, you can kind of consider these as sort of patient characteristics that would make them better suited for some of these therapies. So, you want somebody maybe who has moderate or severe GI symptoms, but really hasn't responded to some typical medical treatments. They really should be open to the idea of using psychological treatments to improve their GI symptoms. And at least be either be aware of the brain-gut axis or open to education around the brain-gut axis. And oftentimes these patients who do well with these therapies can see the link between stress and their GI symptoms. And they do report that these GI symptoms interfere pretty significantly with their daily functioning as well. Another important piece is that they have been conclusively diagnosed with a GI disorder by a GI provider for which these therapies are actually useful. Really helps with buy-in and their understanding of why brain-gut behavioral therapies can be useful to help modify some of their symptoms and related distress. And then some other considerations are just that they don't have any untreated psychiatric conditions, any active psychotic disorders, things like that. And then they also have to be willing to make the commitment to therapy. So oftentimes these are patients who are seen for weekly or every other week appointments for about 2 to 3 months. And the expectation is that they complete some homework or practice in between sessions as well to really learn the skills and practice them regularly. So in terms of efficacy of these brain-gut behavioral therapies, one thing is that most of these have really been tested in conjunction with other medical therapies, so they're not really seen as alternative or standalone therapies. But nonetheless, there are many high-quality randomized control trials that support the use of brain-gut psychotherapies, specifically with GI CBT and gut-directed hypnotherapy. So there are over 30 randomized control trials for CBT and at least a dozen for hypnotherapy. And the other great piece is that these studies show some long-term maintenance of efficacy for even up to 2 years with CBT and nearly up to 5 years for hypnotherapy. So I'll quickly just review some of these specific areas where there is really good quality empirical support for use of CBT and hypnosis. And I will say that a great majority of the literature is in studies with IBS. So even though this data is largely in IBS, the thought is that these brain-gut behavioral therapies could be useful across the spectrum of DGBIs and even structural disorders, really just because of the way BGBTs work, more on those centrally mediated processes and sort of acting on that brain-gut connection. But so with IBS, some recent systematic reviews and meta-analyses show us that psychological treatments overall show therapeutic effect sizes of a medium size on IBS symptoms that last at least a year post-treatment. These studies also report improvements, patients reporting improvements in bowel symptoms and mental health and daily functioning. Another review noted that the number needed to treat is about 4 with this intervention. And so superior outcomes really with a majority of these control trials compared with controls. And the controls typically have been things like usual medical care, education, wait lists for treatment, placebo pills, even antidepressants and antispasmodic pills, and supportive talk therapy as well. And again, both of these therapies, both CBT and hypnotherapy, really show that gains are well maintained. So you see durable results for at least 6 to 12 months after the end of treatment. And then some other areas where there is a lot of really good research is with functional dyspepsia and non-cardiac chest pain. And again, you see sort of similar things here, that there are improvements in both the physical symptoms as well as improvements in quality of life and well-being as well. And again, similar to IBS, you see that these gains are maintained for a good amount of time after therapy ends. And again, these, like I said, IBS has the majority of the studies, but there are, anywhere from like 2 to 6 RCTs with CBT for these conditions, and at least 1 RCT for hypnotherapy for each of those. And then lastly, I know I'm talking mostly about disorders of gut-brain interaction, but I did throw in IBD just to sort of highlight how these brain-gut behavioral therapies are used in other GI conditions, and are really getting some rigorous testing in these other disorders as well. So in a recent meta-analysis with IBD and CBT, they identified 7 RCTs and found that CBT significantly improves quality of life in IBD, even though there's no evidence that it has an effect on disease activity. Interestingly, though, the hypnotherapy study showed a lower relapse rate in symptoms after 12 months. And of course, you do have to consider the overlap of IBS and IBD. There are a reasonable portion of patients who have IBD who also have IBS symptoms. So it does make sense that these brain-gut behavioral therapies can be really useful for folks with IBD. So really briefly, I'll just kind of review the 2 different interventions, cognitive behavioral therapy and gut-directed hypnotherapy, for those of you who might not be too familiar. So cognitive behavioral therapy really is one of the most widely used interventions in psychology, and it's used for a wide range of physical and mental health concerns. And in GI psychology, we're really using CBT to help improve GI symptoms, as well as mood and daily functioning. It's a very flexible intervention, really just based on the cognitive behavioral theoretical model on the whole, which is what I have up here. So you can see that the foundation is really focusing on these relationships among thoughts, emotions, and behaviors, and how it impacts physical symptoms. And so really the idea is that these thoughts, feelings, and behaviors are learned, maybe developed as a response to different GI symptoms or stressors. And those thoughts, feelings, and behaviors can really influence symptom and symptom perception. So treatment's really aimed at identifying and changing these unhelpful thought patterns and or behaviors to help reduce things like psychological distress, negative emotions like fear and anxiety, avoidance behaviors, and again, those unhelpful thought patterns that can contribute to symptoms and symptom perception. So things like catastrophizing, for instance. This also can be used in multiple formats, including group therapies, internet delivered, and even with pretty minimal therapist contact. And the typical components of CBT include things like psychoeducation, so providing some education to patients about the brain-gut axis and how stress can impact it, relaxation training to help reduce some of that autonomic arousal, cognitive restructuring to help modify those unhelpful thinking patterns that can contribute to symptom exacerbation and distress, increasing the toolkit of behavioral and psychological strategies for coping, and then also using exposure techniques to help overcome fear-based and avoidance behaviors that often leads to worsening distress. CBT is typically about 6 to 12 sessions in length, with some practice in between those sessions to really, again, hammer home those skills that they're building. And sort of the ideal patients would be people who have moderate to severe symptoms, but really show some of that, those maladaptive cognitions and behaviors. So evidence of fear or avoidance, and again, some of those unhelpful thinking patterns like catastrophizing, black or white thinking, and so on. Gut-directed hypnotherapy is really interesting. You can kind of think about it as just sort of a form of deep and focused relaxation, where the mind just becomes more open to therapeutic suggestions to facilitate some psychological and physiological changes and really improve that communication between the brain and the gut. So these imagery suggestions often aim at regulating smooth muscle activity, reducing the impact of stress on GI symptoms, reducing pain perception and attention to symptoms, and really just sort of increasing the patient's control over the symptoms they're experiencing. Typically, it's delivered over a course of 6 to 12 sessions, again, with the expectation being that there's some home practice as well in between sessions. And this too can be delivered in group settings and also through telehealth, so video appointments as well. So in each session of hypnotherapy, the clinician really leads the patient through these typical stages. So the first stage is this hypnotic induction, which is usually through guided relaxation and a narrowing focus of attention. So if you've ever done like a guided meditation or relaxation where you just close your eyes and relax each part of your body, that's sort of how this starts with hypnosis. So it really just results in your body feeling calm, and you start to be able to ignore some of those outside distractions. The next stage, the clinician uses deepening techniques to really promote more of that mental dissociation from the here and now. So here we might use things like you're going down the stairs, or you're going down in an elevator, you're sinking down in a cloud, which then leads to some more vivid mental imagery to really enhance that dissociation and increase the relaxation. And you can also use this imagery as a metaphor for inner calm and comfort. So in one of the most commonly used protocols, the North Carolina protocol for IBS, the imaging that's used there are things like being on a beach or being in a warm and cozy log cabin, so things like that. And then this last stage is really where the post-hypnotic suggestions come in. So this is where therapeutic suggestions are really aimed at changing some of those emotions, those thoughts, the reactions to the physical symptoms. So things like, the pain, the discomfort that they might be experiencing, normalizing some of the bowel activity that they experience, and really just sort of helping them increase their overall sense of well-being. So in this stage, you might hear a clinician say statements like, your intestines are becoming much less sensitive to pain and discomfort as a healthy, soothing wave of change spreads deep inside your body. Your stomach and intestines will feel less and less sensitive to discomfort from one day to the next, beginning right now. So again, the idea is that when they're in this really relaxed state, they are more open to those suggestions. And then it finally ends with the clinician bringing the patient out of that hypnotic trance. And here, the sort of the ideal patients would be patients who have severe to refractory symptoms, high levels of somatization, but also no history of unresolved abuse or dissociative disorders. So really quickly, I'll just mention, I hope you're convinced that these are treatments that can be really useful for different GI disorders. But the bad news is that access can be a problem. There aren't a lot of GI psychologists. We're basically asking patients to complete a series of often individual appointments with really specialized mental health providers. And so we recognize that there are some practical obstacles preventing the sort of widespread use of GI psychology services. There's also cost limitations, lack of immediate care, integrated care, all of those things as well. So one thing I'll just mention is the use of digital technologies to help increase the availability of some of these services on a larger scale. I'm just going to skip to this one. I'm going to just throw this up here, but encourage you to kind of take a look if this is something that you're interested in incorporating in your practice as well. But these are some FDA, well, some of these are FDA cleared apps. And some of them are covered by insurance as well, but most of them are probably easier out of pocket. But these are some apps that are self-guided, evidence-based programs for delivering BGBTs. And so it's definitely a growing area of interest. And so if that's something, you know, if it's something to consider if you have patients who are really motivated to engage in some things on their own to help with their different GI conditions. And then really briefly, of course, you know, the advantages of these digital therapeutics is that it's a great option for people who are motivated, who may not have a lot of these other significant psychological comorbidities, but these are templated programs. It does require the patient to actually open up the app on their phone and use it. If they have complex mental health needs, they probably need more comprehensive care. And for a GI provider, it requires a little more solicitation on your part. So just checking in to see if these patients are actually using these apps and finding benefit from them. So basically, I hope what you learned is that brain gut behavioral therapies are empirically supported treatments, and CBT and gut-directed hypnotherapy are really two effective treatments that can improve both GI symptoms as well as psychological distress and quality of life.
All right, I'll invite our speakers from the first session to come back up to the stage for the panel discussion. So this is our first panel discussion of RMH 2023. So I'll just start by kind of going over the structure. This is really the part where we want you guys to engage with us. We'll start it off with some audience response questions meant to summarize some of the points made by our speakers in the 3 lectures you heard today. And then we'll have opportunity for a question and answer session. You see the microphone up here in the middle of the center aisle. And feel free to step up if you have questions. So as I mentioned, we're going to start off with some audience response questions. We're using Poll Everywhere, and you can see there at the top how you can join this question response component of the talk. So text CU Hep GI 222333, or you can scan the QR code up here on the screen if your phone will allow you to. So give you a second to get that. And the first question we have, obviously from Dr. Ahmed's first talk, which of the following therapies discussed today are effective in patients with previous exposure to biologics or small molecules? All right, and I'll let Dr. Ahmed weigh in on these responses here.
No? Yes? Okay. Multifaceted question. Basically, all the answers are correct. But it's never that any subsequent therapy is not going to be effective in patients who've previously been exposed to advanced therapies. It's always the question of what's the likelihood, right? And so all these agents, all of our biologics are potentially effective in patients who have a previous exposure to other advanced therapies. But often we tend to go with certain agents relative to others. So typically, for the relevance of this question, probably upadacitinib has the highest response rates or remission rates in patients previously exposed to biologics. When you look at indirect based evidence, particularly in ulcerative colitis, mirikizumab definitely has a demonstrated effect as well. Etrasimod, a little bit more hesitant depending on what clinical trial program you looked at. We'll see how the real world data pans out, but basically likely is positive in some patients. CURQD, small study, but at least 50% of their patients had previously failed advanced therapies, with a third having failed biologics, and they still had a signal there. So all these compounds are potentially effective in patients. It's just a matter of what's the chance and what are you more likely to prescribe given a patient's refractory disease state.
Great, thank you. All right, moving on to the next question. A 24-year-old Caucasian male diagnosed with eosinophilic esophagitis is not responding to PPI, elimination diet, or topical steroids. He has a history of asthma and eczema. So what is the next best step in treatment? Again, Dr. Reddy, I'll let you take this one.
Yeah. So I think this is sort of kind of like the classic scenario with a white male who doesn't necessarily respond to the sort of the standard treatments. So starting in 2022, the dupilumab is sort of what has been used now, and the fact that he has asthma and eczema would be a good candidate. And so he could even be a good candidate to get this as first line therapy at some point when the algorithm changes. But the answer is C. Yeah, oral prednisone wouldn't necessarily work. PPI plus topical steroids, again, wouldn't necessarily be something to do. And cromolyn hasn't really been much studies on, or actually been effective studies on EOE. So.
Sorry. One more question related to EGIDs. So a 28-year-old Caucasian male been diagnosed with eosinophilic gastritis. He's uncomfortable with being on prednisone and wants to try a diet. What is the best diet for him to try first?
Yeah, so sort of looked at this. So this is interesting. This is sort of a different sort of what the data shows. So actually the 6-food elimination diet is actually a little better for eosinophilic gastritis in the sense you kind of get a more robust response. So the step up approach hasn't really been shown to be effective in sort of this group. And so 6-food elimination diet is sort of what you would want to do for this patient.
All right. And then which of the following concerns could be targeted using brain gut behavioral therapies?
Yep. So this one is all of them. You can use brain gut behavioral therapies, things like CBT and hypnotherapy, really to help patients shift some of that attention away from gut signals, not process it so much as a threat. Also use it to help people address that fear and avoidance of GI symptoms. So CBT is a great strategy for that, using exposure strategies, behavioral experiments, and then, of course, modifying some of those unhelpful thoughts like pain catastrophizing. So experiencing some of this normal gut sensations, again, as a threat. BGBTs can be really useful in modifying some of those unhelpful thought processes.
Awesome. Thank you. So with about 5 minutes we have left, if we have time for audience participation, if you have questions for any of our speakers, feel free to come up the microphone and ask them. And I can kick things off. So I have a question for you, Dr. Ahmed. You know, when I was a fellow, which was not long ago, you know, we had the anti-TNFs, which are kind of the mainstay of treatment. And then obviously ustekinumab and vedolizumab and some of the other ones were just starting to come on the market. Now, just a short 2.5 years later, it seems to be an explosion of options for our patients with IBD. Other than kind of as therapies for people who are not biologically naive, so for patients who are non-responders to the anti-TNFs or small molecule inhibitors, are you ever reaching for some of these newer therapies that you mentioned today, kind of in biologically naive patients?
Yeah, it's a great question. You got to use it or you lose it, basically. So unless you start only use these drugs as last line agents, you're not going to have good success or ever really learn how to position them. So it's important, obviously, to pay attention to the literature. In all of these clinical trial programs, approximately half of the patients are bio-naive. And so It is, potentially attractive, particularly in young, healthy patients, especially because a lot of these therapies have very good safety profiles of maybe a once-a-day pill is totally fine, and I don't need to actually be on Remicade or infliximab for the rest of my life via infusion. So what I would say is often, yes, we do. There are some intricacies that we have to be aware of, particularly with the JAK inhibitors. There is a FDA black box label warning that says you have to fail TNF therapies first before you can consider them. It's kind of a stupid black box label warning, but we have to deal with it. There are some workarounds with it. But yeah, I use the S1P receptor modulators, the IL-23 antagonists, the workarounds to use JAK inhibitors first line all the time.
Great. And then a question for you, Dr. Gumidyala. As I think you talked about, and as someone who practices general GI and sees lots of these patients, that you're a very valuable and scarce resource. What are some of the, I guess, mispractices you identified most in terms of your referral populations from general GI providers that you want us to know about?
Great question. I think, one of the biggest things is thinking about GI psychology as a subspecialty of mental health. So we are not the de facto mental health providers. And so if there are patients who have, untreated or undiagnosed mental health conditions like PTSD, even with depression and anxiety, it's really not the focus of GI psychology to work on those things. And it's hard to really focus on the GI related issues if they have some of these other bigger issues happening. So for those patients, I always recommend referral to more general mental health providers, psychiatrists, psychologists, therapists to help address and at least stabilize some of those other symptoms. And then they can come back and really work on the gut related issues that's coming up for them.
Awesome. So if there are no further audience questions, I'd say we can wrap up session one. I want to thank all of our speakers so much for developing and giving these talks. And yes, so this is a free conference. So obviously that takes financial support. And so that comes from our sponsors. So I want to thank them again. And we're going to have a 20-minute break now before our next session. Encourage you to go out back into the lobby, engage with the exhibitors, and then come back here sharp around 9:40. We have a new talk that we're very, very excited about this year, given by Andi Dwyer, entitled, it's going to be about community networking and how we can best serve some of our underserved patients in terms of colorectal cancer screening. All right, we're going to get started with our next session just so we can try to stay on time as much as possible. This is a session that's near and dear to my heart, and I want to start out by introducing the session, then introducing our speaker for this session. So this is something we decided to put together as we were building this conference in the hopes that we essentially start something here today that continues throughout the year and onward in terms of colorectal cancer prevention and helping some of our underserved patients in the Denver metro area. And in that light, we've invited Andi Dwyer here to give a talk. It's going to be entitled Building Capacity for Colorectal Cancer Screening in Medically Underserved Communities, the Links to Care program. Andi is someone I've gotten to know over the last couple months. I have some notes here that I want to read. She's an incredibly accomplished young woman, and to read all her accomplishments, I need to write them down. So Andi Dwyer is the director and one of the founding members of the Colorado Cancer Screening Program, CCSP for short, at the University of Colorado Cancer Center. She's implemented the country's largest screening patient navigation program for preventative screening within the safety net clinics. CCSP is now growing its prevention and cancer control work to hereditary and lung cancer screening initiatives. She's also co-chair of the National Colorectal Roundtable for Evidence-Based Health Promotion Subcommittee and an executive committee member of the National Colorectal Roundtable. She's got extensive partnerships at the state and national level for health promotion activities, as well as partnerships within the realm of colorectal cancer. At the state level, Mrs. Dwyer is on the executive committee of the Colorado Community Health Worker and Patient Navigation Collaborative to help advance this work in Colorado. She's also the chair of the Colorado Cancer Coalition. And on the national level, Andi's the vice chair of the Patient Navigation Roundtable, supported by the American Cancer Society. She also advises Fight Colorectal, a national colorectal survivorship nonprofit, in their health promotion and research aims for the growing number of colorectal cancer survivors and advocates to bridge the public health, research, and medical care for better programs. And again, her talk will be entitled Building Capacity for Colorectal Cancer Screening in Medically Underserved Communities, Links of Care Program.
So thank you guys so much for having me. And I just want to say Dr. Jones, Dr. Kalra and team have been amazing, as well as Dr. Edminowitz, Patel, and others who really saw the potential in terms of really thinking about opportunities for screening for the medically underserved in Colorado. And so, as Blake mentioned, we have been working for about the past 4 or 5 months thinking about building capacity for the medically underserved. And when I say that, I'm really talking about those who have Medicare, Medicaid, as well as those who have no health insurance, and thinking about access to care. One of the programs that I help lead out is particularly thinking about increasing colorectal cancer screening in federally qualified health centers, rural health centers, and critical access hospitals. So over the last 15, 20 years, really thinking about increasing those screening rates has been critical. When I first started in this work, we saw screening rates amongst those individuals for endoscopic screening, colorectal screening, and even stool-based screening somewhere in the 10 to 20%, but many of them are up now towards 40, 50, almost even nearing the 60% mark. So I'd like to say that a lot of the work that's come from our state cancer program, our cancer coalition and team, as well as funders all throughout the CDC, NCI, NIH have been pivotal in making sure the work moves. But we really do have a lot in terms of the need, in terms of thinking about the medically underserved. So what I'm going to need your help today is really thinking about needing your response and input based on some of the data and findings we have in terms of getting feedback from our safety net clinic systems about where they are, what they need, and the trajectory of what it's going to take to increase screening rates for the medically underserved. Assess the willingness, of course, from all of you to engage in ongoing efforts to support in the links of care work. And again, I think we already have several champions in the room who are really going to hear the need and really think about how do we connect the dots to hopefully grow something that's not just a spotty type of approach, but what can we think in terms of a systematic approach for responding to the need for capacity for colorectal screening for those who have no health insurance, particularly Medicaid, and even those with Medicare. I'm excited that I get to have several of my team members. So Allie Bain from the American Cancer Society, please stand up. I almost said Slim Shady, the way I said, please stand up. Let's see, Ian Kahn from the American Cancer Society, or from the Health Department, Allie from ACS, Elsa Weltzine, who's also part of our team for the Colorado School of Public Health, stand up. And then Dr. Hans Elzinga, who's with Salud Family Health Centers, who's also leading out a number of GI initiatives, who's also joining us today. And we're all collectively part of the Cancer Coalition. Specifically, I have an appointment within the School of Public Health, and many of my initiatives run through the Colorado Cancer Center. So when we do join today for some of the discussion, I'm going to please be asking for your input from the QR code. I don't know if you can do this from your seat right now, but we'd love for you to follow along, provide some input, as well as sign on for some continued discussion about where we're going in direction. Because again, I think what our goal is really to think a little bit about how can we look at in-kind, low cost, no cost type of opportunities to help support the medically underserved. So again, Ian, Allie, Hans, and Elsa will be joining us, as well as Blake and Avash, in terms of having that table discussion in terms of the direction and next steps. But what I want to share with you is a little bit of a finding. And again, this is with just a few of the health centers that we've been working with about their response to if colonoscopies are too expensive for patients who are uninsured, and we need a way to complete those screening in a sustainable type of approach that may oftentimes not need particularly for out-of-pocket expenses, but making something that's ascertainable. What kind of approach are we going to need to build a link of care project that can create a referral process across community health centers, regional specialty care groups to provide lower, no-cost screening? And so that's why we're here. That's what we're really going to talk about. And in terms of having our safety net partners who are specifically funded from our cancer control program at the State Health Department, we spent some time since about 2022 meeting with them to ask what are their needs, what is the baseline, where are they going, and what have they done previous that might be good sort of general direction for where we need to grow programs in the future, and how can our communities be really responsive to that. So essentially, we created a small questionnaire and an assessment, which I'm going to share some of those. And again, this is just a small bit of a snapshot in time from just a subset of clinic systems who are safety net clinics or rural health clinics all throughout the state to understand where were they, what did they need, and then having a little bit of time for us to be responsive in terms of thinking about building that network that I'd mentioned in terms of referral type of approaches moving forward. So essentially, again, I want to just also say from the beginning, this is essentially 5 different health systems. Dr. Elzinga even is part of Salute, who wasn't mentioned here. But I think this gives just a general sense of what we're hearing from our safety net partners who usually serve people who have no health insurance or types of public health insurance where access is an issue. So ultimately, when we looked at the survey findings in terms of STRIDE, TEPIEC, which are both in the front range, STRIDE has, I think, actually 5 to 10 different health centers all throughout the metro area. TEPIEC is also in Denver proper. Regional Mountain West, we have representation from Summit Community Health Center, Uncompahgre Medical Center, and then the rural Eastern Plains in Lamar, Colorado, High Plains Community Health Center. So we're not just front range, we're really getting perspective from throughout the state in terms of really what the issues are related to screening. And so basically what we were hearing and what we've seen, and as I noted, ultimately when we looked at the screening rates, which is typically the UDS measures or the quality measures, we know that most of these systems are hovering at top, almost close to 40, but even Summit Community Health Center for all of their patients is about 20% in terms of overall screening rates as it relates to colorectal screening. We know the percent uninsured population for those who are seen in those clinics are usually upwards of either a quarter, sometimes almost a half, in terms of they have no insurance at all. But then Medicaid is typically the driving type of insurance type. And then when we spoke to these individuals asking if you were really looking at the estimated number of colonoscopies that you need for your uninsured population, that would be symptomatic, asymptomatic individuals, what's your best sense of what you would need if colonoscopy were particularly the primary mode? So I just level set a bit in terms of thinking about these numbers. Again, this was really post and still almost pandemic period of time. We know ultimately what that need is, probably still hovers, but we're also finding other types of opportunities to screen asymptomatic patients, such as stool-based screening approaches, really looking at systemic approaches to others beyond colonoscopy. But I think the big question for this group is, particularly if those people are symptomatic, have stool-based testing, what are they doing with those referrals? So when we also look at ultimately your current need for colonoscopy by year for the responses, and again, I think this one would specifically for screening and diagnostic. But if you're looking specifically at colonoscopy, I think this one was particularly for colonoscopy for the symptomatic individuals. We get a little bit of a varied response about what is that need. But again, I think one of the things we're really trying to work with these systems are really thinking about all the types of screening modalities that are available, understanding who are high risk because of symptoms, signs, symptoms, family history, as well as those who might actually be positive for stool-based testing, and when do we need to really prioritize colonoscopy. So one of the things that we'll be settling in and continuing to work on with those groups is really making these linkages. So for those 5 to 6 different health systems who are part of specific grant program, we're using this data, we're using the information to make those regional connections with a specific number of endoscopy groups so that we can really help think about that response. But I think one of the things is that this is just a highlight of those that really need the services. We essentially right now through several of our other programs are working to 20 to 30 health systems. And so we really want to think about how we're responsive using this kind of data, again, to build that infrastructure. So in terms of referral processes, we all heard that, of course, that referring for Medicaid and Medicare patients is the same process typically as privately insured, but the delays for Medicaid patients can be excessive. We know that about 3/4 of them required a different referral process for uninsured patients. So particularly really thinking about using the stool-based testing for uninsured and really thinking about prioritizing those individuals who are positive. There's currently also a freestanding program called Colonoscopy Assist that's been a little bit hit and miss in terms of finding linkages for low-cost individuals for people who have extensive issues paying out of pocket. And then some of the patients use the funding that they do have in terms of paying out of pocket for free or for reduced cost screening, which we'll talk a little bit about what we know about those costs. When we've talked to the 5 systems about what for referral components can be approved upon, I think that there was some really interesting things that they feel that they can sufficiently identify patient who needs screening, which I think is great because we're seeing stronger implementation of the EHR records, scrubbing charts, really identifying who's eligible, knowing that colorectal cancer screening is now a priority for FQs and critical access hospitals, I think is great. They're doing a better job of identifying who are specialists in the community, thinking about those referrals and thinking about the preparation. But I think the area in terms of seeing that process and improvement in terms of referrals, as well as getting information back about screen, is still sharing the results of colonoscopy and then ultimately thinking about those referrals for diagnoses. So I still think, there's some areas where we need to identify, thinking about the specialists, making those connections, but we're also, I think the highlight is doing quite well as it relates to really thinking about CRC and identifying patients where I would say when I first started in this business, that was something that wasn't on many patients' radars, or many different providers' radars. So when we actually then talked further with folks around this idea of this continuum of referral and what it means to be screened by colonoscopy, attend the colonoscopy, and then thinking of those and those referral for treatment. Again, the strengths, we're identifying those people working internally and referral to get patients prepped and transported, but the locations who will accept uninsured patients still remains a little elusive. The staff capacity post-COVID and receiving those reports and having those referrals for treatment, again, are kind of the areas where I think many of us at UC Health with Dr. Adminowitz, Dr. Patel, Dr. Jones, and others have really helped us think about some strategies for building that capacity. When we actually also spoke with these health centers around what are the challenges related to scheduling and completing a colonoscopy, transportation still seems to be an issue, particularly those who are rural and frontier. But even in the metro area, when we think about sedation and we really think about that need for having someone accompany, that still remains a bit of an issue. And then, of course, thinking about that geographic distance insurance and some of the communication challenges. And I would also say that in terms of utilizing particularly translation, interpretation services for Spanish-speaking individuals, but also for Russian, French, and a number of languages still come up as areas that we need to be responsive. We did ask the systems of ultimately if they'd received donated or in-kind services for a colonoscopy. The blue is in the past, the green is current, and have never received. I think the one thing that we have to also really be critically thinking about is that if we're looking at setting up programs for capacity, that it's not just about the physician time. It's not just about doing the scope. It's also thinking about those referrals and also for paying for the pathology, the anesthesia, treatment, and adverse events. And then ultimately, I think where we've seen some great success is that transportation, ACS, other groups have done a great job in providing support, grants like mine, as well as in the past, there's been some good opportunities by gastroenterologists and others who've actually provided that support. But again, I think if we're really going to be thinking about putting a program together, it has to be thinking about the physician time, as well as also thinking about the time it takes for the institution facility, as well as the pathologist, anesthesia, and any adverse events. So other states have set up these type of referral systems in terms of low cost or no cost donation programs. Some of the components we were asking for what were some of the facilitators in terms of looking at strongly agree that these were in place to get something and moving. And ultimately, the idea of leadership and having physician support internal seems to be something that people really feel strongly about. They can identify how many colonoscopies are in need, consistent with the other data that we see. We have a strong navigation and or coordination care program. I will say Colorado has done a lot in terms of building in navigation, reimbursement, workforce development, and really meeting the needs of the patients. So these are all really great things. And that ultimately they have support from a neutral party who can help convene and really get a referral system. And that's one area where we feel like we'd like to have stronger emphasis, and some people feel that that's helping, but this type of facilitated discussion today, I think will really grow that opportunity. And we have a strong relationship with specialists in the community to be responsive to the need. And that's where other groups say they had to be successful, and that's still an area of growth. So key takeaways, again, money and funding is a primary barrier for uninsured patients, as we all know. Many have colonoscopy assist for free or reduced colonoscopy pricing, but still that can be more than most patients can afford out, and we can talk a little bit about those costs. Specialty care centers are experiencing staff and capacity shortage due to COVID-19 pandemic. And I know even with the insured population, there's still a bit of a backup. And we have lower no cost model existence in terms of looking at making those referrals. But even with language barriers, that's something that we have to really be thinking about, meeting the needs and the specific cultural and contextual issues that patients are facing. There's no other options for those cancer diagnoses, and challenges with transportation out of the area can definitely be part of the problem. And then ultimately, thinking about those screening results and getting those results back from specialty providers and endoscopy and pathology labs to know about next steps is an area that we think that we can really help provide some support. We do know that there are opportunities to learn from our breast and cervical partners in terms of what they've developed, as well as other programs, again, that have been set up all throughout the country. One of several of my colleagues and I'll send this out just because I think this might be helpful in terms of those thinking about grants, grantsmanship and writing for future types of proposals. One of the things that we did try to do is really match the needs based on the policy, community, organizational, and individual level based on this, really the socio-ecologic model. And we've used this in terms of citing some of the reason and rationale for being responsive in terms of what we know in terms of needs of patients and really thinking about our funding moving forward. And again, I really do think that a number of the issues that we've spoke to really pair nicely to these areas that we're looking for support. And one of the things I will say is in terms of also looking at the policy level, you know, our state health department, many of our initiatives to pay for the tobacco tax have been responsive to cancer screening. But over the period of time that ACA has been implemented, not many of those any longer will provide for direct services, but yet that's an exceptional area where we still have gaps and we want to be responsive to that. And that's something that I think we've been really sharing with policymakers and others, that this is great and we can set up infrastructure, we can set up support in kind to a point, but we're still going to need some undergirding to make sure that this population has an opportunity to be seen with providing infrastructure for all of you in our FQHCs to be able to create linkages. So I just bring this up, and this was just a snapshot in time again, where we saw in 2022 what many of our out-of-pocket costs. So even some of the programs that had been set up, like colonoscopy assist and others, we do know that at that period of time, in terms of out-of-pocket expenses, most of the time the screening costs were upwards of $1,000. I know this has come down, and I know that others sometimes have even lower reduced rates. But in terms of what was actually accessible publicly and in understanding what it would mean for out of cost, the prices were really still quite high for many of our individuals who had no health insurance. In terms of thinking about the examples of link of care of approaches, we do know that ultimately many of our states have been our other CRCCP CDC funded program who receive dollars from the feds through CDC to do colorectal cancer type programs when they've been working with partners to think about a links of care type of approach. Surgery on Sunday is something where there's been donated time for screening on weekends, evenings, and that was particularly an LLC that was set up to do that type of work. A baker's dozen, which I like to call it, is essentially some of the docs were doing 10 to 12 different scopes per day for insured Medicare, Medicaid patients, and then actually providing 1 or 2 free or in-kind services, which is something I think that we've talked about even within UC Health. How do you use an opportunity that's already the lights are on, the people are there? How do you use that infrastructure for uninsured? Designated colonoscopies per month. I think in March, we see different health systems. I think many of you have even participated for CRC month where we're seeing a donated time. And there are those kind of in-kind opportunities. Colonoscopy Assist is a free and standing LLC group, or not free, but it's a group that's specifically looking at linkages and providing patients that opportunity for lower cost. But again, over $1,000, sometimes still not accessible for patients. And again, March is CRC Awareness Month, where there's a designated month or a number of colonoscopies that are donated. So I think these are all areas that we've been looking at as top possible models that we could deploy these sort of implementation strategies in Colorado. But again, we really do need kind of an army of individuals who are from facilities, who are from the community, who are docs, who are nurses, who are people who are in the business administration side to really help us build this sort of infrastructure. And one of the things that I will say is that in our survey work, when we look at the central resources and coordination, most folks are really talking about this idea of information technology. Can we build something like a repository or a needs or endoscopy services in a database? Can we utilize our EMR, EHR systems to identify a matching type opportunity? Do we have synergies with other and existing programs? So colonoscopy assist, can we have a formal relationship with them, bring those costs down as they help make linkages, even with the e-consult or co-RIO, where these information highways for referral type of approaches, can we create something that has infrastructure where the EHRs, EMRs, or these technology pieces speak to each other, again, for that matching opportunity? Established information sharing, again, which would really help with that kind of the EHR technology component, and matching services. And so in my mind's eye, I'm thinking of like a Tinder for endoscopy. So I don't know really what that looks like. Everybody laughs. I see some head shakes. Not sure what that looks like. We're going to be beaning at the back table. So that's where we'll have that time to talk. But it does seem like that there is an opportunity. I will say that I have tried several of these types of approaches before. The month, I had 1 month in March several years ago where I had over 300 colonoscopies donated through the month of March, but essentially that didn't last. We didn't have the infrastructure. We didn't have the person power. We had a one-time thing. We got a lot of people screened, but we really didn't build in the pieces that we would need to have that make for staying power. The other thing I just wanted to mention quickly is the hospital discount and care program. I think is going to provide some opportunity as we think about implementation for referral services for care that's necessary. So we've been really thinking about that moving forward. But I think what's also important to think about is also, again, this idea of staying power. And I, in closing, wanted to bring some of the thoughts around donated colonoscopy from our partners. So it'd be best to have a website or a portal for a local donated colonoscopy service, connecting uninsured patients to donated screens for discounts available in their geographic area. And with characteristics like procedure cost, or if information and the discounts available, what they need to do apply, language is available, and if interpretation is available, how the patient would assess interpretation if materials are available in Spanish as well. I'd also like to know if they participate in co-RIO or how we could easily access the records. Matching needs with availability is a challenge. Could be there an external site or something to put in on our radar, or having a screen to reach out to someone when they have an uninsured patient in need of colonoscopy. Is there a concierge service, and that could exist? Could this be helpful? And again, that whole idea of what can we use for information highways. So again, I think one of the things that we're hearing is essentially that we really think about the donated screens. There's a lot of will, there's a lot of potential. I think hearing from many of you, this is an area we'd like to think critically, but I'd really love to have some time. And I think Dr. Jones will share with us a little bit about our next steps. What we'd really love in the takeout time, next steps in terms of this conclusion of the session is, what feedback do you have about the information we presented? What information would you like to know if we're building these sort of programs, or if you would be involved in donated type opportunity? What approaches would you recommend to help provide free or low cost screening? And would you be willing to join our efforts? And I think Ian had a good question. What does that mean? If you'd love to sign up today to be one of those providers who might provide direct services, if you know the facility would like to be involved, that's great. That's a big ask. But I think what you were interested in is, would you like to follow along with us and thinking about being responsive to this as we grow that infrastructure? And whatever that looks like, we'd really love your support. So Blake, I will have you give us our next direction. And thank you guys so much for having us. I know we're a little bit outside the box, but we really appreciate the time on the agenda. Thank you.
Yeah, thanks so much, Andi, for coming, and for everyone else in the back. So with about 20 minutes or so we have left before our next session, we really want to use this meeting and then this session specifically as a launching point, really for coalition building. So we have seen that there's some people doing some amazing stuff in our community, really trying to help patients who need help, but they can't do it all on their own. And there's some of us in this room who potentially have the capacity to provide some of that help. And so for the next 20 minutes, everyone will be in the back. Andi mentioned who they are. We'll have opportunities for you to interact with them, and then also just essentially sign up to continue to learn more, continue to have this discussion, and to really continue to figure out how we might be able to solve some of these issues. We're not asking for people to sign up to do that themselves today, but we really want to start a discussion that then is maintained and hopefully develop something in the community that's sustainable, where we can really help these patients. So I'll leave it there. Again, people will be in the back. If you're someone from one of the community groups in the Denver metro area, or if you think you have any other way you might be able to help, or you just want to learn more, please come join us. Thank you. And we'll resume with our next session. What time is it? 10:30. Sorry, 10:30.
All right. We're going to go ahead and start the next session now. I just want to thank everyone for engaging with our leaders in the community on the back tables, and hopefully those conversations can continue as the day goes along. I think I know I speak for Blake and the conference organizers that we're having a great time today, and I hope you all are as well. We're moving on to the next session, which is high yield topics in hepatology, and I will be speaking first. So as you heard earlier, I'm an assistant professor of medicine here at the University of Colorado. I'm also the director of our liver transplant outreach program, which I'm happy to talk more about with you during the breaks or at lunch, but essentially it includes both educational initiatives within our own community, but also establishing outreach clinics outside of the Denver area, such as up in Montana, down in New Mexico, and all throughout the state of Colorado as well. But for my talk today is not necessarily outreach related. I'm going to be talking about malnutrition and frailty in the setting of chronic liver disease, and specifically talking about a practical approach to that. We'll then have a talk after this about alcoholic hepatitis and liver transplant, and then a talk about what we can offer for the treatment of what used to be called NASH. And I won't steal Dr. Whelan's thunder on that. All right. So I have no disclosures for this talk. The learning objectives, number one, is to define the term frailty as it applies to patients with cirrhosis and recognize the many interrelated factors leading to that condition. Number two, recognize the social determinants of health that contribute to malnutrition and frailty in patients with cirrhosis. And number three, identify a practical approach to assessing frailty and also interventions targeted at identifying that condition and preventing worsening frailty as well. I'll start by sharing a photograph of Dr. Thomas Starzl, who many of you may know was the transplant surgeon here at the University of Colorado who performed the world's first successful liver transplant in 1967. That was when the campus was, well, this building certainly didn't exist, but the whole campus was at 9th and Colorado. And you can actually, if you can see his scrubs, says the University of Colorado Health Sciences. This is a photo to remind us of a couple of things. One, this was only in 1967. I know it's a black and white photo, but in the grand history of medicine, the management of chronic liver disease and liver transplantation is pretty new. And the discussion of the topic today, frailty, is even newer than that. Back in Dr. Starzl's day, assessing frailty was maybe the eyeball test that he would give from the door. Dr. Starzl, by the way, considered a pioneer of transplant, and obviously we're very proud that the first liver transplant successfully done in the world was done here. But he actually intended on becoming a priest. That's a fun fact for you. He was planning on going and becoming a priest. Actually, his mother was diagnosed with breast cancer when he was younger, and that caused him to change course and go into medicine and be the pioneer of transplant. So transplant evaluations take, at our campus, a couple of days, and it's an intensive process. And the goal of today's talk is not to talk about our transplant evaluation necessarily, but to highlight the fact that in addition to the surgical evaluation from Dr. Starzl's successors, a cardiac evaluation, lab testing, imaging, a psychiatric or psychological assessment, social work evaluation. A big part of this is their nutrition evaluation as well, assessing their nutritional status and patient education regarding that. There are guidelines by the AASLD, the American Association for the Study of Liver Diseases. This is our governing body, especially in North America, for guidelines related to the management of liver disease. Malnutrition, frailty, and sarcopenia in patients with cirrhosis. This is largely out of data from UCSF, but you can see that this was published just in 2021. It's one of our newest guidance documents, and I'll make references to this as we go along in our talk today. But I also want to just emphasize that you can refer to this anytime you like by just visiting the AASLD website and seeing their guidelines, which we always try to follow. So first of all, malnutrition, what is it? Well, it's a clinical syndrome. It results from an imbalance, and that can be either a deficiency or excess of nutrients that causes adverse effects on the body, size, composition, and function, and that leads to adverse clinical outcomes as well. I also want to emphasize at the start of this talk that malnutrition represents a spectrum of nutritional disorders. This isn't just referring to patients with low BMI necessarily, but across the entire range of body mass index from underweight to obese. And malnutrition itself leads to adverse physical effects, as we'll talk about at length, commonly manifested phenotypically as what we call frailty, or the term sarcopenia, which I'll discuss again. So in the setting of cirrhosis, first of all, cirrhosis is a catabolic chronic illness. It's accompanied oftentimes for a variety of reasons by reduced appetite that may be related to the fact that they have, a lot of these patients are decompensated. They have ascites. That ascites also masks muscle wasting. And then there's a misconception regarding protein intake. So we know that there's no need to limit protein intake for patients with chronic liver disease. These are just some caveats that I'm mentioning at the start. And malnutrition leads to poorer outcomes following liver transplant as well, especially with a BMI less than 18.5. This was studied nicely in a publication from 2015 from faculty members who formerly worked at this center, and showing that low rather than high body mass index confers an increased risk for post-liver transplant death. In fact, in this study, overweight and obese liver transplant recipients did not have an increased risk of death or graft loss, regardless of their MELD score, but underweight patients had an increased risk for poor outcomes. So frailty, what is it? Well, first of all, it's a broad term. It's classically used in the medical literature by geriatricians, and we've sort of taken it from their field and used it in ours. It's defined as a clinical state of decreased reserve and an ability to endure health stressors. And although this representation deviates somewhat from the classic geriatric definition of frailty as a global construct, physical frailty represents clinical manifestations of impaired muscle contractile function that are commonly reported by patients with cirrhosis. So the operational definition of frailty for patients with cirrhosis, we're talking about physical frailty, the manifestations and consequences of the loss of muscle function. And it's present in over 30% of patients listed for liver transplantation, and that's likely an underestimate. Having frailty is linked to increased waitlist mortality, decreased quality of life in patients awaiting transplant, increased hospitalizations as well. And frailty worsens longitudinally over time if we don't do anything about it, and it can persist after liver transplant as well. So even though a single patient can be described as frail, sarcopenic, which is a loss of muscle mass, so literally a deficiency of sarcomeres, to take you back to basic science, and malnourished. So even though, like I said, a single patient could be just defined as any of those, frail, sarcopenic, and malnourished, thinking about the terms separately is useful because it's not just malnutrition, as you can see in this schematic here, that contributes to frailty. There are cirrhosis-related factors, such as synthetic dysfunction, cognitive dysfunction, and buildup of ammonia. Other systems such as metabolic dysregulation, insulin resistance, and endocrine dysfunction. There's physical inability related to muscle disuse and cardiovascular deconditioning. A lot of our patients have what's called a cirrhotic cardiomyopathy. Okay, they don't have as well-functioning hearts. And then environmental or organizational factors as well, which I'll talk about a little bit more in a bit, social determinants of health. And these are the etiologic factors that you can see at the top that lead to these manifestations of muscle dysfunction, frailty. And the outcomes are, as I mentioned already, increased risk of decompensation, healthcare utilization, a decreased health-related quality of life, death, and adverse post-transplant outcomes. So why is it so common? Well, I touched on this a little bit so far, but to go into it in a little bit more in depth. Well, first of all, malnutrition, okay? This is the impaired intake and uptake of both macronutrients and micronutrients. So zinc, folate, thiamine, vitamin D, just to name a few. So in some of our patients with chronic liver disease, it's related to reduced oral intake. So if they have an abdomen that is full of acidic fluid, they have decreased appetite, they may not be taking in these nutrients to begin with. A lot of our patients have cholestatic liver disease, where they cannot absorb, for example, fat-soluble vitamins, vitamin D being one of them. And then they have altered metabolic processes as well. including increased catabolism. Cirrhosis leads to impaired hepatic ammonia clearance, which itself, the buildup of ammonia leads to mitochondrial oxidative dysfunction and myotoxic damage, further contributing to the acceleration of muscle loss. Systemic inflammation and endotoxemia, which can lead to increased infectious complications as well. Physical inactivity in these patients, and then social determinants of health. So while we often talk to our patients about a healthy diet, say a Mediterranean diet, this would just be an example, can patients really afford all of this? And do they have access to this delicious spread? I am also realizing right now that this session is right before lunch, so I'm sorry I'm showing you this photo. Social determinants of health. Many patients with cirrhosis have a limited knowledge to begin with about their disease self-management, and that includes nutrition therapy. Inadequate food knowledge and preparation skills, and a term called food insecurity also is a significant contributing factor for these patients. So that is those are social factors such as poverty, isolation, and limited access to nutritious food. If you're telling a patient who doesn't have a reliable source of income to go to Whole Foods and shop for fresh fruits and vegetables, they're going to not be able to do those things. They're going to look at you like you're crazy. Financial strain limits caregiver presence. It limits monitoring as well, and then limited supervision for physical activity, less attentive management for cirrhosis complications, such as timely lactulose therapy. All of these are social determinants of health that contribute to this condition as well. I already mentioned earlier that frailty is strongly linked with mortality in both the ambulatory and acute care settings, as well as the post-transplant setting. The AASLD recommends in their guidelines that all patients with cirrhosis should be assessed for frailty with a standardized tool both at baseline and longitudinally. And hopefully, as we go through the remainder of this talk, we can talk about practical ways that we can all do this in our own practices. You certainly don't have to be at a liver transplant center to be able to assess frailty objectively in a patient with chronic liver disease. So frailty by the Liver Frailty Index is which I'll talk more about in a second. The Liver Frailty Index is an objective measurement of frailty. It's associated with a nearly twofold increased adjusted risk of death. And this is in a study of over 1,000 patients in the clinic awaiting liver transplant at a multi-center study in 9 transplant centers. So the Liver Frailty Index was a tool developed in San Francisco at UCSF. I think they have a great logo, by the way. Since LT also stands for liver transplant, and they managed to work a liver into the logo. But it basically includes 3 key features that can be measured in the clinic. So hand grip strength, chair stands, which assess their muscle strength, and then balance, 10 seconds each in these 3 positions, side by side, semi-tandem, and tandem. So this is assessing nutrition, muscle strength, and neuromotor coordination. So frailty, as measured by the Liver Frailty Index, improved in only 16% of over 1,000 patients with cirrhosis awaiting liver transplant. And post-liver transplant, their Liver Frailty Index scores worsened from pre-transplant values in a significant proportion of these patients. So, for example, at 3 months after liver transplant, their Liver Frailty Index score worsened in 60% of patients. Worsened in 40% of patients at 6 months and 32% of patients in 12 months. All of this is underscoring the need to optimize their frailty before transplant and then continue with those recommendations afterwards. And then only 20% of patients achieved functional robustness as defined by the Liver Frailty score less than 3.2 by 1 year after liver transplant. And I would argue that we certainly can do better than 20%. So I've alluded to this already, but the Liver Frailty Index has established cut points to define robust, pre-frail, and frail. So I won't bore you with the calculation of these numbers, but those 3 modalities that I talked about, the hand grip strength, the muscle strength testing, and the balance testing, ultimately produces a score, okay? And under 3.2, we would consider them physically robust, 3.2 to 4.3 pre-frail, and over 4.4 frail. Each 0.1 unit change in the liver frailty index over 3 months is associated with a 2-fold increased risk of death, independent of MELD score, which I think is kind of a remarkable figure. And you can see the high hazard ratio there for that statistic as well. This is a test, the liver frailty index, that we do at our center. We test this on all of our patients who are undergoing liver transplant evaluation. And then depending on the scenario, retest them as they go through the evaluation process leading up until liver transplant. So what can we do about this practically? Okay, well, first of all, I want to talk about practical interventions for patients who are identified as malnourished. So a big emphasis that you'll hear us talk ad nauseum about, especially when we're seeing patients in the hospital, is protein intake. So protein intake of 1.2 to 1.5 grams per kilogram per day for adults with cirrhosis is recommended. And that maintains a positive protein balance. I want to emphasize here a common misconception that protein intake to this degree does not worsen hepatic encephalopathy. Older recommendations may have hesitated in promoting high protein intake for a cirrhotic patient because of breakdown of the protein leading to increased ammonia production. That really does not happen. So does not worsen hepatic encephalopathy to promote protein intake to this degree. Prolonged fasting should also be avoided to limit that exacerbation of catabolism that I talked about earlier. And there's good evidence supporting an early morning breakfast or late evening snack in these patients to limit the time period that their body is catabolic. And then enteral supplementation should be considered. So for example, tube feeding, particularly for patients awaiting liver transplant who have failed oral supplementation. And in those patients who are critically ill, we would actually target an even higher protein target, up to 2 grams per kilogram of their ideal body weight. When patients ask, well, what am I supposed to do? How can I increase my protein intake? Well, if they have the capability and resources to do so, we often tell patients to find a protein shake that they like. And they may say, well, I've had Boost and I didn't like it. And you can say, well, there are about 20 or 30 different brands at the grocery store if you go to that aisle. And you can typically find one that you like. That you can see in some of these labels that some of them have up to 30 or more grams of protein per shake. And we encourage intake of these protein supplements. Certainly, you have to personalize their calorie needs. The energy expenditure in a patient with cirrhosis typically ranges from 28 to 38 kilocalories per kilogram per day. And so current nutrition guidelines for patients with chronic liver disease would be a caloric intake of at least 35 kilocalories per kilogram per day. How about physical activity? Well, this would be a tailored approach, certainly, in per patient. So creating a physical activity plan is important. We talked about sarcopenia earlier, the loss of muscle mass. A lot of these patients are physically inactive because of how chronically ill they are. If they continue to not use their muscle, they're going to continue to lose their muscle mass and therefore their function. And I want to emphasize that that's a big deal in these patients. In these patients who cannot use their muscles anymore, they often can't walk. We sometimes see a patient who is only 40 or 50 years old with decompensated cirrhosis. They come into our clinic, they can't walk. It takes 3 people to help them to the exam table. They're in a wheelchair. Such a patient cannot survive a liver transplant. And it's important to make sure that we're intervening well before it gets to that point. It's certainly possible and common for somebody to be too sick for liver transplant. And like I said, we want to avoid that. So creating a physical activity plan is important. Combination of aerobic and resistance training for 150 minutes a week. You know, my own approach is to start by simply asking patients if they're able to walk, 15 to 30 minutes a day to start with, before you start talking about resistance training and so forth. And this is particularly important in the sarcopenic obese phenotype, which is certainly a common condition that we would see. Can also utilize modern technology, fitness trackers, smartphone apps. Again, this goes back to the social determinants of health, but if they're able to, and if they have those resources, it can provide real-time objective tracking data for the patient. What can we do about social determinants of health? Well, while I'm not expecting that we can solve some of the underlying socioeconomic factors that led to these issues in the first place, we can, when we're seeing these patients in clinic, provide education to the patient as well as the caregiver about, first of all, just disease self-management. A lot of our patients, before we even get to talking about the intervention, need that education about what they can do to manage their disease at home. And that includes nutrition therapy. It's important to be clear on responsibilities in a multidisciplinary setting. And so if you have the capability or the resources to have a registered dietitian with you, to bring them in to this conversation as well. Advocate for resources for patients negatively impacted by social factors such as poverty, isolation, limited access to nutritious food. Obviously, this is a very broad recommendation, but it is something that we should be thinking about how we can use our positions to do these things. And then management of cirrhosis in terms of practical intervention. So when possible, the cause of their underlying chronic liver disease should be addressed. So just as an example, eradication of chronic hepatitis C, which I think is a almost universally accessible intervention at this point that can be done in a primary care clinic, does not require seeing a hepatologist, will reduce systemic inflammation. Alcohol-associated skeletal myopathy may be reversible with alcohol cessation. Management of hepatic encephalopathy and ascites. Certainly, the presence of ascites, as I mentioned earlier, leads to early satiety and limits their exercise capacity. So managing that with appropriate doses of diuretics, salt restriction, and paracentesis, just as examples. And liver transplantation. So I think that while we like to think that liver transplant cures the patients of all of their problems, many problems can persist, including frailty. And so trying to intervene before transplant to make sure we're improving frailty and sarcopenia is really critical. And this also emphasizes the need for pre-transplant interventions, what we might call prehab, so like rehab, to prevent or minimize frailty and for mechanisms to identify transplant patients before they become severely frail. So conclusions for today. Malnutrition and many other interrelated factors lead to a highly prevalent frail phenotype in patients with chronic liver disease. Frailty has been strongly linked with mortality in both the ambulatory and acute care settings, as well as the post-transplant setting. And clinicians should reassess malnutrition risk and frailty in patients with chronic liver disease, whether it be rescreening for the development or evaluating for worsening of these conditions. Emphasizing physical activity, nutrition, and protein intake are really the three big take-home points in terms of interventions that any of us can be doing when we're seeing these patients. I want to just mention that if you're in our community and want to reach us at any point, we do have a 24/7 attending hepatologist that can take your doc line calls. But importantly, I also included the phone number and fax for referrals, including outreach, and listed our outreach clinics there. We're going to be starting an outreach clinic in Grand Junction next month. That's my email and cell phone at the end. And though I have a question slide, and those are my daughters, and I think we all recognize the toy on the right because we all had it, I think, when we grew up. That is not the correct way to use it. We'll take questions at the end when we do our panel talk. But I want to encourage as many questions as possible for this session. So if you think of anything, hold on to it, and we'll do that at the end, and we'll have one of our staff walking around with a microphone. So thanks for your time, and I will now introduce the next speaker. All right. Our next speaker is Dr. John Rice. John is an assistant professor of medicine here at the University of Colorado, also a transplant hepatologist. He's also my roommate in a way. We share an office. So we do see a lot of each other. Alcoholic hepatitis and liver transplant. When is transplant appropriate is the title of his talk. I'm sure a lot of you may have questions about this. So thanks, John.
Thank you, everyone, for being here. All right. Good morning, everyone. As Avash said, I'm John Rice, one of the transplant hepatologists here. Today, my talk is alcoholic hepatitis and liver transplant. And when is transplant appropriate? This is a hot topic in liver transplantation with significant variance amongst centers and even within our group as providers. There's significant stigma and misinformation surrounding this topic. So my goal today is to provide an objective framework for providers to approach this problem. I have no disclosures for this talk. So kind of going through my learning objectives for today, we're going to start with understanding the current problem in the United States. Next, we're going to define the types of high-risk alcohol consumption and how to screen for them. Then we're going to define alcohol-associated liver disease and alcoholic hepatitis. We'll then review how to treat alcoholic hepatitis, as well as indications and requirements for liver transplant. And finally, we'll review the University of Colorado's alcohol high-risk pathway, which some of you may have interacted with at times through referrals or seen our patients. So let's start it off with a case that we've all seen before, unfortunately common. You're in clinic and you're meeting a 28-year-old male who's referred by an ER for 1 month, progressive jaundice, edema, and abdominal swelling. He has no past medical or surgical history, no family history of liver disease, denies any new medications or supplements, denies any recreational drugs now or in the past. But he does endorse that he's been drinking about a pint of whiskey per day since losing his job at the beginning of COVID. You start by getting some labs. As you can see here, he has some macrocytic anemia with slightly low platelets and an elevated white blood cell count. His LFTs are elevated in a mixed pattern with AST greater than ALT and a mixed hyperbilirubinemia. His INR is elevated as well. Get an ultrasound which shows an enlarged liver with a heterogeneous ecotexture, nodular surface, portal vein reversal of flow with recanalization of the umbilical vein and a large spleen with some moderate ascites. Putting it all together, this presentation is consistent with alcoholic hepatitis, which we've all seen before. I know that subjectively, we've felt the rise in number of cases that have occurred since COVID, but let's look and see if there's any objective data that discusses this. So as you can see, there was a rapid rise in alcohol sales at the start of the pandemic, which has unfortunately not come down to pre-pandemic levels. There's a lot of reasons for this, including unemployment, isolation, lost loved ones, exacerbation of the mental health crisis, unrestricted or unstructured work environment, amongst many other factors. In a survey by the National Institute of Alcohol Abuse and Alcoholism, around 60% of people increased their alcohol consumption since the start of the pandemic, with only 13% decreasing. However, cirrhosis-related mortality has in fact been on the rise over the last 2 decades or so. In young people, this is almost exclusively driven by alcohol-associated liver disease. It seems that the pandemic only accelerated a growing health public emergency. The rise in alcohol-associated liver disease has correlated with a rise in transplant for alcoholic hepatitis. The graph on the left shows the rise in alcoholic hepatitis listings, and the right shows the number of deceased donor liver transplants for alcoholic hepatitis. One thing to note is that the rise does predate the pandemic as well. And this is likely because early liver transplant for alcoholic hepatitis was not a standard of care until proof of concept from a New England journal by Mathurin et al. In 2011. So this has been a rise that's been occurring for numerous reasons, but there was definitely a significant rise that occurred at the start of the pandemic, which again, we're all feeling now. But what type of drinking leads to alcoholic hepatitis as we close in on the social happy hour coming up this afternoon that I'll run for you? So here's a reminder of a standard alcohol unit looks like. Beer is a 12 ounce at 5% alcohol. So unfortunately, the 16 ounce IPA at the local brewery is more than 1 drink to your liver. Also for wine, that's a 5 ounce glass of wine. So there's about 5 glasses in a bottle of wine and about 1.5 ounces 80 proof alcohol. So as you can see, these standard units are going to be used to kind of as a framework for discussing number of units going forward. But what patterns of drinking actually lead to are actually worrisome? So here's some high-risk alcohol consumption patterns, specifically starting with binge drinking. So around 140 million people in the United States drink some amount of alcohol. Of this, around 67 million drink in a binge drinking pattern, which is defined as consuming 5 or more alcoholic drinks for males or 4 for females on any occasion. Heavy drinking, which is an important one when we're talking about liver disease related to alcohol or alcohol-associated liver disease, is having more than 4 drinks on any day or 14 in a week for male, or 3 drinks on any day or 7 in a week for female. So in general, it's thought that keeping below this amount will not lead to alcohol-associated liver disease. However, there's technically no safe amount of alcohol, and further studies are coming out looking at links to cancer and other disorders that are associated with any amount of alcohol consumption. So minimizing is important. So when do people have a problem with alcohol? So we used to call this alcoholism, but the term is now alcohol use disorder, which is meant to destigmatize and encourage providers and patients to treat as a medical diagnosis. Unfortunately, around 15 million Americans will meet the criteria for alcohol use disorder, and 1 in 3 Americans will meet this diagnosis at some point in their life. Studies have shown that around 35% of patients who have an alcohol use disorder will have some amount of alcohol-associated liver disease in their life. So as you can put the math together, that's a lot of people who have some amount of alcohol-associated liver disease. So this is a busy slide, but here are the symptoms of alcohol use disorder. There's a range of symptoms and life impacts that are meant to identify disordered use as well as tolerance and dependence. The number of symptoms defines the presence and severity of disease. So alcohol use disorder is diagnosed or defined as having at least 2 positive responses. This is then quantified as mild, moderate, and severe based on the number of symptoms. Given the number of questions, this can be obviously a time-consuming process, and that's why several shorter screening questionnaires have been created. One of the more common one is the CAGE questionnaire. So this is 4 questions. Have you ever felt like you should cut down? Have people annoyed you by criticizing your drinking? Have you ever felt guilty about your drinking? And have you ever had a drink first thing in the morning? A score of 2 to 3 indicates high suspicion for alcohol use disorder. This test has a sensitivity of 75 to 95% and a specificity of 85 to 97% for detecting alcohol use disorder. And a positive test should prompt a more thorough screening. Another easy screening tool is the Audit C, which has been shown to be more sensitive than CAGE. This questionnaire quantifies how often and how much a person drinks, as well as how often they binge drink. Cutoff score for Audit C is usually 3 points for women or 4 points for men. This test has a sensitivity of 83% and a sensitivity of 90% for identifying alcohol use disorder. Again, a positive test, should lead to further evaluation and a full evaluation. So some of you might think, how does alcohol consumption, this type of alcohol consumption, actually lead to liver disease? So obviously a busy slide here as well, but briefly, alcohol-associated liver disease is a spectrum, which includes steatosis, steatohepatitis, or inflammation related to it, cirrhosis, and HCC. As you can see on the left, patients move throughout this progress, sometimes in a linear, but there is potential to move back and forth if it's early in the process and caught early. So this occurs by the liver metabolizing ethanol to acetaldehyde, which leads to immune activation, glutathione depletion, lipid peroxidation, and mitochondrial damage. This leads to inflammatory response, which is further propagated by alcohol-induced gut permeability that leads to changes in gut microbiome and gut translocation. The inflammation activates fibrogenic cell types, which lead to fibrosis and eventually cirrhosis. The injurious effects of alcohol in the liver is not dose dependent, but there is a threshold beyond which risk occurs, which is usually this heavy alcohol use, which we talked about before. Progression between these different stages is very patient level. So things like genetics, sex, ethnicity, obesity, and concomitant liver disease all affect how fast you move through this. A common question is when patients come in, why do I have cirrhosis when my drinking buddies only drink, they drink twice as much as I do? And I always tell the patients it's too much alcohol for your liver. It's also a framework for discussion around alcohol use disorder as people try to minimize their use. But it's important to understand that everyone is different and there are thresholds for everyone is different as well. I do want to note the diagram on the left, which shows a green arrow between steatohepatitis and steatosis, that there is around 20 to 30% of patients who do not have cirrhosis at the time of diagnosis. I cut out a couple slides in here, but basically this is a very common question of do I have cirrhosis or not? And it's a question that honestly at the time of diagnosis, if you have steatohepatitis, is not important because they both can lead to decompensated liver disease. This is a question to be answered later on if the patient does not recompensate with sobriety and end up in that 20 to 30% range. So while it is important long-term, in the short term, it is not necessary for treating these patients. So we're all here to kind of talk about alcoholic hepatitis for this talk. So what is it? This is an inflammatory process that requires a minimum consumption of greater than 40 grams a day for women or 60 grams for men, which is around 3 to 4 drinks per day for greater than 6 months. The onset of jaundice should be less than 8 weeks with an AST greater than ALT ratio of 1.5 and only a moderate elevation in liver enzymes less than 400. So if it's higher than this, you should think about secondary processes. You also need a bilirubin greater than 3. So we'll kind of review each of these management and outcomes. I actually cut a couple slides on nutrition, which is near and dear to my heart as well, as Dr. Kalra just talked about it. But those protein and calorie goals are evidence-based and have a mortality benefit potentially in this population as well. So early intervention is important. So one of the mainstays for treatment for alcoholic hepatitis is treatment of the underlying disease, which is alcohol use disorder. Treatment of alcohol use disorder includes both counseling and medications. I won't go into the specifics because it's definitely beyond my skill set. It requires input from a mental health provider. However, when we do require counseling for transplant, it is at minimum individual counseling and not mutual aid societies like AA. Beyond that, we commonly defer to addiction provider since there is no proven superior modality. One thing that is important to note is that patients admitted with alcoholic hepatitis, early rehab has significantly reduced the risk for hospital readmission, relapse, and even death. And so early addiction counseling is really important. It might seem trivial, but getting them involved early and getting these people in the counseling, specifically inpatient counseling, has been shown to help these patients significantly. The other thing to note is that some recent studies have shown that incorporating alcohol use disorder treatment with liver care has improved outcomes as well. So these alcoholic clinics are kind of popping up, and there's a couple different models, and one of which we'll be bringing to the university at some point. So more TBD, excitement for the future. So there is a role for alcohol use disorder pharmacotherapy, despite the adverse risks events in patients with alcohol-associated liver disease and decompensated cirrhosis. So the FDA has actually approved a couple, disulfiram, naltrexone, and comprosate for alcohol use disorder. However, none of these are actually approved for advanced liver disease. The only one that's shown efficacy is baclofen, which was a single center study that needs further investigation. But if you're looking for evidence, there's the one there, but is not FDA approved. More research is needed, but I definitely strongly encourage people to not be afraid of these medications and to encourage people to ask interest in these patients or getting them into, because you'll get a lot of messages from providers who are taking care of these people in the mental health capacity. And in the right setting, they can be effective, but you just have to be careful in decompensated cirrhosis. And in fact, I'd probably avoid them mostly in that population. So how do we screen for patients? Now you've gotten them into counseling, you've gotten them on medications. The phosphatidylethanol, the PEth test, is kind of a mainstay of what we do here at Colorado for monitoring these patients. So PEth is a phospholipid that's formed by reaction of phosphatidylcholine with ethanol in the red blood cell membrane. So this is why we call it the A1C for alcohol. It has a half-life of 10 to 14 days, and it will remain elevated for 2 to 4 weeks, but sometimes longer with chronic repeat heavy use. A cutoff of greater than 20 has been shown to show a high sensitivity and specificity for heavy consumption. And something that will come up, came up this last week in eval clinic, but a positive test really only comes from a blood transfusion. You can theorize that if this is on the blood, that if you get blood from someone who drinks alcohol in a heavy sense, you can have a positive test. And so that is really the only false positive, not baking with alcohol, not NyQuil, not any of those things that will come up. Really, blood transfusion is the only one. So it's really good for kind of cutting through the discussion and saying, positive, it's positive, and you kind of have to move on with that fact. But it's not meant to catch patients. I tell all my patients that this is meant to elicit a conversation. And honestly, some people will endorse use after I tell them what the test I'm going to be doing is, but some people still continue to deny, which is an ongoing problem as well for their access to transplant if needed. So what can we do medically to treat for these patients outside of treating their baseline alcohol use disorder? And so steroids, as many people know, is kind of the mainstay of what we have to offer, which is not much at times. So patients who have a MADRE discriminant function that's greater than 32 are candidates for steroids. Modern evidence comes from the STOP-AH trial, which showed a non-statistically significant decrease in 28-day mortality with prednisolone 40 milligrams daily. Further future meta-analysis, though, however, has showed some statistical significance. But one thing to note is that there is no benefit outside of the 28 days, which there's a lot of theories behind that regarding who goes back to alcohol and other reasons. But there is no significant benefit long-term. The power of this is also increased through using patients with a MELD of greater than 20 or 21 or greater. So it's important to use that in conjunction with your MADRE discriminant function when deciding on risk-benefit profile. And while this evidence is weak, I think it is okay to start steroids in patients who meet criteria. But remember that patients with infection, GI bleeding, renal dysfunction are all excluded from this study and shouldn't be contraindications to use. Another thing to remember is that people who had treatment with prednisolone, there was twice the number of infections. And so remembering a low threshold to stop if that develops. But as you can see here, there's only so many options. And there's another score that we can use, which is the allele score, to decide when it's not working and we should stop harming the patient and stop the medication. So outside of the discriminant function, the allele score is the other part of this equation. It uses age, albumin, renal function, prothrombin time, serum bilirubin, as well as change in bilirubin at day 7. However, more recent analysis showed that day 4 is acceptable, which further allows me to say, let's stop this after 4 days if it's not working, so the harm is reduced. A cutoff of greater than 4.5 predicts poor prognosis and lack of response to steroids, which should prompt discontinuing. Non-responders, in fact, had a 25% 6-month survival compared to 85% for responders. So this is a big deal, not only for obviously finding medication that might be helpful, but just understanding the risk of this population for steroid non-responders. And this will kind of lead to what we'll talk about with transplant. And then, therefore, in patients who are not, as I said, therefore, patients who are not eligible or who don't respond, transplant is important for discussing this. So there's kind of the crux now that we've got to the point. So these are sick patients. They have not responded to our limited standard of care. You know, who should we refer? And so given patients can potentially avoid transplant and recompensate, the goal is to defer transplant as long as possible while supporting them medically and simultaneously treating their alcohol use disorder. However, not all patients will recover. And so who should we consider early transplantation for? Since we don't have great scoring for this, we don't have great ways to predict this. So there was a consensus conference determining several criteria. They recommended considering patients who have severe steroid refractory or intolerant alcoholic hepatitis. These patients couldn't have any previous knowledge of their liver disease and couldn't have any concomitant substance abuse disorder. Most importantly, they needed to have a favorable psychosocial profile, which we'll review in a second, which obviously is a very nebulous term. So the big question that always comes up on our phone calls on DocLine or from in our hospital is how long should these patients be sober? So historically, we always thought about the 6-month rule. This was actually to provide time for liver function to improve and to avoid transplant. There's no evidence that 6 months reduces relapse, and it actually encourages dishonesty and does not encourage treatment for alcohol use disorder. So patients potentially would lie to say, oh, it's actually been 6 months, but it might have been sooner or may have benefited from more intensive treatment. The most important thing, I think, is that it's an unrealistic barrier for transplant. 75 to 90% of deaths occur within the first 2 months. And so it's important to identify patients that won't go back to drinking who would benefit from a transplant, given the high mortality in this population. However, since time doesn't predict relapse, what factors should? So they've looked at this and they've looked into protective and negative factors, which is a lot of things that we kind of talk about when we're in clinic or at eval of what are good and bad. And our psychology and social work team help us kind of put these into categories, and we kind of have to weigh that scale together. So protective factors include insight into their addiction, social support, substitute activities for alcohol addiction, improved self-esteem or hope, and perception of negative consequences of their alcohol use. So these are all things that are protective factors. Negative factors are psychotic disorders, personality disorders, family history of alcoholism, alcohol dependence diagnosis, repeat attempts at rehab, unrelenting substance abuse despite physical and social consequences, as well as social isolations. Thinking about these are kind of used later on when we talk about our alcohol high risk pathway and how selecting patients that we try to obviously maximize protective factors and minimize negative factors. As with all things, they created a score called the SALT score. So this is used to predict relapse after transplant. It uses the quantity of consumption, failed attempts at rehab, alcohol-associated legal issues, and a history of non-THC substance abuse. And a score of less than 5 actually has a 95% negative predictive value for sustained use post-transplant. So it could be helpful. I think we don't always use the score. I haven't really heard this come up in our committee, but all these things definitely come up when discussing this. So, once we've picked a patient, so why do they actually benefit from this? So here's the landmark study for early liver transplant for severe alcoholic hepatitis. and inclusion criteria included severe alcoholic hepatitis with non-response to steroids. They required that the event was the first liver decompensation, which comes up a lot in these conversations, as well as close social support and absence of severe psychiatric disorders. This actually led to a screening of less than 2% being included for the study for transplant, so highly selected population. However, the results were remarkable that it showed a 6-month survival of 77% in those that were transplanted and only 23% if they weren't transplanted. So a significant mortality benefit with this. Another important study was the Accelerate AH trial, which is a retrospective multi-center study for early alcohol transplantation for severe alcoholic hepatitis. The median length of sobriety was only 55 days, and the median MELD was 39. So these are really sick patients. So mortality was actually 70% at 6 months if these patients weren't transplanted. So they actually found a 94% post-transplant survival at 1 year and 84% at 3 years. But I think the big question that people have in this population is not the medical. We know how to take care of transplant patients. We assume that we can take care of these patients afterwards and they will survive. The question is, do they go back to drinking? So they actually showed that only 10% at 1 year went back to, and this is a high-risk population, obviously, went back to sustained alcohol use at 1 year and 17% at 3 year with a median time of 25 months. So, not all these patients are actually going back to drinking. However, harmful excessive drinking led to 32% of these patients developing cirrhosis within 4 years. And the median time to death happened in, or two-thirds of these patients died from related to their cirrhosis. And the median time to that was 1.1 years from the diagnosis of cirrhosis. So if these patients do go back to drinking heavily, they get sick fast and can die quickly. So it is very important to treat alcohol use disorder after transplant to continue to take care of these patients to prevent relapse. So I always tell patients we're treating two things simultaneously here. I'll even joke sometimes transplant's the easy part and alcohol use disorder treatment's the hard part. But here at Colorado, we have some requirements specifically around candidates must admit their use. They must deny significant, if they deny significant use and they don't have alcohol use disorder or they don't have insight into it, they need to demonstrate this insight and commitment to lifelong sobriety. They need a lack of coexisting major uncontrolled psychiatric disorders or other untreated addiction. They need to be able and willing to engage in the evaluation process. This does come up sometimes on our inpatient side where patients are unfortunately too confused or intubated or too sick to interact. So we can't really have a psychosocial evaluation when someone can't. Even if they have supportive family advocating for them, they have to advocate for themselves as well, unfortunately. And historically, patients were required to leave the hospital to initiate alcohol counseling and screening. However, as we saw before, a lot of these patients will die before or can't get out of the hospital. So, what are we supposed to do for those patients? This leads us to kind of the UCH alcohol high-risk pathway. And so this uses a lot of those same requirements from before, but more specifically, there's no sobriety length. So this can be done during an index admission and in the hospital. In addition to what was required for alcohol use disorder, they can't have any prior relapses, no major complications of their alcohol use disorder in general. They need the support of their advocating hepatologists, and they need unanimous agreement amongst the transplant committee. After transplant, we do monitor these people. This has been a flux recently, but they used to see a provider every month afterwards, as well as get monthly PET tests afterwards. We've backed off on the amount of us seeing them every time, but they still do really well. And in the initial cohort, I think of like 30 some patients, there was 90% sobriety at 1 year, which is kind of consistent or even better than some of the national studies. So I think this slide kind of gets to, what can you do to help these patients? I think it's clear that, these patients would benefit from transplant in the select population. But identifying patients early by screening for alcohol use disorder can prevent them from getting severe disease and requiring transplant. Get a detailed alcohol history and document the protective and negative factors that was discussed before that helps communicate with our team. Discuss alcohol use disorder like a medical diagnosis. Discuss there is no safe amount and they should quit immediately. Offer resources for addiction medicine and counseling to help get them into counseling, treatment, and medical therapy. One thing that I think comes up a lot is people say, oh, they're drinking. Why do I need to check a PET test? I think it's important to check a baseline to show trajectory if they get sick in the meantime. So check one at baseline and then monthly. And then medically start steroids in appropriate patients and only continue them when they're indicated. And I think the bottom is kind of the key to the slide. While it's hidden on the bottom, early referral for transplant is always appropriate. I don't want anyone to feel like, oh, I'm nervous to send them too early. Send them early and let us kind of get the care they need. And if it's too early, we'll evaluate any barriers to transplant, any psychosocial problems, and get them back to you and ready for next time if they do get sicker. So I think early transplant's important, and always reach out anytime. So thank you again, everyone. And obviously we can talk at the end about, any questions. Thank you.
Okay, I mentioned that Dr. Rice and I are roommates, and Dr. Wieland is our neighbor, actually, in our office, so we're a close family. The next talk is going to be focused on fatty liver disease, and I'll leave Dr. Wieland to go over the nomenclature with you. She's an associate professor of medicine in our division. She's also co-director of our multidisciplinary fatty liver clinic, and she's a Rocky Mountain Highlights course director, part of the course director alumni. She passed the torch over to me and Blake, so we appreciate her guidance as we put together this year's conference. Thanks, Amanda.
Wonderful. All right, thank you so much. And I do want to thank the new bright and shiny course directors that have set up a wonderful conference. I love the new location. It's convenient for me, which should always be the goal of everything. So welcome. Thank you guys again so much for inviting me to come. And I have been tasked today with talking about what used to be called non-alcoholic fatty liver disease, or NASH. So it's 2023. What can we offer for the treatment of NASH? And now, MASH. Very exciting. Were you guys aware that the name had changed? Is that new to you? All right. Well, that is the late breaking new news of fatty liver disease, is that we changed the name. No disclosures. So educational goals today. We're going to review the definitions and the new nomenclature of metabolic dysfunction associated steatotic liver disease, or MASLD. Just rolls off the tongue, formerly known as NAFLD. We're going to discuss the spectrum of metabolic liver disease, and including MASH, the more concerning form, with inflammation and fibrosis. We're going to review the guidance for screening for high-risk patients with MASH with fibrosis, and then we're going to outline some treatment strategies. What do we do in 2023? All right, so the new nomenclature. So I'm still unsure. One thing, I'm probably going to say it wrong about 50% of the time during this talk today, and I probably have not updated all of my slides. So you can go to the AASLD website and see a lot of very excited hepatologists talking about this new nomenclature. So the big punchline, so steatotic liver disease, which used to be called fatty liver disease. So we've removed the word fat and moved to steatosis. So the idea is that that broad umbrella term of steatotic liver disease, it used to just be alcohol and non-alcohol. So defining the majority of what was going on by what it wasn't didn't make a ton of sense. It stigmatized to some of the patients when they really, weren't drinking. So it added barriers. So in trying to get a better idea of the spectrum of what causes steatosis in the liver, you can see that they've got several different categories now. We've just heard all about alcohol-related liver disease and how that leads to steatosis. There's also these kind of NOS causes there, and cryptogenic. But we're going to be really focusing today on the metabolic side of things. You can see they also have this category of MET-ALD, which is basically metabolic disease and alcohol on a spectrum. But again, we're going to be focusing today on metabolic dysfunction associated steatotic liver disease, or MASLD. So I'll probably refer to it as metabolic liver disease just because that's too many words for me. So again, we got fatty liver disease is now steatotic liver disease. Non-alcoholic fatty liver disease, or NAFLD, is now metabolic dysfunction associated steatotic liver disease, or MASLD. Say that 10 times fast. And non-alcoholic steatohepatitis, or NASH, is now metabolic dysfunction associated steatohepatitis, or MASH. So why is MASLD important? You guys are probably very aware that there is a lot of fatty liver disease out there. It is the most common cause of abnormal liver tests in the Western world. There's high risk in those with metabolic dysfunction, thus the name. Obviously, diabetes, obesity, insulin resistance, all of those risk factors. Up to a third, if not more, of our population is affected by metabolic dysfunction and the liver ramifications. 1 in 5 of those with metabolic fatty liver can have NASH or MASH. See, you guys can count every time I mess it up. 1 in 25 of those can progress to significant liver issues, including fibrosis and cirrhosis. So big deal. And it really is MASH, not just the steatosis, that's associated with this increased mortality. So the spectrum, to kind of get an idea of what we're talking about. So, at the heart of this, there's fat accumulating in the liver. And that's really just bland steatosis. And that's what most people, when we see fat in the liver, have. But the subset has the fat leads to inflammation. So it's toxic fat, leads to inflammation. That inflammation, which technically has to be defined histologically or with a biopsy, but it's crazy to biopsy millions of people. So we have to use all these other markers to assess for that. And so that is the diagnosis of MASH, where you have fat inflammation that can lead to scarring. And that's what can eventually lead to cirrhosis and liver ramifications. So the amount of scarring is on a spectrum, anywhere from 0 being no scarring up to 4 being advanced scarring or cirrhosis. So blue is bad. I couldn't give a talk about the liver without pictures of liver biopsies, because that is why I'm a hepatologist. I think they're very pretty. I think these should be framed as art, although unfortunately the prettiest ones are often the worst involved. So MASH with fibrosis, again, is what's really associated with higher mortality. You can see they're all-cause mortality. So you got on the bottom line there, 0 up to 4. So that's moving towards cirrhosis, just all-cause mortality. A lot of this is actually cardiovascular disease and all those other metabolic issues. And then you can see liver-related mortality. Liver decompensations, cancer really escalates and jumps off at stage 3 and stage 4. So that's what we really need to find from the liver side, although everything along the spectrum is important for the health. So getting into the meat of it, how are we going to approach MASH in 2023? So it's a massive problem. So number one, we got to find these high-risk patients. We got to stop ignoring it. I think that's actually been something that's happened over many years now, that it's really recognized and finding these high-risk patients. So we want to screen for fibrosis. That's really the heart of that. The second thing is we want to treat these high-risk patients. And it really comes down to weight loss. Weight loss is key in these patients. And whether that's through, the heart of it is going to be lifestyle, really talking with our patients about that. A lot of this is just counseling and motivating. You need to motivate them and destigmatize it and really kind of empower them. Considering bariatric surgery is really important. And then all these new tools. There's a whole other talk that can be done on new pharmacologic treatments for weight loss. And I'm sure you guys have heard of semaglutide, the new kid on the block, and all of the GLP-1s. And I'll be mentioning those throughout this talk as well, because they are really important in this area of metabolic dysfunction. So diabetes management is really moving towards endocrinologists have really embraced that when outcomes of the patient is really how they should pick their diabetes medicines. And so for MASH and MASL, they really need to pick agents that treat that underlying issue. And so we'll highlight that as well. And then I'll also touch on some future therapies that are going to target MASH itself and try to actually get to the core of that. We still are lacking in that area. So let's talk about identifying these high-risk patients. So the AGA came up with this really nice screening pathway to find the fibrosis. So this is really targeted for those that are on the front lines of caring for patients. So it's going to be primary care docs, endocrinologists, GI, obesity specialists. So how do they think about this in their busy day? So in general, it's a step-by-step process. You want to identify those at risk. So it's going to be people with metabolic risk factors. It's going to be diabetics, those with incidental steatosis, mild elevated liver tests. They need to think about it. Then very basic, simple history and labs, and then calculate these non-invasive scores. And then that puts them in these risk buckets and really kind of organizing it into these buckets where you can follow the patients and get them to the right places is really what's key. So we're going to run through this quickly with a patient. So this is a 45-year-old Hispanic female. She's referred, noted to have abnormal liver chemistry tests. So you can see there she's enriched in all the metabolic issues, elevated BMI, diabetes, hypertension, has a family history of her mother with cirrhosis. And so you can see her labs have the kind of mild hepatocellular injury. Platelets are a little on the lower side, but nothing that really on itself would be that striking. Imaging shows a steatotic liver, but otherwise no signs of portal hypertension or advanced liver disease. So what are we going to do next? So going to our handy algorithm, we would want to calculate this non-invasive test. And the take home is the FIB4, cheap, easily, readily available. There's other proprietary tests out there, but really at the heart of it, to make this easy and simple and to just get this on the radar and find these higher risk patients, FIB4 is the way to go. So FIB4, 4 values. I love things that are simple: AST, ALT, age, and platelets. And then with that, you get low risk, intermediate, and high risk. You can see I just found a quick and easy calculator on the internet, and this patient ended up having a FIB4 of 1.64. And so that puts her in intermediate risk group. Of note, if you guys are using Epic at the university, you can just do .fib4 and it calculates it for you, and you can just put it in your note. It's quite beautiful. Didn't work for a long time, but now it does. So that's quite nice as well. So getting back to our pathway, so we have our high risk patient, and then she's got that intermediate FIB4. And so the next step there is to do a liver stiffness measurement. So what is liver stiffness measurement? So this is what is called vibration controlled transient elastography, is the most widely available, also known as FibroScan. And so this is the report you get from a FibroScan. Basically, a FibroScan is a form of an ultrasound, more or less, that's specialized, where you just put the probe on the side and they get a little liver tap, and it sends a vibration through the liver, and that vibration gives you an idea of the density. So this actually gives you a physical measure of the stiffness of the liver. And the key number we look at is that E score, or elasticity score, or the KPA. And so back to our nifty algorithm, you can see that the liver stiffness measurement here, hers of the 17 puts her above 12, which is in a high risk group. The other number to remember here is anything above 8 kind of falls into that intermediate or high risk group and requires a little bit more digging in general. So again, steatosis, FIB4, intermediate, high risk. So she is sent to hepatology. So what do hepatologists do? We biopsy. And I will say the decision to biopsy or not, is really case by case. We in general favor a lot of non-invasive things, but in this young patient, there were some other factors going on. It seemed very important to get a really solid baseline to know her degree of fibrosis. And so she did have biopsy confirmed steatohepatitis, and she was, had been confirmed that she really had no alcohol. And so that would be MASH. And the fibrosis level was also found to be in this advanced stage 2 to 3 out of 4. So what do we do now for this lady? And this is really where things are in evolution. So what are we going to do for this young woman? So again, the cornerstone of all of this is lifestyle changes. And it's important. It takes time, but this across the whole spectrum, again, really empowering patients. And, I really try to keep it very broad, and again, just try to, it's that fine balance where these are often people that have struggled with weight. It's part of the metabolic dysfunction. And so you want to give credence to that it's really hard, but then they also need to realize a lot of it is on them. It's not fair, but they need to learn to really how they can work with the metabolic dysfunction. So weight loss is the key for the majority of these patients. And even this weight loss of the 5 to 10% really has meaningful improvements in histology. Maintaining that is hard. So the goal is really to have these long-term healthy habits that they can stick with, and exercise as part of that to maintain that weight is also really critical and important. So other things to consider: bariatric surgery is a very good tool for certain patients that have really failed to maintain weight and have other barriers. And in general, the indications are the same as for the obesity in general. It hasn't been shown to be specifically a treatment for NASH and fibrosis, but we do know that after bariatric surgery with successful weight loss, a very large percentage will have reversal of fibrosis. So it really can be a great tool. One caveat with bariatric surgery is if they have advanced fibrosis and cirrhosis, it can be okay in selective centers with experience, but as soon as they have portal hypertension, it's contraindicated. So now pharmacologic treatment options is another thing to think about. And this is an area, again, that's expanding, and really there's so much developed in this. And I think this is the new wave of really changes in healthcare. You guys, I'm sure, have all heard about Ozempic and its role. So these pharmacologic weight loss options really can have benefit in a lot of patients. So using those tools and getting patients to, obesity management specialists, empowering PCPs to get comfortable with weight loss medicines, these are all important tools. And my role as hepatologist is really letting them know that they should consider these for you. I don't think most hepatologists or gastroenterologists are going to embrace being the prescribers of these. Some selectively might, but it really is getting it back on the ones who are managing the metabolic disorder. So, and again, for diabetics, really picking the medicines that have efficacy in MASH is really essential too. There are no FDA medications for MASH itself, but there are clinical trials ongoing, and we'll talk about some of those as well. So this is, again, back to that AGA. They have a really nice summary here, just kind of when you put your patients in the buckets, what does that mean for how you're going to manage them and what can we do? And things to highlight here, again, as I said, lifestyle across the board important. Weight loss, yes. They have some caveats about how aggressive to be about weight loss there across that spectrum. Pharmacotherapy for NASH, you can see that, yes, the interesting thing there is that we don't have any. So I think it's funny they have that on there, but I'm going to mention a couple that are in the ASLD guidelines, but when those get approved one day, which I'm cautiously very optimistic, there is a need, especially in these intermediate and high risk group. That's why we got to find them now. Diabetes care. This is something to me that I talk with my patients about. So diabetes care, the majority of it's done in the primary care setting. Endocrinologists, I think, are a little more aware of this, but really empowering PCPs, if they can, to think of these other agents. Even if they're controlled on metformin, that might not be the best med for them. Metformin has never been shown to be helpful in NASH and fatty liver. So seeing if they can get them a GLP-1 or even pioglitazone in certain cases, which is kind of a old school and not used as much, but does seem to have some benefits in diabetics with fatty liver. So really mentioning that to patients and saying, talk with your PCP about that is something I always try to do as well, that there might be better agents for them based on their risk factors. So we're talking about for MASH specifically, again, nothing approved now. A couple of things that we'll touch on today: vitamin E, the data on pioglitazone, and a little bit on the GLP-1s, and a couple other things on the radar. So when we talk about the ASLD guidelines, do have some caveats about a couple things with vitamin E and pioglitazone. So vitamin E was studied, it's getting old now, 2010, so it's been a while, 13 years ago. When it was a very well done study, the Pivens trial, and they looked at vitamin E. And overall, vitamin E did show improvements in the NAFLD activity. So it more or less resolved NASH and the inflammation, but didn't improve fibrosis. So it really didn't catch on. It was only studied in non-diabetics, non-cirrhotics. So the caveat is if you have somebody with biopsy-proven MASH and they've got active steatohepatitis and they have some fibrosis, this is something to consider. There are some risks with it. It has some all-cause mortality that's not well understood, but overall fairly low. Prostate cancer risk seems to be real. So a family history of prostate cancer in male patients, you want to talk about the risk benefits. But I have a few patients that I'll mention, you can try vitamin E. The dosing was 800 in the studies. Some people favor just giving the 400 as something to try. So it's something to consider. And there's some newer studies that were a little bit flawed that they were retrospective, but they showed that patients on vitamin E had decreased need for transplant. And so it can be considered in some patients. I don't like it as this idea of, just take vitamin E and don't do the lifestyle thing. So it's all about making sure that they're doing the lifestyle things as well. And pioglitazone. So PPAR gamma, so an older medication. So in general, again, this in these older studies and trials clearly improved inflammation, but didn't improve fibrosis. The big issue with pioglitazone was that it increased weight. And so with that being a side effect with it, it really fell out of favor. Although when you look at the weight, it's actually that the weight goes from being the visceral bad fat to more the peripheral fat. So it can be an option as part of their diabetes regimen. So it's something to mention again that if they're on pioglitazone or considering that for some patients, it's dirt cheap too, which can be a good thing in our healthcare system as well. So, but that weight gain has really always made it one that is not as favored. So in general, these are the ones that are mentioned in the ASLD guidelines and can be considered in these very selective subgroups, but pretty limited in the true efficacy, especially if somebody has more advanced fibrosis or cirrhosis, so we need something better. So this is meant to be a busy slide because it's showing that it's busy. There's a lot going on out there as far as clinical trials for fatty liver disease, multiple agents under investigation across that whole spectrum, phase 1, 2, 3. And this is like a billions of dollar market out there. So there's no lack of work going in. Unfortunately, due to the complexity of the pathophysiology of metabolic dysfunction, there's so many targets to hit that over and over again, we see things just aren't meeting the clinical outcomes. And so there's a lot of X's on here. I know it's hard to see because it's so little, but basically as soon as something's looking good, it really doesn't come to fruition. The most recent one to fall is obeticholic acid. Unfortunately, really, in the end, the FDA just did not think the data was robust enough despite a couple submissions to the FDA. So that's also been halted as a phase 3. So this is a little bit simpler, but still busy of currently ongoing phase 2 and 3 investigations. And this changes so quickly. I've highlighted ones here that are under currently ongoing at the university. So it's very dynamic which trials we have coming and going. So we're always open to hearing about interested patients, motivated patients. So always send them our way. But these are some that we have right now. I'm going to highlight a couple real quickly just about the phase 2 that has shown some promise in these, including saroglitazar and then semaglutide, GLP-1. So saroglitazar, so this is a PPAR, but it's an alpha gamma agonist. And so depending on which receptors the PPARs act against, there's different side effect profiles and benefits. So the alpha gamma is positive as far as steatosis and insulin resistance, so it's very promising. The phase 2 trial showed a lot of positives as far as improved liver tests, decreased liver fat, insulin resistance, and it had a very positive atherogenic dyslipidemia. So it was very positive in a lot of factors, and it was safe and well tolerated. This is actually approved in India as a treatment for NASH. So this is something, or MASH, and right now the phase 3 trial is enrolling and ongoing. So New England Journal came out with the placebo-controlled trial for semaglutide, so GLP-1. So again, phase 2 trial, very promising in the this was fibrosis 1, 2, and 3. The primary endpoint of this was resolution of the inflammation, the MASH, and no worsening of fibrosis. And it met that primary endpoint. You can see there the higher dose there had 59% that had resolution of the inflammation compared to 70% placebo. Of note, that B box over there, it did not show significant improvement in fibrosis. So I think that's really the limitation of semaglutide. And in general, that's the issue, is that we're not seeing both the inflammation and fibrosis improve with one agent. That's probably because there's such a so many mechanisms going into this. The separate study that was done in cirrhotic patients was a negative study. It really didn't show any benefits, probably because fibrosis is the driver. So this gets to this issue of this new idea that's coming out of combination therapy. And so this is where you synergize and optimize these histologic benefits. And so you can think about it as if you have somebody with non-cirrhotic NASH, you need to target the inflammation and maybe some antifibrotic. But if you've got these patients with cirrhosis, then you really need an antifibrotic potential and the inflammation. So it probably depends on where they are in their disease and using more than one agent. So right now, the phase 2 study going on for the GLP-1 semaglutide in combination with FXR and an ACC inhibitor is ongoing. The phase 2 was found to be safe and effective, and the phase 3 trial is ongoing, and we're enrolling this at university. So conclusions. So how to approach NAFLD in 2023. Or MASLD, dang it. So you identify MASH with significant fibrosis. So remember, FIB4 greater than 1.3, liver stiffness measurement greater than 8, following that very nice algorithm. We need more aggressive monitoring and management in primary care, referral of these higher risk patients to the tertiary teams, educate the patients, really stress, empower them, multidisciplinary approach to weight loss, have the PCPs and endocrinologists target their diabetes regimens, and then consider clinical trials and await these novel agents. Thank you very much. Okay. Thank you.
Have a seat. Have a seat. Yes. All right. We're going to start off our panel discussion, first of all, inviting Dr. Rice and Dr. Whelan to stay on stage. So before we go into sort of the pre-prepared poll everywhere questions, just wanted to open it up to the audience to see if any of you had questions for any of the three of us to start with. And Lindsay has a microphone here that she can bring to you. So raise your hand if you would like. No worries if you also would not like. We'll keep an eye out. We'll go into some of the questions. For those of you who were not here earlier, if you would like to be involved in participating in the question, you can connect to the QR code at the top, or you can also, probably the easiest way is to send a text that's CU-HEPGI to the number 22333. All right, so generally what is an appropriate protein intake goal for a cirrhotic patient identified as frail? Obviously, this is going back to my talk from earlier. And as the answers come in, it looks like the majority of you are correct. The answer is 1.2 to 1.5 grams per kilogram per day. The other two options are too low for most patients, and I'm glad that no one picked D. So you heard the soapbox comment earlier that protein intake does not worsen hepatic encephalopathy. So good job. All right, it's just more of a fun question. I told you it was a fun fact, but see if you remember. Dr. Thomas Starzl performed the world's first successful liver transplant. In his youth, he had planned on becoming a teacher, a priest, a mechanic, or a dentist. Huh? Yeah, exactly. All right. So yes, it was he intended on becoming a priest, but fortunately for the three of us on stage, he did not do that. All right. And true or false? There are current and recently updated AASLD guidelines that review assessment of and interventions for frailty and malnutrition. So if I forget absolutely everything from this talk after the happy hour today, I can consult those guidelines anytime I please, since they are available for free and can access by simply Googling frailty guidelines cirrhosis. And of course, that is true. So please use these guidelines as well. And again, please raise your hand if you have any questions for us at any point. So how long should patients be required to be sober prior to listing for liver transplant? A, no delay. B, greater than a month. C, greater than 6 months. D, greater than a year. Dr. Rice?
So this is meant to be just as a discussion point that I think no delay is the requirement in certain patients, but longer is better. So I think the question gets to more counseling, more time of sobriety is important and actually a goal of ours. But that doesn't mean you shouldn't call us if a patient is interested in being sober and meets those criteria for our high-risk pathway. So no delay versus longer the better, but requirement should be no delay, and give us a call if they're interested.
John, you earlier talked about post-transplant alcohol use, and it may have been surprising for some people in the room to see 10% at 1 year returning to sustained alcohol use, 17 to 20% at 3 years. When you would hope that those numbers would be as low as possible. Should that number be 0? Is that even a reasonable goal?
I think in general, it's an unreasonable goal, but to have 0. And I think in general, we've seen that 90% at our center and thought we're actually probably being too strict. Because if you understand the natural history of the alcohol use disorder portion of the disease, a certain amount of patients are going to go back to drinking. I think it's almost flipping the coin where we should start talking about risk mitigation after transplant rather than complete sobriety in these patients. And how do we keep them from drinking too much? But any amount of alcohol, though, is bad for the liver. And that's the goal and the request and requirement. But that's not like we should stop taking care of them afterwards. But yeah.
Should steroids... Oh, sorry. I think we have a question. Okay, we'll get the microphone over to you. Should steroids be used to treat patients with alcoholic hepatitis? A, yes. B, no. C, what about pentoxifylline? It's answering a question with a question. And I know that was allowed. D, I need more information.
So yeah, I think this question is kind of getting at the crux of a lot of the consults and things that we get to is I think both A and D are the answer. I think, yes, it can be used for alcoholic hepatitis. And yes, you need more information. I think there's a lot of tools to help us minimize the amount of exposure to these patients and to help them. And no, you should not use pentoxifylline for those thinking that in their head.
Question.
Hi, my name is Sarah. I'm a dietitian, and we're dietitians. We work in the GI clinic. Just curious, Dr. Whelan, within the NASH population or MASH, sorry, that yes, we talk about weight loss and supporting them because it is so hard, but I think there's a lack of that integrating us into those programs. And so, is that something that I guess specifically at UC Health that's been considered, and maybe nationwide, is that something you're seeing within those programs as well?
Yeah, so I would agree that access to dietitians, there seems to be a lot of barriers that shouldn't be there. I even struggle when I'm seeing them because it depends on when their motivation, what they're willing to do, how engaged they are, and then what their insurance will cover. And I find I've tried to predict it and then I can't. I think they would all benefit from seeing dietitians because even if they think they're eating healthy, there's clearly improvements that can be made. So yeah, why they can't be integrated better? I think it's a systems issue is a big part of it. I think it's the patient, the systems, and then probably the providers. We don't even know like exactly how to get them in there. You know, here at the university, what I usually do is I'll kind of give them my general. As you know, it's a lot of work to really get a good, it takes a lot of time. So I just kind of skim the surface. We have our multidisciplinary fatty liver clinic, which is basically me and Tom Jensen, who's an endocrinologist, and he digs deeper. I focus more on the liver side of things. But we would love to be able to also have a dietitian at that. It wasn't logistically possible in the end when we were trying to set things up. But we'll often refer to the wellness center as another access to dietitians. But I think it's a lot of systems issue is what it comes down to. And other ways to better integrate dietitians. We need more dietitians.
Yeah. And I guess I would just for here, and if you're like in your clinic or like, we kind of need your support for that and you advocating for that, because us saying, well, we'd love to be here, but they're going to probably listen to you guys more than us.
Yeah,
so.
It is. There's like levels where we fight. We have the transplant dietitians. We have pretty good access there, but even they're stretched them and what they need. And a lot of it was kind of this fight to try to get dietitian support and their time supported. But I think it came down to how the billing comes out. So I think it came down to the money.
Makes sense.
But yeah, I agree from a patient standpoint. Nutrition and lifestyle counseling and resources for that are undervalued by our healthcare system, mainly from the monetary side.
I agree. Yeah. Thanks.
Okay. Any other questions right now? We're almost done with the morning session. We are, for the sake of time, going to do one final poll everywhere question. So a 52-year-old male with a history of diabetes and obesity with BMI of 42, labs show an AST of 42, ALT of 30, platelets of 189, and a FIB4 of 2.11. What would be the next step in management? A, refer for liver transplantation. B, imaging with ultrasound. C, refer for a liver stiffness measurement non-invasively. That's with the FibroScan or vibration-controlled transient elastography, or prescribe semaglutide.
Yeah, no, good job. There is no exact answer here. I led you guys to what I think is probably the most appropriate for the algorithm that you guys have selected of the FibroScan. Ultrasound is very reasonable, especially with the slight elevation in liver tests. So you can help you, especially with his platelets on the lower side, see if he has a cirrhotic appearing liver, splenomegaly. So very reasonable to do that. From the kind of primary care and workflow, at minimum, getting the FibroScan would be a really good way to triage this guy and see, because he definitely is at risk to have more fibrosis than you would realize from just initial assessment. So, and it would be nice to get him semaglutide likely, but the reality of actually getting that approved and prescribed and access to it, you'd need more information to see if it's possible. But he actually could be a very good candidate for semaglutide.
Awesome.
Can I ask a question?
Of course.
Order of ultrasound and FibroScan, or simultaneously ordered? Do you have a way that you approach if you're trying to? I guess it depends on the clinical situation.
Yeah,
but
I think it would depend on, I think if this person was seeing hepatology, I would get an ultrasound as part of it. So it'd be kind of simultaneously get both of those. I think in the primary care realm, I'd understand if they didn't. It wouldn't be like first on their radar, but I think most of the time it is done and that's appropriate. So, but I think that goes to this idea of thinking about fibrosis, thinking about looking for fatty liver, because those liver tests and things at face value aren't that exciting and would get overlooked, but this guy could easily have cirrhosis and it's not being recognized. So, and I think the best way to detect that would be the FibroScan. So I think of things happening to get him put in the right bucket, the FibroScan is probably the most useful. But in the full workup, and he would probably get sent to hepatology and we would do an ultrasound. So.
And to add to that, I think we all hear from patients sometimes, well, how did no one knew I had cirrhosis before? My liver tests were normal or near normal. So underscoring that point, certainly. All right. Well, before you all run out of the room for lunch, give me 30 seconds to go over some housekeeping items. First of all, thank you to all of you for a great morning session, and thank you to our speakers as well. If you could give them a round of applause again. I want to thank our sponsors as well. This conference, Rocky Mountain Highlights, this is the 10th year, and Blake and I are really, really fortunate to be the course directors. But the reality is this wouldn't be possible without the generous support of our sponsors. The free registration wouldn't be possible without the support of our sponsors. And so I want to thank them all again by name. And as you get lunch after this, please interact with them. Our sponsors again, AbbVie Incorporated, Bristol Myers Squibb, Castle Biosciences, Cook Medical, Irby USA, Exelixis, Gilead Sciences, Intercept, Interscope, Janssen, Medtronic, Olympus, Ovesco, Sanofi, Steris, Takeda, and Fujifilm. So thank you again to our sponsors. Please visit them during the lunch break in the exhibit hall that's right outside the conference room. Again, as a reminder, if you visit 8 or more booths and get a star put on your bingo card, you will be eligible to win one of 10 $100 gift cards. To be eligible to win, like I said, you have to not only bring your bingo card to the exhibitors, but we'll be giving out those gift cards at 3:30 this afternoon. That's after our debate. And I want to just close the morning session by saying that I think our afternoon session is going to be really exciting. We have several talks themed at therapeutic endoscopy. We'll then have a reception on the rooftop. We're not getting an afternoon thunderstorm at that time. We've triple checked, so it'll be safe. You can call it a happy hour if you'd like, despite what we've talked about for the last couple of hours. We're really looking forward to that event. After that, Dr. Jones and Dr. Patel are going to have a really fun debate about colorectal cancer screening. So it'll be a bit of a different format than a lecture type talk. So thank you again. Enjoy lunch, meet the exhibitors, and come up and chat with us if you'd like as well. Thanks.
Hello. Okay. This is on now. Sorry. All right, everyone. Hope you enjoyed lunch. We want to bring everyone back to get the afternoon sessions going. We're going to start off the afternoon with session 3, high yield topics in therapeutic endoscopy. And our first talk is courtesy of Dr. Kasuma Pakala, one of our former general GI fellows and current all-star advanced GI fellow. And she's giving us the talk updates on screening, surveillance, and management of Barrett's esophagus.
All right, thanks, Blake. So let's just hop in. I have no disclosures. We have a few learning objectives for the talk this afternoon. First is to review risk factors for Barrett's esophagus and esophageal adenocarcinoma. The second, to understand which patients should undergo screening for Barrett's esophagus. To understand the components of a high-quality Barrett's esophagus exam. And to discuss when biopsies should be obtained to evaluate for Barrett's esophagus. And to review principles of endoscopic treatments for Barrett's. So I'd like to frame this talk with a case. We have a 67-year-old white male with a history of tobacco use, class 1 obesity, long-standing GERD symptoms, who is referred by his PCP for an upper endoscopy for new dysphagia. You do his EGD, and this is what you find. Find a mass in the lower third of the esophagus. You perform biopsies, and the diagnosis is esophageal adenocarcinoma. Further workup reveals that he has stage 3 cancer and will require surgery and chemoradiation. Cancers like this are preventable if we can identify and screen at-risk individuals and manage them appropriately. Today, I'll focus on the updated American College of Gastroenterology Barrett's esophagus clinical guidelines, which were released in April of 2022. In particular, I will bring attention to recommendations in these guidelines that are changes from the previous guidelines published in 2016. Barrett's esophagus is defined as a columnar-lined esophagus at least 1 centimeter in length, with pathology consistent with intestinal metaplasia. The length of the columnar-lined esophagus is determined by the distance between the top of the gastric folds and the squamocolumnar junction, also called the Z-line. In patients with normal anatomy, the top of the gastric folds, the squamocolumnar junction, and the diaphragm are all at the same level. In this diagram to the right, you can see all of these landmarks, but this patient has a long suspected Barrett segment with a hiatal hernia. The spectrum of Barrett's follows a stepwise progression of disease, starting with non-dysplastic Barrett's, progressing to low-grade dysplasia, high-grade dysplasia, and esophageal adenocarcinoma, which can be intramucosal or submucosal. Indefinite for dysplasia is a pathologic diagnosis where the pathologist cannot confirm the presence of or exclude the presence of dysplasia. And this is often seen in patients with active inflammation. So we'll start by discussing the updated recommendations in the new guidelines for Barrett screening and diagnosis, then discuss recommendations for surveillance, and lastly, discuss recommendations for treatment strategies for Barrett's. Identifying and screening individuals at risk for Barrett's esophagus and esophageal adenocarcinoma is extremely, extremely important. A patient's diagnosed with esophageal adenocarcinoma, concurrent Barrett's is seen in about 60% of patients. If we only look at patients who are diagnosed with early stage esophageal adenocarcinoma, concurrent Barrett's is seen in over 90% of these patients. However, sadly, only 12% of patients who are diagnosed with cancer were previously diagnosed with Barrett's. It's difficult and challenging to identify which individuals are at risk for Barrett's and who we should screen. But data has shown that the prevalence of Barrett's in patients without GERD or without risk factors is extremely low. When you add GERD in, it raises the prevalence to 2.3%. If you add GERD plus a single risk factor, the prevalence increases to 12.2%. And if you add 3 risk factors to a patient who has GERD, then the prevalence of Barrett's is 14.6%. Thus, the guidelines recommend a single screening endoscopy for patients with chronic GERD symptoms and at least 3 additional risk factors for Barrett's based on the data. These risk factors include white race, male sex, age greater than or equal to 50 years old, tobacco use, a BMI greater than 30, or a family history of Barrett's esophagus or esophageal adenocarcinoma. Despite the rising incidence of esophageal cancer that we're seeing, the vast majority of high-risk individuals do not undergo screening. In fact, this was evaluated in 2 different healthcare systems within the past year, and one healthcare system found that their rate of Barrett screening in high-risk individuals was 10%, while the other study found that their rate of screening was 40%. So we have a lot of work to do. Aside from screening with an EGD or an upper endoscopy, possible screening methods also include unsedated transnasal endoscopy. Although this screening test has a sensitivity and specificity over 90 and 95% respectively, it is not readily available at most centers in the US. But newer, less invasive modalities are currently being developed. And the guidelines currently recommend the swallowable non-endoscopic capsule sponge device combined with a biomarker is an acceptable alternative to endoscopy for screening for Barrett's in those with chronic reflux symptoms and other risk factors. So as the field moves forward and towards these non-invasive screening modalities, various testing is being developed. These modalities, the goal is that they can be performed in a PCP's office or even within the comfort of a patient's home without the presence of a healthcare provider. All of these different modalities work similarly in that a patient swallows the device, and then the device is withdrawn orally via a string. And as the device comes up through the esophagus, it scrapes the esophageal mucosa, and then that sample is sent to the lab to look for markers that are found in intestinal metaplasia, whether or not they're protein markers or methylated DNA markers. So this, on the slide, you can see that A represents a device called the cytosponge, B is esophagcap, as well as C is an open esophagcap, and then D and E are Lucid's EsoCheck. With the establishment of the KDO and Paul M. Reddy Esophageal and Gastric Center of Excellence earlier this year, here at the University of Colorado Anschutz Medical Campus, we are really at the forefront of Barrett's esophagus screening, diagnosis, and management. We have a strong multidisciplinary team and have multiple ongoing studies pertaining to Barrett's esophagus. We have 2 studies in particular that pertain to minimally invasive screening modalities.
The first is looking at Lucid Diagnostics EsoGuard and EsoCheck, and the ability for this device to detect the spectrum of Barrett's disease. So if there are any patients that you know that meet the study criteria listed here, please consider letting them know about the study. The second study that we have ongoing is a pilot study for EnteroTracker, a string-based collection device that captures esophageal mucosal samples and is currently validated for use in EOE patients. It's currently being modified or been modified for the use in Barrett's esophagus, and hence we are performing this pilot study. This device was actually developed here at the University of Colorado. If you have any patients that meet the study criteria listed here, please consider referring them. So next we'll move on to discuss updated recommendations for the diagnosis of Barrett's esophagus. So guidelines now recommend a 10-step approach to performing a high-quality Barrett's exam. These 10 steps include using a distal attachment cap, identifying esophagogastric landmarks of the diaphragmatic hiatus, the gastroesophageal junction, or the top of the gastric folds, and the squamocolumnar junction, also known as the Z-line. You should also clean well using water and suctioning carefully to avoid traumatizing the esophageal mucosa, using both insufflation and desufflation to identify very subtle lesions. Spending adequate time inspecting the Barrett segment, both on phos view as well as retroflexion to also inspect the gastric cardia. Using both high definition white light endoscopy as well as chromoendoscopy to inspect the Barrett segment and identify any concerning lesions. They also recommend using the PROG classification and the Paris classification to describe the Barrett segment length, as well as to describe any lesions to standardize documentation, and to use the Seattle protocol when sampling the suspected Barrett segment to increase diagnosis as well as dysplasia detection. So, as I mentioned, the guidelines recommend that the columnar mucosa of greater than 1 centimeter in length be necessary for the diagnosis of Barrett's esophagus. But also, the guidelines mention that patients with a normal appearing Z-line or squamocolumnar junction should not undergo routine endoscopic biopsies. In the absence of any visible lesions, patients with a Z-line less than 1 centimeter should also not undergo routine endoscopic biopsies. And this second point is really supported by evidence that shows for less than 1 centimeter of a columnar lined esophagus, there is extremely low risk of progression to high-grade dysplasia or esophageal adenocarcinoma when biopsies show intestinal metaplasia. And this can be seen on this graph to the right. In addition, these patients who have intestinal metaplasia on their first EGD, when they come back for a follow-up EGD, over 50% of these patients no longer have intestinal metaplasia seen. A study performed in 2020 found that for patients presenting for an EGD with a normal Z-line or an irregular Z-line, over 90% of these patients had biopsies obtained. Over a third of patients with biopsies had intestinal metaplasia, and over 80% of those patients with intestinal metaplasia were recommended surveillance EGDs to be performed. So not only does this practice mislabel a patient as having a precancerous condition, but it leads to unnecessary surveillance procedures that have risks and costs to the patient. So now we'll move on to updates to the guidelines with regards to surveillance of Barrett's. The main updates are within regard to a non-dysplastic Barrett's esophagus. And they state that that non-dysplastic Barrett's esophagus segments should be surveyed according to the length of the segment. So longer segments, or segments greater than or equal to 3 centimeters, should be surveyed every 3 years, while segments that are less than 3 centimeters should be surveyed every 5 years. And this is based on data that shows that segments less than 3 centimeters in length have a much lower rate of progression to high-grade dysplasia or esophageal adenocarcinoma than segments greater than or equal to 3 centimeters. The other recommendation I'd like to highlight with regards to surveillance is the recommendation to use both white light endoscopy and chromoendoscopy in patients undergoing endoscopic surveillance. I mentioned that this is crucial to doing a high quality exam for diagnosis, but the same stands for surveillance exams as well. So chromoendoscopy can be performed with virtual chromoendoscopy like narrowband imaging or eye scan, or it could be performed according to the traditional method of using vital dyes like acetic acid. Chromoendoscopy improves detection of irregular mucosal or vascular patterns, which might harbor dysplasia or carcinoma. Additionally, it's thought to be helpful because the added time of inspecting the Barrett segment gained by adding chromoendoscopy is thought to also help improve detection of lesions. Traditionally, surveillance is recommended by performing 4-quadrant biopsies every 1 to 2 centimeters of the Barrett segment, and this is known as the Seattle protocol, which has been shown to increase detection of high-grade dysplasia and cancer compared to other biopsy methods. However, data has shown that adherence to the Seattle protocol is low, less than 50%, and adherence tends to be lower for longer Barrett segments, which are at higher risk of containing a dysplastic lesion. Thus, other modalities are being assessed, including wide area transepithelial sampling. This is the use of an abrasive brush to sample the Barrett's area and has been compared to the Seattle protocol for surveillance. But the data for Watts as an alternative surveillance strategy is mixed, although Watts has been shown to improve dysplasia detection when used as an adjunctive method for surveillance. We have an ongoing study here that is aimed at helping to elucidate how Watts can be used or should be used for surveillance. And we'll wrap up by talking about management of Barrett's esophagus. So we already discussed that the management of non-dysplastic Barrett's involves surveying these individuals every 3 to 5 years according to their segment length. For Barrett's esophagus with low-grade dysplasia, the updated guidelines now suggest endoscopic therapy to reduce the risk of progression to high-grade dysplasia or esophageal adenocarcinoma. The guidelines state this, but also state that surveillance endoscopy is an acceptable alternative. The management of Barrett's with low-grade dysplasia is a very hot-button topic right now, and there's a lot of controversies about what should be done. But at the end of the day, this should be a patient-based approach in deciding if a patient should undergo surveillance or endoscopic therapies. To better answer this question of what is optimal management for patients with Barrett's with low-grade dysplasia, Dr. Wani has a $10 million grant and is currently enrolling patients for a multi-center study evaluating outcomes in patients with low-grade dysplasia who undergo surveillance compared to those who undergo endoscopic therapy. So endoscopic eradication therapy is the term used for endoscopic treatments for dysplastic Barrett's. The principles of endoscopic eradication therapy, including resecting all visible lesions. This can be done in the majority of cases with endoscopic mucosal resection. In some cases, endoscopic submucosal dissection may be required. The second principle of EET is to ablate the entire Barrett segment. This can be done with radiofrequency ablation or cryotherapy. And patients who undergo EET should be continued to be surveyed and should undergo further EET until the goals of treatment are reached. So the goals of treatment include complete eradication of dysplasia and complete eradication of intestinal metaplasia or CEIM. So once CEIM is attained, patients should continue to undergo surveillance periodically in order to identify recurrent intestinal metaplasia or recurrent dysplasia so that they might be treated and managed within a timely manner. Cessation of surveillance should be considered for patients who no longer are candidates for endoscopic eradication therapy. So the guidelines also now suggest that patients with Barrett's esophagus undergoing endoscopic eradication therapy be treated at high volume centers. And they define high volume centers as those that have 10 new referrals for high-grade dysplasia or esophageal adenocarcinoma per endoscopist per year. And the reason why they recommend this is because data has shown that patient outcomes are improved for individuals undergoing EET for dysplastic Barrett's at these high volume centers with regard both to attaining goals of eradication therapy as well as adverse events. So to summarize, our take-home points include making sure to screen and identify at-risk individuals. Do not biopsy the columnar esophagus if it is less than 1 centimeter in length. Perform high quality Barrett's exams. Take your time. Use chromoendoscopy techniques like narrowband imaging. Manage Barrett's with low-grade dysplasia using a patient-centered approach. And consider referral to a high-volume center for endoscopic eradication therapies. So in summary, please join us in improving care for our patients who are at high risk for Barrett's esophagus and those with Barrett's esophagus, so we can decrease the incidence of esophageal adenocarcinoma, as well as decrease the morbidity and mortality associated with this horrible disease. I'd like to thank Sachin Wani and our research assistants, Jasmine, Case, and Jack for their assistance with creating this presentation. And I'd like to thank Dr. Jones and Dr. Kalra for inviting me to speak today. Thanks for your attention.
Thanks, Dr. Pakala, for that amazing and very thorough talk on the latest and greatest advancements for evaluating and managing our patients with Barrett's esophagus. Moving on in session 3, our next topic is going to be from Dr. Hazem Ahmed. He's an associate professor of medicine in our advanced therapeutic endoscopy section, and he's going to be giving us a talk on endoscopic management of large and complex colorectal polyps.
Good afternoon, Blake and Avash. I can't be more proud of you guys. Thank you so much for the invitations and for taking on this great conference. And can't thank enough Matt, Lindsay, and Christy for sure for keeping this course going strong. And thank you guys for being here. We know Saturday and everybody's probably had a busy week. We know we did. But before we took too long, let's get on to this talk and talk a little bit about endoscopic resection. We were going to talk a little bit more in general about endoscopic resection, but we all know that we see a lot more colon polyps and more of these lesions. So we'll just keep it to colon polyps today. But if you have any questions later about endoscopic resection in general, we'll be more than happy to discuss these. Okay, so here we have a 70-year-old patient with history of hypertension and chronic kidney disease who underwent a surveillance colonoscopy. There were multiple small polyps that were removed, and a 2-centimeter polyp was found in the rectum, starting from the dentate line, and the biopsies showed high-grade dysplasia. So another repeat colonoscopy showed a similar lesion. It was a large lesion with a slightly depressed center. And the pattern was also concerning for an advanced neoplasia. So what would you do if this was your patient that you're taking care of? Would you consider referring this for EMR? Would you think about a endoscopic submucosal dissection, transanal surgical excision, or referral to surgery given the high-risk features and the high-grade dysplasia for abdominal perineal resection? So what we do, and we will talk about the rationale for this, is endoscopic submucosal dissection for this patient. We will start with marking this lesion to make sure that we have all the lesion and the surrounding tissue with negative margins, and then proceed with a circumferential incision, and then submucosal dissection from the underlying muscle layer, and then remove the lesion en bloc. So when we have and that's what we tell our patients, that but only 50, by the time we remove the lesion, a lot of people think that we're done or we're close to being done. And what I tell my patients is like only about 50% of the job is done, because a lot of the work is done after you remove the lesion and send it to the pathology, because that's when you actually can tell the patient, are they fine, or do they really need more attention or more care, more chemotherapy, more radiation? And so for this patient that we just discussed, there was a 2-centimeter tubular adenoma with high-grade dysplasia. There was a focus of adenocarcinoma. And we don't stop here. We will take it a little further to see what grade of this cancer was. And this was a well-differentiated tumor. There was no lymphovascular or perineural invasion. The tumor invades into the submucosa. That gets us a little concerned. But the extension was only about 190 microns. So we really take a very, very little measuring tool and then go to the microns. A micron, if you guys can imagine the millimeter, is 1 in 1,000 of a millimeter. And these things matter for patient care. So this was about 0.2 of a millimeter extension into the submucosa. The tumor budding score was low. All these are good features. And then the deep and horizontal or mucosal margins were negative. So with that, we can tell the patient that congratulations, this resection that we did was a curative resection with very low risk of recurrence or spread of this early lesion or cancer. So after have talked about all this, what is endoscopic resection? Basically just a minimally invasive technique for excision of superficial GI neoplasia. It is an alternative to a more radical surgical treatment. The only drawback to this kind of treatment that it's a local treatment. We just excise or scoop out the lesion. We cannot harvest lymph nodes to evaluate those. So it would only work for those patients who have negligible risk for lymph node metastasis. So that hence all this like looking into all these criteria to see if this actually a lesion was a low risk for this lymph node mets or not. Okay, so when I talk to the patients about these lesions, we talk about the layers of the GI tract, and most of the GI tract come in 5 layers. As long as the tumor is in the superficial or inner layer, that's the mucosa, or the superficial part of the submucosa, and we can scoop it out completely, then the patient is in, the outcome is very good. If the tumor is going deep into the wall, then it doesn't matter. It's not about the size. It's actually about how deep that tumor is rather. So we can cure anything that goes all the way down to the superficial submucosal layer. And the same thing, the reason with that, because if we take it all the way down to the superficial submucosal layer, the lymph node risk is very, very low. And as we always say, it all starts with seeing. Endoscopic evaluation and identification of these early lesions and deciding which lesion actually has risk for lymph nodes, which lesion does not have that risk, really is very important. This, when you look at this polyp and just, you know, with the white light, you may not understand a whole lot about it, but when you turn on the different knobs on the scope with what's called enhanced imaging, you can see a lot more and try to identify more about this polyp and also the characteristics, or what we call now visual biopsy. Like you actually can just be like a pathologist, instead of just looking at the microscope, you're looking with your tools and enhanced imaging tools that are available on all the scopes nowadays to characterize this lesions look like a precancerous polyp, this looks like early cancer, or this looks like a deeply invasive cancer that probably should be handled differently. We talk about Paris classification, and this is just how the lesions look. Is it pedunculated? Is it sessile? Is it slightly depressed? Is it ulcerated or excavated? So you will hear this this designation for these lesions. For example, if it's an excavated or ulcerated lesion, the risk of lymph node metastasis is very high, and those lesions should not be treated endoscopically. There's also the characteristic of these lesions with enhanced imaging, like the NICE classification, where we look at type 1, 2, and 3. Type 1 are those hyperplastic polyps. They look pretty plain on imaging with the enhanced tools. If the lesion has more like a brain pattern, huge with a regular pattern, when we see them under the narrowband imaging, those are typically precancerous polyps that could be handled successfully with endoscopic resection. If we look at the lesion and we see part of it has this amorphous or absent pattern, then we start thinking that this lesion actually may be too deep and the risk of lymph node is high and probably should not be handled endoscopically. A lesion like this probably the best course of action, even if it was small, is just to be biopsied and sent for a surgical evaluation. Kudo classification is another more complex, but basically from 1 to 6, 1 being the normal tissue. Again, a really simple way to remember, if you can see regular pattern of this tissue with enhanced imaging, this is fine, all the way to Kudo 4. When it becomes irregular, but you can still see the pattern, this is still fine. You can probably resect that endoscopically with a good chance of endoscopic curability. But if you don't see the pattern here, this is probably too advanced, and this lesion should be only biopsied and referred for surgery. A term you would hear quite a bit about is lateral spreading tumor. This is any lesion that is flat or elevated more than a centimeter. Non-granular, or those flat, smooth lesions, have more risk for invasive carcinoma than those lumpy, bumpy, or granular type LST that we see. Like it or not, actually, in the last 20 years, this is the graph for the surgery for patients who have colorectal polyps, benign colorectal polyps. It had almost, the incidence of surgery has almost doubled in the last 20 years for patients who are being referred for surgery for benign colorectal polyps. And this does not come without a price. There's about a 1% 30-day mortality, but 15% major post-op adverse event, also need for about a 5% risk of needing a second major surgery, and also a colostomy. And remember, we're talking about actually a benign polyps here. When we look at also the mortality, particularly when we look at those patients who are really old and have multiple comorbidities, you can see really significant mortality for these colorectal surgeries for these patients. And, most of the patients that we have are in their 60s, 70s, 80s, right, that have these large polyps or that are being, screened and surveyed for colon polyps. When you look at the surgery versus endoscopic resection, major difference. I am yet, thankfully, to remember and that we lost any patients doing endoscopic resection on. But if you look at the really surgical mortality, it's very high. Okay. So with colorectal EMR, basically, this is, as most of you know, injection of a submucosal lifting agent. And most of the time, we do piecemeal resection of these benign precancerous lesions. The technical success is more than 90%. The concern with that, when you do piecemeal resection, that there is a lot of recurrence. You leave small islands or strips of tissue between these pieces that you remove. In many of the studies, up to 16 or 20% actually. However, even with that concern for this recurrence, most of these recurrences can be handled endoscopically. One new concept that we talk about is this snare tip soft coagulation. Is after removal of these large lesions, you take the tip of the snare and coagulate the edges just like that. And this is a demonstration of that. So this lesion was resected completely. And then after you remove the lesion, you take the snare. And this is good for a lot of the nurses that we have. The same tool. You don't have to have another tool. You're not increasing the expenses of the procedure. And you turn your setting to soft coagulation mode, and then touch up the edges about 5 to 10 millimeter of whitish tissue around. Gentle technique, and that can really decrease your chance of recurrence to about 1%. In randomized trial, in a prospective real-time also prospective cohort, also has been shown to be really decrease that chance of recurrence to 1%. So these techniques work really good. One really important concept that we talk about these days for these lesions that we see quite commonly these days because of the better optics on the scope is the sessile serrated adenomas. Those are the flat polyps with the mucus cap on them. We see them often in the right side of the colon. When we used to do piecemeal EMR and even more advanced resection for these lesions, nowadays the standard of care is to do piecemeal cold resection for that injection under these lesions, and then you remove them with cold snare. This has been shown to be as good as the EMR technique, and also with a lot less chance for bleeding, perforation, and all these issues that come with endoscopic resection. And also the recurrence rate is actually similar to the EMR technique. Cancer in pedunculated polyp is different. It's not the cancer itself, it's how deep into the stalk is what really matters. So when we see a pedunculated polyp, we really are careful where that snare is on the, where do you cut this? Because you want to try and make sure that you have a really nice margin on the stalk. And that's what the pathologist will use, because that could mean a difference between a patient needing colectomy or you tell the patient that they're cured. ESD is a more advanced technique that starts with lesion assessment and then marking the lesion, injection of submucosal lifting agent, and then circumferential incision, submucosal dissection under, and then basically you end up with a really large area of resection with an unblock removal of this lesion. This will really help pathology assess the lesion much better with the margins, and even if there is a small cancer, that they can really tell you how deep that cancer is. This is an example of a procedure, of an ESD procedure. After submucosal injection, there was starting with a circumferential incision and slowly proceeding with the submucosal dissection. This is the muscle layer here. This is the submucosa with the lifting agent that's stained with the blue color, methylene blue or indigo carmine. Bleeding is not unusual to see. And that's, as we say, just part of the deal. You just have to be ready to deal with this. That it makes a big difference to have a team who's trained to handle these situations and, you know, remain calm when you have something like that. Many times we use traction to be able to maneuver around the difficult angles of the cone or the rectum, as was shown there. And then finally, we can resect the whole lesion en bloc. This is about 80% circumferential resection. Usually this heals nicely without any issue. This is an amazing, and it always amazes me how beautiful the human body can heal. I mean, you can't really imagine that this is the healing scar from that massive resection that we did for this patient. She was doing fantastic a year later. You know, imagine if this patient would have had a partial colectomy, potential for a colostomy, all these things, or change in life and quality. So these things can really matter. We talk about this fancy endoscopic submucosal dissection. It really sounds cool, but is it really right? It's more complex procedure. It takes longer period of time. So what we do is really selective ESD is probably the best and the most cost-effective way to approach these, and only for lesions that have high suspicion for low-risk submucosal invasive cancer. So lesion that looks suspicious but can be cured endoscopically, this is where we really use this technique. This is where you have some irregular pattern, depressed center, size more than 5 centimeter, location in the rectosigmoid, and also remember that the smooth lesions, the smooth polyps, or the lateral spreading tumor, non-granular. ESD is now in the guidelines with ESGE, and for any colorectal non-granular depressed lesion more than 2 centimeter, also with the updated guidelines from ASGE as well as the ESGE as well. So remember those high-risk lesions. So one thing, like if we really come out with this lecture is if we understand and we agree on this, that would be really great, is that lesions without characteristics of deep submucosal invasion should not be referred for surgery without consultation with an expert endoscopist for evaluation of polypectomy, EMR, ESD. you'd be surprised, right? Like that, you're just taking away business from colorectal surgeons and all this. But I tell you that a lot of my work, actually comes from colorectal surgeons, that actually handle these patients and believe that this is a better option for these patients. We're going to talk just a couple of minutes about some of the newer techniques that are out there to handle these difficult colorectal polyps. Endoscopic full thickness resection is a cap that's mounted on the scope where you can actually pull a part of the wall of the colon and then resect it completely. So basically just that part, the whole part of that colon is removed after putting a clip on. This is a patient who was dealing with a difficult polyp that's just that kept recurring, and then finally ended up with 1.5 centimeter polyp in the cecum, and with the pathology that's showing tubulovillous adenoma with focal high-grade dysplasia. Routine or the standard polypectomy techniques were not possible. We can see this lesion here. Really difficult to do EMR, difficult to do ESD because of the thin wall and because of the scarring from the prior attempts. So that's where really the full thickness resection can be really very valuable. So this is marking of this lesion here. And then this is the device. Our fantastic advanced fellow, Dr. Pukala, would tell you that it looks really easy and make it look easy. But advancing this cap through the colon is not that easy. And sometimes you have to be really careful. It's a big cap, especially with these older patients who have fixed colon angles. We're pulling the whole wall actually of the colon here inside this cap, being careful to not suction too much and pull some of the adjacent structures. For example, in the sigmoid, the ureter just passes by, and actually there have been reports that you can pull the ureter inside, and then we deploy the clip and then cut on top of that. And that's how it looks. We have a full full thickness piece of the colon with actually some ammental fat on the back. So we got the whole thing. And the pathology usually just shows you this full thickness resection. One of the newer kids on the block is endorotor EMR. This is a non-thermal mucosal resection device that's basically a catheter with suction and a blade, a rotational blade that can basically shave off the scarred lesions. This is the device here. There's a suction from inside, and then the blade goes inside this. You suction part of the lesion, and then the blade basically shave off the lesion. This also works really good for these very scarred lesions that are low risk, and you just basically really hate to send these patients for surgery, but they just keep having these recurrences or residual of this this polyp. This is one really good way to handle that. It's a tedious process. You really have to be careful because sometimes if you're not careful, you can actually suction the muscle layer and end up with perforation using this tool. So you have to be careful where that suction is applied. But when it's applied in the right way, it works really, really good. You will see the end result here. So this is the end result, really looks good, clipping after. And then just for some tips for endoscopic resection, we always advise to use cap. That's the distal attachment cap on the scope when possible. To use some staining method for the submucosa using methylene blue or indigo carmine. to use stiff snare, even in the community setting. If you're embarking into doing endoscopic resection, really you need to get some stiff snares for these procedures. Don't forget about this really neat technique called snare tip soft coagulation to decrease your recurrence of polyps. And then also do not forget about the cold snare EMR technique for cess-ulcerated adenomas. Thank you very much.
All right. Thank you, Dr. Ahmed. And our last and final talk for this session, actually our last and final didactic talk for the day, is going to be courtesy of Dr. Stephen Mundovitz, who is currently the interim division director for the Division of Gastroenterology and Hepatology, and also the director of the Digestive Health Center. He's going to be giving us a talk on endoscopic management of complex biliary obstructions, art of the trade.
"43 days, but no one's counting." Good afternoon. It's really nice to be here. I've shortened my talk because I knew I was following Dr. Ahmed. So we'll see if we can move forward. These are my objectives. I just want to talk a little bit about the management of obstructive biliary disease, primarily talking about the clinical aspects of it. My disclosures for the lecture are listed there as well. So when we think about biliary obstruction, there are really two common categories we run into. There's stone disease and malignancies or strictures. And when your patients present, they typically can present with a history that you want to dive into a little bit to make sure that you're not missing something, like they had a gallbladder operation that was complicated, or they have a strong family history of pancreatic cancer, or these kind of things. They typically present yellow. And the way I kind of think about it is, if they present with painless jaundice, I'm very worried about a malignancy, because that's typically how patients with pancreatic cancer and biliary cancers present. If they present with pain, like colicky pain, I'm thinking more stone disease. And I'm thinking maybe this patient has retained bile duct stone or has had complicated cholecystitis. They'll all have obstructive liver enzymes, just no matter which the etiology is. Typically, alk-phos-bili and GGT will be elevated in addition to the bilirubin. And the one thing that's kind of interesting is you want to think about cholangitis in these people that present kind of with achy pain or just low-grade fevers. And I've learned recently that screening these patients is surprising. I had a patient walk into the lab to get some blood work because he was having symptoms. I said, I'm just going to, out of curiosity, I'm just going to send some inflammatory labs and see what's going on. And sure enough, they were markedly elevated. And this patient got admitted, got treated with antibiotics and IV fluids very quickly, and I could have easily dismissed that on the phone. So it was kind of an interesting situation. Two comments I'm going to make. One is CA19-9 is a very nice tumor marker for pancreatic masses. It goes very high. It's extremely elevated in cholangitis and biliary obstruction. So please don't tell the patients that they have a cancer when you have a CA19-9 of 10,000, but they actually have cholangitis. The second thing is that biliary obstruction, as I'm presenting it, is great, but you want to see obstruction somewhere. So either an ultrasound, a CT, or an MRI should show that there's dilation of the biliary tree. Occasionally, we see early cases where there's no dilation, but for the most part, you'll see this. So this is the stone side of the talk. You can all identify that this is our typical ERCP scope. And the scope is actually in position in the duodenum, dilated bile duct. And here you see the filling defects as we put contrast into the biliary tree. Those can be obstructing. They can stick in the bottom of the duct and actually completely obstruct it. You can move them usually freely with the scope. And these are the tools we use to manage them. We open the sphincter with a sphinctertome, and then we either use a basket or a balloon to pull these stones out, and that typically relieves the obstruction. We do this routinely on an outpatient basis, and patients are quite satisfied when they're done. Another example, same thing, stone in the biliary tree at the bottom, stone in the balloon above it. You do the sphincterotomy to open the sphincter, and you sweep the stones out. Everybody in the state, I think, that does ERCP is doing this on a regular basis. The bilirubin and the liver enzymes should resolve fairly quickly, and everyone should be happy at the end of the day. This is a interesting video. I'm going to show you the sphincterotomy. It's from a friend of mine. nice big sphincterotomy and a big papilla. This is how we cut with the cutting wire. He then puts a balloon into the distal bile duct because this patient has big stones, as you saw on the cholangiogram. This is the balloon dilation that we do up to 15, sometimes 18 millimeters. And then the same tools we use to take the small stones out, we basically put up into the biliary tree. This is all the view from the ERCP scope, and we pull the stones into the duodenum and let them pass. And that technique can be very useful. You can actually remove fairly large stones. This is not a new modification because it's a stone I took out in 2001, 201, so 23 years ago. So it is possible to take big stones out of the biliary tree without surgery and relieve obstructions. We have some additional tools that are kind of interesting. They've kind of evolved over the years. We have a mechanical lithotripter, which is kind of like a nutcracker. It essentially has a basket and a long steel sheath. You put this steel sheath through the scope into the biliary tree. The basket's now deformed because we cracked the stone that had the density of granite into multiple pieces, and then you pull it out. And these are used for big stones that you just can't pull out with balloon dilation. The thing that's really revolutionized our work in the biliary tree is this single operator cholangioscope. It's a second scope that we pass inside the ERCP scope, pass it up into the biliary tree. You can see big stones. You can actually see the structures nicely, and you can use laser or electrohydraulic lithotripsy to break up the stones. Electrohydraulic lithotripsy is basically spark gap technology. You have a catheter that's on the end of the steel tip at the end of a catheter that generates an electrical spark that creates a shock wave in the bile duct, and it fragments the stones. It actually works pretty well. I think this is going to play. So this is the choledocoscope looking in the biliary tree. There's a quite large stone that was not easily to be entrapped in a basket or balloon. That's the EHL probe at the bottom, and with one shot, it starts to fragment. Some of these stones are like sand clusters. They break up very easily. Others are like chips of granite. They're very hard to break up. But once we reduce the size of the stone to a size that we can extract into the duodenum, we can then go with our tools and pull all the pieces out, relieve the biliary obstruction. And again, these patients can be done as an outpatient, and this should recover fairly quickly. Now, all of this is not without the risks of ERCP, i.e. pancreatitis and bleeding and cholangitis, but for the most part, it's a pretty standard procedure. And I think in our group schedule, if we see a stone case, everyone starts smiling because it's a lot easier than the other cases that we're going to talk about that we end up dealing with here. I just want to share this for a second because, oops, I'm sorry, I interrupted that. The stone looks like it's been completely fragmented now. The pieces look like they're at least half the size of the bile duct. And then using the balloon or the basket, we can then pull these pieces out into the duodenum, just like we did the single stone. And you can actually clear quite a large stone burden with these techniques. We can do the same thing with lasers. They're a little more efficient, a little more expensive, but they actually are very effective at breaking up the stones as well. And the last pre-surgical attempt we have for breaking up big stones is the same shockwave lithotripser that you use for kidney stones can be applied to the biliary tree and the pancreas to break up stones as well. This was popular back in my era. Hasn't been used very often now that we have cholangioscopes and other tools that are more fun to play with than these machines. And I wanted to show this. Sometimes you get lucky, and when you go to do your procedure, you find the stone is actually stuck in the opening trying to get out. And this is a good demonstration not only of how you can open up the papilla to allow the stone to pass into the duodenum, but what actually happens in the physiology of cholangitis. So this patient presented with cholangitis, had a bilirubin of about 13, had high white count, had almost septic parameters, got fluids, IV antibiotics, and was brought to the endoscopy suite. And as my fellow is actually incising the papilla here, opening this up, you start to see the pressure that the bile and the infected material is under coming out. And you can understand how this could actually translocate to the portal system and cause sepsis because there's really a lot of pressure in the system. The stone falls out, and even after the stone's gone, without any negative pressure in the duodenum, it's just flooding the whole duodenum with bile and pus. So it's a very rewarding procedure when you can accomplish this. The patients actually often feel better by the time they're leaving the endoscopy suite. So I want to talk about the other half of biliary obstruction, and that is the stricture side of it. a little more complicated and a little more complex. Strictures can occur anywhere in the biliary tree. This is a nice review of the anatomy, starting down at the papilla and the sphincter of Oddi here, the common bile duct, cystic duct coming off, common hepatic duct or main duct, then the bifurcation, right system, left system, as we look at it in the ERCP films. This is demonstrating that strictures can occur anywhere in that biliary tree. In certain conditions like PSC, you'll have strictures everywhere. In other conditions, you'll have dominant strictures that are causing the obstruction. And as you can imagine, your imaging, your three-dimensional imaging, which is extremely helpful in managing these patients, will tell you where the stricture is by where the ducts are dilated and where they're not. So when I get referred to stone case and the only thing we see on the MRCP are dilated ducts above the bifurcation, I get very nervous because that's typically a Klatskin tumor or something involving the bifurcation that's going to be very complicated. Whereas if I see dilation all the way down to the papilla, I'm pretty happy because I know that's going to be a pretty straightforward case with something down in the distal bile duct. So location is key. The extent, you can have multiple strictures. The severity is kind of interesting. You don't really appreciate that until you're doing the procedure of how tight the stricture is. And the compliance of the stricture can be a real problem. The most challenging strictures, these post-op ischemic strictures with clips all around them that are almost like rock. Very hard to get stuff through there and to dilate them, but it is possible, and we have a number of tools that I'll explain to do that. The location for us is very useful. If it's right around the ampulla, it can make cannulation a little challenging, but if it's up a little bit, the typical pancreatic cancer stricture, those are usually pretty straightforward because you have good access, you're close to the scope, so you can push things through the stricture and you can deal with it. Any of my colleagues want to tell me what this is? Right, it's a double duct sign. It's a double duct sign in malignant pancreatic cancer. Cancer's right here, blocking both the pancreatic duct and the bile duct. But as you can see, the distal bile duct is actually normal. So I should be able to cannulate, get a wire in here, push it up above to the dilated main duct and then the bifurcation, and put a simple stent in, do brushings and biopsies, make a diagnosis. So this is what we typically see in pancreatic cancer, and those are the strictures that are probably the easiest to deal with because they're away from the papilla, but they're in the region of the duct where you're not going to have too much trouble pushing things through. What about the bifurcation and beyond? Well, that creates a little more of a problem because you're further away from the scope. You're up here now. Your tools are a little bit flimsy. They're plastic or they have a steel wire in them, but you have to push above that. And then you also have to worry about all these other branches up here that you're possibly going to occlude if you put a stent or a balloon or any other device up there, because it's going to be like a broccoli stalk, right? There's all these branches coming off, and that becomes a little more challenging. So for bifurcation strictures above the head of the pancreas, it's really helpful to have three-dimensional imaging before you start your work. MRCP is an ideal way to visualize this. You can do an MRCP even without contrast. They can do a T2 weighted image and you can get a very nice picture just like this one here that shows you that this is not just a simple stricture of the bile duct, but it's a complicated stricture involving aspects of the left and right duct. And then when we go to deal with these, we're often not dealing with just one stricture, but we're dealing with right and left main duct strictures. And in this case situation, there's probably other areas of the right ducts that aren't even being filled that are undrained. And for the most part, these are the cases that you really worry about, because if we're not completely decompressing this and we're putting a lot of dye up there, these patients are going to get cholangitis and it's going to be an issue. So we want to approach those carefully, and we always try to approach them with three-dimensional imaging. Now, this is an example of our PSC case. You can see this patient has a dominant stricture in the head of the pancreas, but also a very irregular bile duct throughout the liver. There's areas up here where there's strictures and there's not much dilation above stream, probably because of cirrhosis. The left side of the liver looks nicely dilated here. This is typically what you'll encounter, and often we can deal with these just by dilating the strictures and cleaning out the debris in the biliary tree. So what tools do we use? Very similar to esophageal dilation. We have passage dilators or straight dilators, savory dilators. We have balloons. And then we do use these stent retrievers that have like a rotary screw on the end of them to sometimes screw our way through these tight strictures to get to where we need to be. We use stents to keep the strictures open. There's a lot of advantages to plastic stents. They're effective, they're low cost. They can be removed and replaced if we don't like where they are. They're widely available, but they also have problems in that the size of the stent is limited to the operating channel of the scope, so nothing more than 4 millimeters. And then the stent occlusion occurs quickly with the plastic stents, sometimes because of biofilm. So we often have to change them out every 2 months or so. And there's a potential for side branch or cystic duct obstruction. This is just some pictures of different stents. They're really like straws with slits on them to hold them in place, or they have pigtails. Some of these are pancreatic stents that have side holes, or biliary stents that have bigger side holes. There's lots of discussion about which is the best stent. Honestly, they all work quite well, and you can always put multiple stents in if you want to have more than one drainage site for the patient. What's changed the practice over the last 2 decades has been these expandable metal stents, just like in coronary angioplasty. These stents go over a catheter, they expand. They have like a wire mesh that allows bile to drain through them. And now we have fully and partially covered stents that have like a saran wrap coating, so they can't get ingrowth of epithelial cells or tissue. You pass that stent into a strictured area in the biliary tree here, and let it expand after you release it, and it pushes everything out of the way, and you usually get pretty good flow. Because these are so big, 10 millimeters, 8 millimeters are the typical size we use. We tend not to see obstruction of these stents early. So often in our practice, we'll bring patients in who are going to go through a course of chemotherapy and put a metal stent in, so we know they're not going to get cholangitis and sepsis while they're immunocompromised. Larger diameter, longer patency, and the radial forces dilate the strictures. The disadvantage of them is the cost, not a factor for you or me, but in reality, it does increase healthcare costs all over. Uncovered stents can be removed, but it's quite difficult. So if they've been in for a while, it's a little technique change to take them out. And the epithelial hyperplasia is really the bile duct lining that grows into the stent, is often what obstructs these over 3 months or 6 months. And we'll have to put either a covered stent inside or replace the stent. And just a comparison of the 2 different types of stents we use. Honestly, I think all the stents work quite well, and we just are very careful about which one we select based on the patient anatomy and whether we're worried about things like migration or ingrowth. I talked a little bit about the role of MRCP for planning before you do these complicated strictures. I think it's really essential, and I think you can tell when you have a good MRCP because you should be able to see the biliary tree in total. You should be able to see where the strictures are and what you want to approach. You want to plan an approach for these patients with complicated strictures to decompress as much of the liver as you can. It's harder to decompress both sides of the liver at the same time with metal stents or even with any stents. If you can drain a component of the liver that's fairly large, in this case, the right side of the liver, you could easily drain that with 1 stent. You could probably drain the left side with 1 stent. Looks like there might be even more liver on the left side than the right. You see as the typical sign I was talking about, the bile duct's not dilated at all. That should be the first warning that there's something going on at the bifurcation. So we review these and decide how we're going to place the stents. 1 on the left, 1 on the right. Should we try to put 2 in? Then we go ahead and proceed. At the time of the ERCP, we're really careful, as I mentioned, not to put contrast out into the whole liver, because then you've got areas that you're going to have to drain, and you may not be able to get them all drained at one time. Often we'll collaborate with our radiology colleagues. If there's a segment that's completely cut off, they'll be able to image that with ultrasound, and they can put a percutaneous drain in an area that we can't get to. I use air cholangiograms and other techniques to really visualize what's going on. In the bifurcation, we put plastic stents in, but we can also put uncovered metal stents or covered metal stents, depending on what we're going to occlude. This is an example of just side-by-side uncovered metal stents going up into the liver, draining both sides. And occasionally, if we are kind of having difficulty getting 2 stents side by side, we can put a stent through 1 stent into the other side of the liver and drain them as well. So that's basically an overview of biliary obstruction 101 for everybody here, and it was really nice to talk to you today. I'll have time to answer questions during the question and answer period. Thank you for your attention.
All right, so I'll invite all of our discussants back up to the stage. So just as before, we welcome audience questions. We have a microphone up there, and I think Lindsay will go and grab it. So if you're out there and you have any questions, please feel free to raise your hand or stand up. We also, again, have audience response questions just to get the show started. So first question, while people are thinking of their own questions for the discussants, for which of the following should biopsies be obtained from the columnar-lined esophagus to assess for Barrett's esophagus?
All right, so this goes over when we discussed when should biopsies be obtained. And so we discussed that biopsies should be obtained from the columnar lined esophagus when it is greater than 1 centimeter or at least 1 centimeter in length. And so the pictures are a little small on the screen, but actually there's 2 correct responses here. You all did a great job in identifying one of them being C, but B also has a columnar lined esophagus greater than 1 centimeter in size. A represents a normal Z line, so I'm glad that no one picked A. And D represents an irregular Z line, so a columnar lined esophagus less than 1 centimeter in size. So I'm also glad that no one picked D.
Great. Next question. Seems like it's for Dr. Ahmed. Endoscopic submucosal dissection is a recommended first-line therapy for which of the following? Superficial lesion in the esophagus, 15 millimeter sessile polyp adjacent to the appendiceal orifice, a colorectal non-granular depressed lesion greater than 20 millimeters, or any lesion in the duodenum.
You all passed then. I think it's this is fantastic. Yes, I think to understand like what is non-granular and depressed lesion means and the risk of neoplasia is very important, and this is the right answer. Great job, everybody.
All right. True or false? Surgical resection of a large polyp with superficially invasive cancer is associated with lower mortality than an endoscopic attempt at resection.
This is again, I think if we like, you guys may think that this is just a given or that we all know it. Everybody should know it, but that's actually not there. Like it's still. As I showed in one of the slides, that many patients are still undergoing surgical resection of benign polyps in Denver and around and all over the place. So this is a knowledge that you have to spread. Great job, guys.
All right. And compared to plastic stents, self-expanding metallic stents, they have a shorter diameter, have a longer patency, are cheaper, or are more widely available.
Yep, I think you all got it.
Straightforward. And then which of the following imaging studies is recommended for planning purposes prior to endoscopic attempt at stenting a bifurcation tumor?
Again, I think that's perfect. You can get good visualization with CT scanning, so I don't want to frustrate you if you've done a really high quality CT and you can see that it's a Klatskin 2 or 3 tumor. By that, I mean at the bifurcation extending or up into the liver, but MRCP really gives you that detail of differentiating those Klatskin 2s from 3s from 4s. So I think that's why it's more useful.
All right. And what is the best next step? This is a case-based question, so I read it. 55-year-old female underwent a screening colonoscopy. She is found to have a 5-centimeter rectal polypoid lesion starting at the dentate line and involving 60% of the rectal circumference. Pathology shows a tubulovillous adenoma with focal high-grade dysplasia. What is the best next step?
Whoever is saying surgery has to come out here because I know who it is. but anyway, this is fantastic, guys. Again, it's really not the size. It's not really, most of the time, it's not the location. If we see a benign polyp, there's no invasive cancer on biopsies. This is definitely a case that should be reviewed for EMR or ESD. Great job. Except 2 people.
All right, another case, 78-year-old male with a past medical history of Hypertension, diabetes, underwent surveillance colonoscopy, found to have a 6 centimeter cecal-based sessile polypoid lesion in the cecum. Histopathology shows TVA. Focal high-grade dysplasia again. What is the best next step for this patient?
I wanted to bring this because it's still to date that we have patients who come and say, oh, this is because I have a polyp in the cecum, and this, is really a very complex place and should not be handled. But again, in the availability, if the expertise is available, any lesions in the colon should be, with no deeply invasive cancer, can be handled with endoscopic resection if the expertise is available, like we said. So cecum is okay. The size being large is okay. High-grade dysplasia is okay. So great job, everybody.
All right. That's all the prepared questions we have. And if there's none from the audience, I think that means everyone's eager to get to the next portion of today's session, which is the rooftop soiree, cocktails and everything like that. Before you all run up there, a few last minute housekeeping points. Just want to remind you to submit your tickets to Lindsay or Matt or Christy around here so you can claim the potential $100 prize. You have to be here for the end of the session at 3:30 and give them your cards by 2:45. We're going to resume at 2:45 sharp, where you can all get to come and watch Dr. Patel kick my butt in a debate about colorectal cancer screening. And then finally, again, want to great shout out and thank you to our talkers for this session, Dr. Edmunovitz, Dr. Pakala, and Dr. Ahmed. Thank you so much. We'll see you guys upstairs.
I want to sincerely thank you all for spending your Saturday with us. This group has done an amazing job of putting together a course for you. We've had great food, beautiful view of the mountains, and some beverages. So we're really, really pleased that you could join us. And we really do like to share the hospitality of this building because it is a fabulous gift to the university. We now have a little bit of time for a kind of a fun session. This is really designed more for an interaction with the group, and we hope that you'll feel very comfortable making your feelings known. We have two expert debaters here to talk about updates in colorectal cancer screening, and we have a specific format for the debate. I don't know if it's here or not, so let me see. What's that? Yeah. Okay, so Blake Jones, who you met before, the course director, is going to discuss the choosing a colon cancer screening test. Colonoscopy is better than the rest. And our own Swati Patel is going to take the con opinion that the best test is the test that gets done. So as you're thinking about this, I think it's fair to think about colon cancer screening, not just the results of an individual test, but as the process and how important it is. These are disclosures for the slide, for the talk today, the same ones as before. And here's the format. So we're going to, after my little introduction here, we're going to have the pro discussion, colonoscopy is better than the rest, by Blake. Then we're going to have a cross-examination question. And I've neglected to mention that we're going to do an audience poll for this debate. And we're going to do the poll 4 times. So you're going to do it at the very beginning. And the idea is to see whether the debaters have actually swayed the population's opinion of the poll. So the first time you're going to do the poll right after this, then we're going to have Blake, then we're going to do the cross-examination and questions from the audience. Then we're going to do the poll the second time, and then we're going to do the con, which is the best test is the one that gets done. Then we're going to have the cross-examination and questions and audience poll number 3. And then we'll have a little bit of time for them to go back and forth. And then we'll have an open forum. Fair enough? All right, let's go ahead. Can we initiate the poll? So what we'd like you to select, yes or no, colonoscopy is the best colorectal cancer screening test in the United States. Uh-oh. All right, I'm going to turn this over to Blake and let him just start the discussion.
All right. Well, it looks like I have a head start. Though I do have a head start, I had the advantage also as being a course director and therefore getting to choose my opponent. And so I asked Swati to do this, and she generously agreed. And then shortly after, she informed me that she was like the debate president in her high school and college and all these type of things. So I say that not to handicap myself, but mostly just you need to hold Swati to a much higher standard than me. All right. So in my portion of the debate, I'm going to make three main arguments. Number one, I'm going to show that colonoscopy works. Number two, I'm going to make the argument that not only does colonoscopy work, but it probably works better than we even realize, and especially with recent advancements, is only going to work better and better into the near future. And then finally, we'll talk about where stool-based screening falls short. So let's start with the circumstantial evidence, right? So these are time trend analyses showing the incidence and mortality rates of colorectal cancer over the last several decades. And we can thankfully see a pretty steady decline over those decades. But what we specifically notice is a sharp drop right around the year 2000, which coincidentally is when Medicare started covering colonoscopy for colorectal cancer screening. And then this other graph over here just shows the inverse relationship between the uptake of colonoscopy for screening and the decrease in the incidence of colorectal cancer over time. So circumstantial evidence, take for it what you will. To me, no, not altogether unconvincing. All right, but what about the other evidence? So we have large population case control studies, observational studies, including thousands of patients that show a benefit to colonoscopy for colorectal cancer screening. And that is it showed a big benefit. So up to a 3/4 to 80 to 90% reduction in incidence and 2/3 or greater reduction in colorectal cancer mortality. Now you'll probably say, observational studies, they're great. They're what we have right now for colonoscopy and colorectal cancer, but they're prone to bias. And I agree that the benefits of colonoscopy are probably exaggerated by these studies. So what about RCT data? Well, we don't have RCT data for colonoscopy, but we do have RCT data for flexible sigmoidoscopy. And I don't think it takes a genius to extrapolate the benefits of an exam that visualizes half the colon to an exam that visualizes the whole colon. And specifically, if you look at the data in flexible sigmoidoscopy, shows a 25% reduction in incidence and a third reduction in mortality with screening versus no screening. But if you isolate the benefit to just left-sided cancer, so the portion of the colon that flexible sigmoidoscopy is actually viewing, the benefit goes up to about a 50% reduction in incidence mortality. Therefore, if you extrapolate flex sig to colonoscopy, where you're looking at the whole colon, it's not unreasonable to assume maybe a 50% reduction in incidence mortality with colonoscopy. We don't have that data yet. All right. Now, some of you are probably saying, well, we do have RCT data for colonoscopy for screening for colorectal cancer, right? So end of last year, New England Journal of Medicine, this was all over the newspapers and the media, the Nordic trial. Very disappointing results in the benefit of colonoscopy for prevention against both incidence and mortality. Showed a very moderate reduction in incidence and no benefit in mortality for screening with colonoscopy for colorectal cancer. So, I mean, I'll leave it to all the editorials that were published, from all of our colleagues and experts in the field to try to I guess, rebut the main points that were made in the media, not necessarily in the article itself. But I do want to highlight a few things from this study. So first off, the study really was not assessing the benefits of screening colonoscopy for colorectal cancer incidence and death. It was assessing the benefits of an invitation to undergo colonoscopy for screening for colorectal cancer. Because only about 40%, slightly more, actually underwent colonoscopy within the intervention arm, the colonoscopy arm. In the United States, we know that we've achieved at least 60% and probably greater, closer to 70% of patients undergoing colonoscopy for screening, and it's higher in even some centers than that. So imagine we had a near 20% reduction in incidence of colonoscopy with just 40% of patients actually getting a colonoscopy. And if you did the per protocol analysis that looked at just patients who got the colonoscopy, there was a 30% or more reduction in incidence and a 50% reduction in mortality, which coincidentally aligns with what we see with flexible sigmoid, the data in flex sig. So furthermore, what else was wrong with this study? Well, it wasn't powered to detect a mortality difference. It takes a really long time for colon cancer to form. And this was a 10-year analysis of a study that was powered to truly detect a difference at 15 years. So it's not surprising that there was no difference at 10 years, because you can see that the rate of colon cancer in the usual care group was really small, 0.3. If you can extrapolate and predict what's going to happen with these time trends as you go out to 15 years, it's not hard to predict that the benefit of colonoscopy is going to increase and eventually become statistically significant. The degree, we don't know, and it depends obviously on the number of patients who actually undergo colonoscopy. And then finally, I'll make the point that this study demonstrates that colonoscopy is safe, right? There were 12,000 patients in the study who underwent a colonoscopy. There were 0 perforations, 0 deaths. There was a 0.13% rate of significant bleeding. All of that was managed endoscopically. So this study not only suggests, and like we will show later on, that colonoscopy is beneficial, but it also shows that colonoscopy is quite safe, one of the perceived limitations of an invasive test like colonoscopy. All right, so moving on. I'm not only going to make the argument that colonoscopy works, but I'm going to make the argument that it probably works better than we even realize. So this is a study out of Poland, so not United States cohort, but not coincidentally some of the same authors from the Nordic trial. They looked at the benefits of a one-time negative screening colonoscopy, so those are patients who don't have polyps or anything like that. But this is what they showed. So not only did they show, obviously, that these patients were low risk for colon cancer, there was a 72% reduction in incidence, 81% reduction in mortality related to colon cancer in the patients who had a negative screening colonoscopy. But in patients who underwent a high quality exam, so for them, high quality was cecal intubation, adequate prep, and an ADR of the provider performing the exam of greater than 20%, which is below the threshold that we've established in the United States, which is in of itself low. That benefit of that one negative screening colonoscopy lasted not just for 10 years, which is the interval we use in this country, but for over 17 years. That suggests that colonoscopy, even maybe once, has the ability, if it's negative, to protect you against colon cancer incidence and mortality for even 2 decades or more. All right, so I will admit that colonoscopy is not perfect. Post-colonoscopy colorectal cancers do occur. They are the vast minority of colorectal cancers that we see. And they're primarily due to the inadequacy of the exam. So either the cecal intubation was not, there was no cecal intubation, the prep was inadequate, or the provider just missed a lesion. So the good news is those are factors within our control, right? If patients, we didn't get cecal intubation, we can bring the patient back. If the prep wasn't good enough, we can bring the patient back. But the biggest problem with colonoscopy is the inter-provider variability. It's very operator dependent in terms of its ability to provide an impact and reduce colorectal cancer incidence and outcomes. And we see that because we know that the adenoma detection rate, which is the gold standard quality metric for screening colonoscopy, is inversely proportional to post-colonoscopy colorectal cancer. But there's wide variability in ADR among providers. But now I'd argue for the first time, with the advent of computer-aided diagnosis and AI technology, we have the ability to bring low-performing providers up so that we all are achieving a baseline level of performance that truly leads to added value for screening colonoscopy. Something we really haven't had. I mean, we've had, feedback, we've had remediation videos, things like that. But until now, we actually have a bedside tool that allows us to, and I think within the pre-market and post-market literature that we've seen, may not improve those who are already achieving really high ADRs, but can help bring low-performing providers up to a certain level, therefore improving the benefits of colonoscopy even further. And not only can AI improve the detection ability within the colonoscopy, but it has the ability to reduce the cost, right? Because not only do we have polyp recognition technology, but we have polyp discrimination technology, which one might reduce the resection of non-neoplastics and completely benign polyps, lowering potential complication rates, but also reduce the cost of a colonoscopy, because with this, you don't need pathology. All right. And now finally to the crux of the issue, relative to colonoscopy, where stool-based testing falls short. So this data is a little bit old, but within the last decade. So what's important about a good screening test? A good screening test should have a high sensitivity. You want a low false negative rate because you don't want a bunch of patients having a normal test who actually have the disease. So we can quibble over whether or not, what an adequate sensitivity is based on the cost and, relative invasiveness and risk of the procedure. But what we probably can't quibble about are the performance characteristics of FIT or other stool-based testing for not cancer, but advanced adenomas. Or in much of our clinical practice, they're treated the same as cancer in terms of family history and your perceived risk. And we can see here that across the board, stool-based testing performs pretty poorly. The best is for FIT DNA, which is Cologuard, and that's up to 40%. But if you notice here, that's with doing FIT DNA every year. And this explains probably why most of the literature and the studies that report the benefit of non-colonoscopy or stool-based testing show a very modest benefit in mortality, but show none or almost no benefit in colon cancer incidence. And that's, I think points to one of the unique opportunities of colonoscopy that really doesn't exist anywhere in cancer screening. And that's the ability to not only detect cancer at early stage where it's treatable and curable and reduce mortality, but to prevent cancer from ever forming through the resection of pre-neoplastic polyps. And that opportunity is limited with stool-based testing just because of the poor sensitivity of the tests to recognize those lesions. All right. And then furthermore, so I think the best argument against colonoscopy for screening, especially on the population health level, is that it doesn't get done. And to some extent, that's true. But this was a recent study, actually published last month, that looked at a trial of a facilitated screening for colorectal cancer across 3 diverse large health centers in the United States. And this is what they showed. So a lot of the studies that compare FIT or show the benefit of FIT in terms of getting people screened, look at these programmatic approaches where you mail FIT out. And yes, you do get more people screened. But the truth about FIT is that in other stool-based testing is that you have to do it year after year after year to get the same durability and benefit you get from colonoscopy. And what they showed was that in this facilitated screening program, at 4 years, less than 40% of patients had actually gotten 4 consecutive FITs. Whereas 83% of the patients had gotten just a colonoscopy within the first year of being enrolled in this trial. And to get comparable rates of screening completion success, they had to allow for significant crossover in the FOBT arm so that, a quarter of these patients actually underwent colonoscopy. Some of them had only gotten 2, with 1 or 3 stool tests. 6% of them almost didn't get a follow-up colonoscopy with a positive FIT. And even then, they didn't reach the rate of screening success that they had in the colonoscopy arm, where there were additional 5% or so of patients who ended up getting a colonoscopy in the subsequent 4 years. And then finally, I make the point that stool-based testing is a 2-step test, right? If you have a positive test, you need to get a colonoscopy to get the benefit from the screening. Because a negative test likely indicates for, within the confines of the limitations of the test characteristics that patient doesn't have colon cancer. To actually benefit patients who have positive tests and detect their cancers early or detect their pre-neoplastic lesions that you can remove before they become cancer, you need to get those patients in for colonoscopy. And in these, large scale health systems that try to deploy programmatic FIT-based screening programs, there's pretty clear evidence that it's really hard to do that. And up to 50% of patients don't get colonoscopy or don't get timely colonoscopy. So therefore, I leave you with answering the question, is it really worth the upfront effort of getting patients to do FIT so that you improve your screening metrics and you get more people screened when the people who then are identified to be high risk don't always get the actual care that they need, when this study shows that if you do the effort up front and get people to colonoscopy, they do seem to do it and therefore actually get the benefit of the screening that they're intended to get. That's all I have.
Thank you. Good to see you.
Before we start, we're going to take Blake's argument in consideration and repeat the poll. So if you could please select your choice again. Excellent. All right. Now it gives me great pleasure to introduce Swati Patel, probably the expert in colon cancer at our institution, coming to us today in her very delightful mode of talking about colon cancer screening.
All those graphs and tables and figures, anybody else get Ross Perot vibes? No, just me? It's not the ears. It's not the ears, really the figures. No. I do have my work cut out for me. What Dr. Jones didn't share is that I recognized that he designed the debate and I let him choose his position, and I knew I'd be coming in as the underdog. So thanks everyone for being here. It's a delight. Congratulations to the course directors. This is an outstanding conference, and I'm amazed that you all have stuck to it to hang out with us. And I brought my phone up here so that I can participate in voting, okay? All right. So before I start my presentation, I get the opportunity to ask Dr. Jones one question. Okay, this is kind of a cross-examination question, so make sure your mic is working. Dr. Jones, 45-year-old woman, marathoner, lives up in Boulder, vegan. She's coming to you for a second opinion because she heard you're an expert in colorectal cancer screening. Her doctor ordered a colonoscopy, and she doesn't have any family history of colon cancer. She has no symptoms, and she said she'll absolutely do it if she has to, but she really would prefer a less invasive test. What would you recommend to her?
Does she like collecting her poop at home every year, year after year for 10 years?
She's not available to answer that question. So
I'd tell her that she's likely to be low risk for colon cancer. In a country with the resources that we have in the United States, she has options. She could choose to get stool-based testing, Cologuard or FIT, or multi-target stool DNA, I should say, or FIT. Or she could choose a colonoscopy. The test characteristics of colonoscopy are better, but if you want to avoid an invasive procedure, then you could choose stool-based testing.
Okay. Well, that's a great answer. I think it's a good advice to our patient and sort of contextualizes the conversation we're going to have today. So I'm going to argue the position that, in fact, the best colorectal cancer screening test is the one that gets done. I'm not saying excluding colonoscopy. I'm saying overall, the best one is the one that actually patients will get done. These are my disclosures, which we've shared before, but I do actually have to also disclose that I'm a colonoscopist, and many of you have shared an endoscopy room with me and know that that's what I'm passionate about. But the reality is I stand by my position at this podium and even in the endo room today. So what I'm not going to do is tug on your allegiances of having scoped with me, our relationships that we've had over the years, to sway your vote. And in fact, we know it hasn't, right? Because the votes have already come in. Everyone in this room overwhelmingly favors colonoscopy. What I'm also not going to do is bore you with study after study after study that shows that non-colonoscopy screening modalities decrease death from colon cancer, decrease the number of cancers that our society deals with. What I am going to do is look at this very simple question that you have been given the responsibility to weigh and vote on. And that is that colonoscopy is the best colorectal cancer screening test in the United States. So let's break this down a little bit. What do we actually mean by screening tests? What are screening tests supposed to accomplish? Well, as Dr. Jones really nicely explained, we are in a very lucky position with colorectal cancer because we know that colon cancers can progress over time from normal tissue to precancerous polyp, early stage cancer to invasive distant disease. So we know that those that are diagnosed with colon cancer, even at early stages, it's a substantial burden to them. Not only the burdens of going through treatment, the side effects of chemotherapy, the surgical risks, the hospitalizations, the cost, but even if they survive that cancer, they oftentimes, over their lifetimes, deal with long-term side effects and problems and financial toxicity because of that diagnosis. And unfortunately, for cancers diagnosed at later stages, only about 13% actually survive that. So we are contending with a disease that is very common in our society and kills people. The beauty is that if we're able to find these cancers at early stages, at the precancer stages where somebody like Dr. Ahmed can remove a large polyp before it turns into cancer, or even at early stages where a patient needs surgery, we know that we can actually completely prevent the significant morbidity and mortality associated with colorectal cancer. So when we think about this question that you've been asked to vote on, the answer to this question, when you think about this, is not what's the best colonoscopy or what's the best colorectal cancer screening test for you or your spouse or your kid. It's what is the best colorectal cancer screening test for the United States. So with all of this, we really need to think about what is the modality that we can employ as a society to really confer the benefit of prevention and early detection in all citizens in the United States. Dr. Jones really waxed poetic on colonoscopy. And in fact, it's not news to this audience. Many of us are involved with colonoscopy during our day jobs. But when we think about colonoscopy, indeed, it is very effective when you look at it in a silo. It is the most common colorectal cancer screening test performed in the United States. Of all the colorectal cancer screening tests done, over 90% are actually colonoscopy in the US. In addition, he also told you, look, colonoscopy is far superior to stool-based tests, other modalities, because it can actually detect disease along the entire spectrum. Precancer polyp, early stage disease, all the way to invasive disease. He also showed you these beautiful test characteristics where colonoscopy, if a patient has cancer, it will detect the cancer in over 99% of cases. And even most impressive, it can prevent cancer by detection and removal of advanced colorectal polyps. So we know from his presentation, it's the most common colorectal cancer screening test performed in the United States. It can detect disease along the entire spectrum, and yet it's not working. Only 40% of colon cancers diagnosed in the US are actually diagnosed at early stages. So if this is our plan in the United States, we're not doing very well. So why is it that colonoscopy is not conferring the benefit that we were hoping for the United States of America? Well, when we think about colonoscopy, the really important point that Dr. Jones conceded is that it only works if it actually gets done. When we look at the state of Colorado, these are the individuals, the percentages across the country of folks that are up to date on colorectal cancer screening. And this is only 50-plus-year-olds. And for 50-plus-year-olds, we're at under 70%. It's even more depressing when we start to look at the data broken down by age. For 50 to 54-year-olds, less than 50% are up to date on colon cancer screening in America. There's even more concerning trends that we really have to be realistic and contend with. Many of us have encountered younger and younger patients being diagnosed with colon cancer, whether it's on our colonoscopy practices, our clinics, our friends, our family members that are succumbing to this disease at a much younger age than we would have expected. And though we don't have a lot of time to go into why this is happening, what's really scary is this phenomenon called a birth cohort effect. Essentially, what it means is that there's probably generational risk factors that are increasing risk. And as these generations, including myself, age, we're carrying these risks with us. Therefore, a 20-year-old that was born in the 1960s just actually has a significantly lower risk of getting colon cancer over their lifespan than a 20-year-old born in the 90s plus. So we see some concerning trends where in populations where we were starting to see positive trends because of screening, we're now seeing in 50 to 54-year-olds the rates going up over the recent years. Again, lots of different reasons for this, westernization of society, increase in risk factors like diabetes, obesity, perhaps other regional exposures, changes in our society, such as introduction of antibiotics in the food chain, industrialization of the food industry. Honestly, we could talk ad nauseum about what's actually causing this, but the bottom line is it's happening. And in response to this, our professional societies have decreased the age to start colorectal cancer screening from 50 to 45. The ACS, the American Cancer Society, was upfront in 2018 to make this recommendation. But essentially in 2021, every major professional organization came in line to recommend decreasing the age to start colorectal cancer screening at 45 instead of 50. Most importantly, the United States Preventive Services Task Force, which actually determines payer coverage. What does this actually mean for our practices? That means a bolus of 21 million adults between the ages of 45 and 49 that as of 2021 are immediately eligible for colorectal cancer screening. When we're thinking about things like colonoscopy, we really have to think about whether we actually have the bandwidth, the capacity to provide colonoscopy for all of these individuals. And as Dr. Jones said, if you live in Boulder and you have insurance, perhaps you do have the opportunity to choose colonoscopy as a test, but many Americans may not. Just in our system alone, that's 150,000 individuals in the UC Health system. Across the VA, curiously, we perform about 300,000 colonoscopies a year across the United States in the VA system. There's actually about just as many 45 to 49-year-olds in the VA system. So you can see how it's just not feasible to try to pretend we can offer colonoscopy to all of these individuals. So when we think about who's actually getting screening done and we factor in the 45 to 49-year-olds, that actually brings the state of Colorado down to 60%. And overall, 45 to 49 across the country is at about 20%. And unfortunately, the reality is that with all of these rates, we know that underrepresented minorities are much less likely to engage with and be adherent to colorectal cancer screening. And so we know there's disparities in access and disparities in outcomes because of this. So we know the rates are going up in young people. And because of this shared generational effect and the fact that all of us are sort of aging as we go, what's really scary is that 50 to 54-year-olds, the rate's going up. These are theoretically screen-eligible individuals. The rates should not be going up. Even scarier is in recent years for the older age groups where we thought we were really patting ourselves on the back. He showed you those incidence curves with colonoscopy going up, incidence going down. Those rates are actually flattening out over the last few years. And it's probably because our generation is aging and the consequences of going unscreened are much higher than they were before. So we really have to face the reality, okay? The reality is that a large proportion of our population is unscreened, and this disproportionately affects underrepresented minorities. And the consequences of going unscreened, of just rolling the dice and hoping you don't get colon cancer, is really a lot worse. Those odds are a lot worse now because of this birth cohort effect, these generational risk factors that are starting to accumulate as our millennial generation ages. So if colonoscopy isn't getting it done, what is the best colorectal cancer screening test? We know there's a bunch of different options. There's blood-based tests, there's stool-based tests, there's structural tests like colonoscopy, and we have all sorts of studies. And Dr. Jones showed you many of these studies that support the use of these variety of different tests, high-quality studies. And based on these studies, our professional organizations actually recommend a menu of options. And they recommend a shared decision between a patient and a medical provider to decide what the best option is. But the debate today is what's the best one for the US? I think when we think about the best one and sort of compare things side by side, Dr. Jones is right. If everyone gets a colonoscopy, the vast majority of colon cancers will be detected, and there will be probably a significant colorectal cancer prevention benefit from detection and removal of polyps. The problem is we can't just think in this silo because it's a great test if you get it done, but what about colonoscopy as a modality for our society? We have to think about the cost. We have to think about how many people are actually going to get it done. So when you look at the adherence rates, and we'll debate these a little bit, only 50 to 60% of the colorectal cancer, the population is actually getting colonoscopy. So if we think about the United States and we think about the sort of expected prevalence of colorectal cancer, and these red folks unfortunately have colorectal cancer. If we think about colonoscopy and just how it's being done, how it's available and accessible and paid for in our country today, if 50 to 60% of individuals get colonoscopy, great. Those individuals confer the benefit from colorectal cancer prevention. But unfortunately, that leaves about half of the cancer diagnoses undiagnosed and likely to progress to late stages before they're actually found. On the other hand, if we go with a test like fecal immunochemical testing, it does have less sensitivity for cancer. So it'll pick up about 8 or 9 out of the 10 colon cancers out there. But many more people in the population will actually get it done. And so it actually performs a little bit better. But with that said, neither test really inspire a great ton of confidence on their own if our goal is to prevent or detect every colon cancer at an early curable stage. There's still a lot of cancer diagnoses that are floating around. So the argument that I want to make is that really the best approach is do as our societies recommend, and that is offer our patients and set up systems where there's a menu of options. So perhaps in a society where we do offer colonoscopy, and then if a patient declines colonoscopy, they're mailed a fit exam, we get as many people screened as possible, we can do a much better job of detecting the colon cancers out there at early stages and curative stages. Still leaves some cancer undiagnosed out there. So Dr. Jones, I asked him to stay on the stage. So before he's like, oh, maybe we'll both go sit. I'm like, no, you have to stay on the stage because people need to see your facial expressions throughout this debate. But I can just see him chomping at the bit, sort of saying, I'm pretty skeptical. You're citing 80 to 90% adherence to stool tests. I showed you data that maybe that's the case on the first one they get, but we're talking about a test where a patient has to test their stool every year, and life races by us, right? And it's so hard to remember to do these things on an annual basis. 80 to 90%, that's way too ambitious. That's too generous of an adherence. Well, I think this is where we talk about where the field is going, okay? Historically, we've always thought of these structural tests like colonoscopy or CT colonography as being able to visualize the entire colon. Stool-based tests really designed to kind of detect cancers at a really early stage, maybe some really big precancer polyps that are shedding blood in the stool. And unfortunately, blood-based tests just haven't been a big part of the conversation because they really in the past have only detected really late-stage cancers where, as we talked about, that's not the point of cancer screening, right? We want to detect cancers early. But there's going to be a disruptive change in the field. It's coming such that there's now going to be the emergence of blood-based tests that actually have really good sensitivity for early stage cancer. So let me just show you a little bit of what I mean here. These are tests that not just take advantage of trying to pick up circulating tumor DNA in the blood, but they really take advantage of what we call multiomics, meaning a lot of the different things and changes that cancer causes in your body and sort of sheds into your blood, whether it's immunogenic cells, whether it's other, types of methylation markers. But essentially, there are now multiple assays out there, simple blood tests that are under investigation and will be imminently available that can detect cancer at early stages. This was a study that was presented at a National GI meeting a few years ago that showed over 88 to 98% sensitivity for stage 1 and stage 2 disease. That is highly impressive. This is a study showing kind of side-by-side test characteristics of a blood-based test against stool-based tests, against sort of older generation blood-based tests. And you see a specificity of 94% with this blood-based test. And so you can imagine that as these technologies are going to become available, and mark my word, it will likely be within the coming year that blood-based tests will be available for routine average risk colorectal cancer screening. We have to think about how this can fit into the model. In this study where patients declined colonoscopy, 63% of patients were like, I don't want that. Only 3% said they don't want any colorectal cancer screening. The rest of them were totally open to getting a non-invasive test. And out of those who wanted a non-invasive test, 15% actually did want to play with their poop. And 83% decided that they would prefer a blood test. So that's really, really informative and helpful as we think about these options and add blood-based screening to our menu of options. And you can just practically think about the adherence to a blood-based test. Imagine going to your primary care doctor, and as they talk to you about the lipid panel they need to check, your thyroid function, your diabetes screening, they say, oh, well, also we should, potentially do some colon cancer screening. What are you into? Okay, not into colonoscopy. How about this blood test? You can see how this could get operationalized into clinical medicine fairly easily. So if we think about this model, and if we accept Dr. Jones's argument that there's no way all these green folks are actually going to do stool-based testing every year, perhaps we bring blood-based markers into the mix and change things up a little bit. And there might still be those 15 to 20% that are really committed to playing with their stool. But if we were able to add another contingent, another contender into this, the common screening test that we use, that could really go a far ways in finding all the colon cancers in our country at early and curable stages. So really, when we talk about the specific goal of colorectal cancer screening in the United States and the question that you've been asked to answer, and that is colonoscopy the best colorectal cancer screening test in the United States? I think the overwhelming answer has to be no, because the reality is, sure, it might be for you, but for the United States, the best test is the test that gets done. So with that, I'll give you the opportunity to vote. Put my vote in too.
So first of all, I tried to delete my Facebook like 40 times, but I was never able to for this exact reason. And I guess I have Mark Zuckerberg to thank for that. So I guess, my cross-examination question for you, Dr. Patel. In a system where, well, first of all, I guess I have two cross-examinations, which I know is cheating a little bit, but I didn't realize that our Facebook profiles were within the bounds of this. So I think I deserve to.
Gotta take the gloves off. Gloves off.
How many procedures do you feel like you do on a daily basis that aren't truly indicated, especially given the change in guidelines that have expanded our surveillance recommendations? And what do you think in the future will happen to those surveillance guidelines as we get more and more data on the protective benefit of polypectomy and colonoscopy in general?
Yeah, that's a great question. I think many of us can attest to the patients that show up that didn't need a colonoscopy. So you're absolutely right. There's capacity that we should ideally be able to open up, right? The patient at the VA who just had a colonoscopy at Kaiser 2 years ago and tells us that, but it just wasn't in the VA system. So the PCP ordered the colonoscopy. They're prepped. They're there. We oftentimes do it. Or, for the different studies that we're doing in kind of expanding surveillance intervals, perhaps the patients with those 1 to 2 tiny polyps, do they really need to come back in 5 to 7 years? You showed that high quality colonoscopy is protective for a very long time. You're right. I think we can continue to do better to open up capacity. But, I think that should be in addition to getting everyone screened, because the reality is all these 2-step tests, if we get every person in the United States a test, whether it's a colonoscopy or 2 steps up, that's not doing nothing for our volume and our jobs. We will continue to do colonoscopy. More and more of them will just be a follow-up of a 2-step test or a surveillance of a high-risk lesion, where we're not doing screening colonoscopy on average healthy young folks unless there's something that increases their risk.
All right. So I guess I have the rebuttal here. I'm going to cheat and phone a friend. First friend I'm going to phone is Michael Berghalter, who was the lead author on the Nordic trial. And coincidentally, I was listening to a podcast earlier this week in which he was interviewed. And guess what colorectal cancer screening test he chose for himself?
This is Michael Berghalter.
Yeah.
Knowing him, I suspect he would have chosen a FIT test, but maybe I'm wrong.
No, he chose colonoscopy.
Colonoscopy. Okay.
And, we've almost made it through an entire medical conference, and no one has brought up ChatGPT yet. So I thought, as part of my rebuttal, I would ask ChatGPT what the best colorectal cancer screening test is in the United States. And I actually already did this, and it said colonoscopy. But all jokes aside, I agree that we need to offer a menu for our patients, but we need to be honest when we offer that menu, and we need to delve into the test characteristics of the tests that we're offering them. And if you tell your patients that there's a 15 to 20% risk that their screening test is going to miss a cancer, more of them might start to choose a test that's much, much better. And I'm not sure we're all doing that. The other point I would make is that in a system where we are, steering patients towards any screening test, what inevitably is going to happen is that patients, like you mentioned, who are more vulnerable and perhaps more likely to be high risk for colorectal cancer are going to be more likely to be offered stool-based testing, the inferior test, and we're going to just expound on existing inequalities within our healthcare system. So yes, it's better to get people screened than for them not to be screened. But I think you can't argue that colonoscopy is the best test. I think you can't argue that we have more capacity than we currently have. And I also think if we see what happens when we get more and more data, we're going to realize that colonoscopy is more protective than we even realized. We're going to have the opportunity to perhaps do what they do in Poland, which is do one lifetime screening colonoscopy and say that is incredibly protective for up to 2 decades if you have no polyps. And if you have a few polyps, your risk is probably no greater than if you have no polyps. And I think there's other data that shows that we don't really define advanced adenomas well, and we're probably way too conservative. And so we're probably bringing people way back and way overusing colonoscopy. But I think that the point remains that if we're giving patients a menu of options, we have to be honest about the test characteristics. Colonoscopy is always going to be the best test. If they don't want it, that's fine. But then you have to be willing to guide them to colonoscopy if their other screening test is positive. And so if they're not doing a colonoscopy up front for whatever reason, that already suggests that it's going to be hard to then convince them to do the colonoscopy, even if they have a positive test. And that is, I think, supported by, the literature where we use FIT in patients because they don't want to get a colonoscopy. They're more likely to be, Hispanic, underserved, minoritized patients. And then we have a really hard time getting to colonoscopy when they have a positive FIT. And that's just because, we don't put in the effort up front to build the infrastructure necessarily to get them to colonoscopy. And if we're going to do that effort anyways, we should really be offering those patients colonoscopy, I think, in the first place. If they don't want it, that's fine.
Swati?
I actually don't refute anything that you say about the value of colonoscopy. It's amazing, right? When we see that advanced adenoma, we lop it off. We know that that patient's walking away with a cancer prevented. So again, when we vote, it's important to vote on the question that's being asked. It's not, is colonoscopy a good test? Is colonoscopy the test that you're going to do when you turn 45 or that you're going to recommend to your friends, family members, or even your patients? The question is, what's the best approach, the best test for the United States? And we can either take the approach of sticking our heads in the sand, crossing our fingers that colonoscopy capacity, physician behavior of overdoing colonoscopy in certain populations will just get better. And it'll open up all this colonoscopy capacity, and we will try to be able to deploy that in a systematic fashion to our entire population. Or for the ones who are willing to come to colonoscopy, keep those doors wide open. But for all those people where a colonoscopy is ordered, they don't show up. Another colonoscopy is ordered, they don't show up. A third colonoscopy is ordered, they don't show up. There are many out there that really are just getting no screening whatsoever. And I agree with you. The resources to get those positive screens navigated to a colonoscopy need to be dedicated to completing the process of screening with the finishing colonoscopy. But the reality is that vast majority of those folks are just not getting anything at all. Some of it might be because they have a preference for a non-invasive procedure and may not complete colonoscopy, but the vast majority are because they just really haven't thought about it or haven't been offered it or haven't advocated for themselves. So I think we need to think about a programmatic approach to colorectal cancer screening and a sequential approach, meaning perhaps you're offered a colonoscopy, but if the colonoscopy is not completed, for instance, in the Kaiser system, they just mail folks a stool-based test. And that really is the safety net to capture everyone. And as we have more and more easier two-step tests that will be emerging over the coming years, this is the model that we have to think. So I think that, colonoscopy is a phenomenal test. I will never argue against that. That's what I do in my clinical work. But the reality is you've been asked to vote on whether colonoscopy is the end all be all for colorectal cancer screening in the United States. And for that, I hope I've convinced you that we need to think broader, that it's any test, including colonoscopy, especially for the folks that are just never going to get anything otherwise.
Can we have the audience ask questions? I'm going to bring the mic back, and if you could help me, Lindsay.
So I absolutely see both vantage points. I would say that the question is lacking in that it should be, are colonoscopies the best test for colorectal screening today? Because the flaw in Dr. Patel's logic is blood tests are not available at the moment. And as somebody who tried to screen per poop sample in the male, at age 50, it got lost and it never reached where it was supposed to go. So the only real way I was screened for colorectal cancer was when I had my colonoscopy at university and then got a job there. So in that way, I think today, though both of your arguments are excellent, at this moment in time, colonoscopy is kind of the best test for it due to the human factor of mailing in the tests and the inavailability of blood tests at this moment. Or do you have an inside track that I am unaware of, Dr. Patel?
No, I was just going to tell you that the check that Dr. Jones has for you, you can pick up on your way out. No, yeah, he's going to just swirl around and find your name. I acknowledge, these two-step tests are challenging to not only complete the test, to follow all the instructions, send it in before it's an expired sample. And then, you didn't really even talk about sort of the challenges that patients have in navigating to a timely colonoscopy after that test. And then you got to do it all next year. I acknowledge it's challenging. And if colonoscopy is accessible and available to you, go get it. Go get it. There are the folks who don't even know conferences like this exist. And for that population of folks that just has much more going on, I think we do have to at least try to get some type of screening test done for them.
So I have a question. Is there any data on how many people develop colon cancer from after colonoscopy versus after other modalities?
Well, there's data on kind of what percentages of cancer are within a screening program and what with our, and we know that, there's interval colorectal cancer, which is just any cancer that's not within the recommended surveillance interval. There's post-colonoscopy colorectal cancer, and probably about 10%-ish is the data I've seen. Roddy, you can disagree with me, but that of cancers, of colon cancer are fit within those frameworks. So it's a significant minority. I'm actually not aware of data that, we know the test characteristics of stool-based testing don't perform as well. So it's, you're more likely to miss a cancer with stool-based testing. I don't know of data that specifically says the proportion of cancers that are diagnosed in people who've only done FIT-based screening or multi-target stool DNA.
So the stool-based tests, and again, this goes back to what the point of screening tests are in our country, right? They're to decrease death from the disease and ideally decrease cost burden long-term. So with that in mind, things like mammograms are designed to detect cancers at early stages where patients can get surgical resection and then go on to live a long, healthy life. So colorectal cancer is unique because not only can we do that, right? A stage 1 cancer, surgical resection, that patient has a 95+% chance of never having to deal with cancer-related problems of their colon again. But with colorectal cancer, we know that we can find these polyps, and there's this sort of concept of trying to potentially prevent disease, which is reasonable. I think, for your question of, what's the detection rates, for colonoscopy versus a stool-based test, up front, we will admit to you that if you have 10 patients with colon cancer and you administer a stool-based test today, you will pick up 8 to 9 out of those. And one cancer patient sitting right in front of you, the stool-based test won't pick up. With colonoscopy, that's very, very unlikely. Now, as we all know, as everyone who's been in a procedure room, colonoscopy is a very operator dependent test, bowel prep dependent test. And when we look back, as Dr. Jones said, of all colon cancers, about 10% have had theoretically a colonoscopy within the last few years. So there's lots of different reasons for that. We don't have to, argue or debate that. I think both Dr. Jones and I can agree that a colonoscopy should only be done if it's done by a high quality, high adenoma detecting endoscopist, good bowel prep, complete to cecum. I think those things aren't necessarily under debate, but they're just designed to detect different things. And so I don't think stool-based testing is really even promoted as a cancer prevention test necessarily, but it's to prevent those deaths across the country that are happening from people showing up with stage 3, stage 4 disease because they only come when they have symptoms.
Swati, just briefly, I know you have obviously been a big part of writing some of these guidelines and talking with experts around the country and the world for that matter. You were at the White House earlier this year and talking about colorectal cancer screening. So could you comment just briefly on how reflective the conversation that you and Blake had today, how much that reflects the conversation that happens when guidelines are written? And as a second part to that question, when the guidelines are written, how is the topic of bias approached? We may be biased towards colonoscopy because that's what we've been trained in. So if you don't mind commenting on that.
Yeah. And I think this is really, really important because somehow, when we go through our training and we think about guidelines, we think of them as sort of these, very altruistic, unbiased sort of sources of information to guide our clinical practice. But each guideline body, comes from their kind of vantage point and has the societies that they represent and the stakeholders that they have. So, for instance, the Multi-Society Task Force is representative of the American Gastroenterological Association, the American Society for Gastrointestinal Endoscopy, and the American College of Gastroenterology, right? So all GI organizations. And interestingly, when we wrote the colon cancer screening guidelines, deviating from every other group, the MSTF recommends a tiered approach to colorectal cancer screening, where tier 1 tests are colonoscopy and FIT-based testing. And then tier 2 is things like CT colonography, FIT fecal DNA, et cetera. But when we look at test characteristics, we even look at sort of the studies available, there's really not a ton to justify that tiered recommendation. There's certainly very strong evidence for FOBT, but to put things that have data also, certainly similar to colonoscopy data in the tier 2 group, it's sort of begs to question, why was that done? And so I think that's where the GI societies come from their own perspective, right? We're all colonoscopists, so that's certainly part of it. But the other part of it was that the MSTF really felt strongly to give clinicians something practically useful, some practical guidelines, like, look, offer your patients colonoscopy or FIT, and if they turn that down, and if you work in a place that does good quality CT colonography, that's a consideration. And then finally, if they can't get through all those things, you could do a capsule colonoscopy. They all look at the same data. So on the other hand, organizations like the National Comprehensive Cancer Network, that represents National Cancer Institute designated centers across the country, sort of a more oncology bent to it, really just says we should offer a menu of screening options and doesn't really put things in tiers. So Avash, there certainly is, the vantage point that some of these guideline bodies come at some of these questions. And I think that's something that we have to consider in this room too, right? Because this is a GI conference. All of us in some way have a connection to GI, and our bias, including mine, is towards colonoscopy. But for folks around the country and certainly internationally, there is a lot more perspective on population-based approach to screening and just trying to get a screening test done in everyone. If colonoscopy is part of it, great, but there are many other tests that we also recommend.
All right, perfect. Well, we're out of time. Any of you that want to spend the rest of the day and tomorrow talking about colon cancer screening, Dr. Patel will be here, and I'm sure she'd be very happy to let you know her opinion about it. We need to vote one last time on our question. So could I have it up? Excellent. I proclaim the debate a tie. We can all go have a drink. We have a couple of announcements from our course directors for you all. Thank you very much.
All right. Yeah.
Oh, yeah, we'll do that. All right. So this just a few quick closing remarks. We're almost done. First thing, we want to thank all our speakers so much. Obviously, this would not be possible without you, Dr. Ahmed, Dr. Gumidyala, Dr. Whelan, Dr. Ahmed, Dr. Edmundovitz, Dr. Patel, Dr. Reddy, Dr. Rice, Dr. Pakala, and Andi Dwyer. Thank you so much.
Never too early to start looking ahead, but a year, the 11th Rocky Mountain Highlights Conference will be approximately a year from now. So look forward to that. But we're hoping for free conference registration again. And of course, thanks for being involved this year.
And then these are just a few more conferences that we have coming up within the division and sections. So this is another save the date. Actually, I should probably let Dr. Kalra talk about this one because it's his conference.
So this is an ongoing webinar series on topics related to the chronic liver disease and liver transplantation management. So we'll be doing 4 or 5 webinars per year. This is also free CME and nursing contact hours as well. So our next talk is August 23rd. My colleague Whitney Jackson will be talking about the role of living donor liver transplant. You can see there's going to be one in September, one in November as well. And then we'll have a whole new set of webinars for next year as well. I will also mention that the videos for all these webinars are recorded and saved on the website as well.
And yeah, another save the date, the 18th Rocky Mountain Interventional Endoscopy course will be next April. Friday and Saturday, free registration again. And we often have international attendees, which is always excited. A lot more live endoscopy than we have in this course. And then one last time, we want to thank all our supporters. So Olympus, Castle Biosciences, Exelixis, Takeda Pharmaceutical, Tibio, Cook Medical, Janssen, Takeda Pharmaceutical Company, Gatex, AbbVie, Inc., Hepan Pharmacology, Irby, Fujifilm, Microtech Endoscopy, Medtronic, Ovesco Endoscopy, AbbVie Digestive, Bristol Myers Squibb, Gilead, Intercept, Olympus, Sanofi, and Steris.
We'll be sending out feedback forms, and really don't hesitate to give us feedback before you leave today. In addition to filling out the feedback form, we used the feedback form from last year to make some adjustments to this year, and we hope to do the same for next year's conference. Now what you've been waiting for. Yep.
So looks like odds are pretty good. Get 10 people win.
Yep.
Me to do it?
Sure.
All right, we're doing this Price is Right style, so y'all got to come on down. Danny Cooper. I swear I mixed these up. I am not doing the VA thing again. Mabel Martinez. Yeah. You go to her. I'm going slow. I got it. You want to pick one up? I don't get it. You should unpress her ID again.
Kelly Hosey.
Yeah.
Karen Greenberg.
Yeah, we are. Run, Matthew. Janet Hank. Hold on, how many is that? 1, 2, 3, 4, 5. We still got 5 to go. Yeah.
Mike Molman. Yeah.
Sarah Christmas.
How many of that?
Rebecca Bontwana.
I don't know if I got that right. Bontawa. Yeah. I butchered that. I'm sorry. Thank you for being here. 3, 4, 5, 7, 8, 9, and 1.
Reddy Martinez.
Uh-oh.
Not here, so it doesn't count.
Doesn't count.
No.
Don't tell Eddie.
Don Coleman. Yay, Don.
All right, your last one. Oh.
The 10th and final gift card goes to Megan Farley.
Yay, Megan!
It's 10, right?
4, 5, 6, 7, 8, 9, 10 more.
Okay, thanks. So congrats to the winners. Blake and I also want to take a moment to acknowledge and thank the course organizers once again. So Matthew, Lindsay, and Christy, if you don't mind coming up here as well so that everybody can see you. They have their initials. We got you guys a gift bag as well for each of you. Lindsay's. Yes, of course. Of course. And yeah. Yeah, and all we really could not have done this conference without the three of you. You guys made our jobs extremely easy over the last year, and we're deeply appreciative. So thank you.
All right, and just a reminder, so you get credit for being here. These are the ways to get it. There's a link on the website for the conference. There's a QR code to check in, and then we do have the course survey and everything like that. You can always contact Lindsay if you need any help with anything.
So this is just a repeat of some of the slides from earlier. 5.75 AMA credits. All of this information is available on the website as well, including the ABM maintenance of certification points.
Yeah, one final disclosure list. Please don't forget to fill out the survey. We always like to hear feedback for next year. And then again, just more information about getting credit. Do everything before August 13th. Or 14th. All right. More disclosures. Here's that QR code for nurses. It's at the front desk too, in case if you didn't get it. We can just leave this slide up here because it's the last one. But thank you guys so much for coming. It's a great conference. All thanks to you guys being here. Thanks to our speakers and thanks to Lindsay, Christy, and Matt.
Thanks, guys.